on the weekend their lives. We may ask all this in Jesus' name.
And thank you very much. We can start with you, Clara. The next session, we are going into a brief introduction of ourselves. So we can start with your table, then we go with our order from the right.
Morning once again. My name is Clara Tieno Odhiambo. I am a surgical oncologist and I work in Zambia Hospital. Really excited to be here.
You're welcome.
Good morning, everyone. Dr. John Isiko. I'm a clinical oncology pharmacist working with Uganda Cancer Institute, Mbarara Regional Cancer Center. I'm glad to be part of this inaugural launch today. Thank you.
Good morning, everyone. Juma Fauz Kavma, serve at C-Care as the Director of Medical. Pleasure to be here. Thank you.
Have the mic move slowly as we introduce ourselves. We would like to welcome all of you. Capacity.
Good morning. I'm glad to be here. My name is Susan Angura. I'm a product specialist, Oncopharm Specialty Pharmacy. Good morning, everyone. It's Jennifer Zung. I work for Joint Clinical Research Center. I'm the program director for Global Hope Partnerships in Uganda. Thank you.
Good morning, everyone. Deo Gracias Munube. I work as a pediatric hematologist oncologist in Mulago National Referral Hospital. Thank you.
Dr. This meeting.
Morning, ladies and gentlemen. My name is Helen Opolot, International Sante.
Good morning, everyone. My name is Haider Khan, and I represent Metropolis Labs.
Thanks for hearing the invite and thank you for part of this.
Good morning, everyone. My name is Ravi. We are from Petro Labs. Thank you.
Good morning, all. My name is John Namushiri. I'm coming from Aga Khan University Hospital, Nairobi.
Good morning, everyone. My name is Innocent Twebazi, Principal Technician from the University.
At least from the first introductions, we can all see we are having a diverse group in this room. Thank you.
Good morning, everyone. My name is
Yes, good. Eddie Francis, surgical oncologist.
Let's have this.
Morning, everyone. My name is Mawazo David Wambale. I'm the country manager for AstraZeneca. I'm very privileged to be part of this inaugural ceremony for launching HOSU. As AstraZeneca, we've been long-term partners, and the Cancer Institute is almost synonymous. So we are glad to be part of this.
Morning, everyone. David Chadono is my name. I come from Health and Development Center, but also I'm the chairperson of the Institute Research Ethics Committee. Okay.
Good morning, everyone. My name is Kavuma Awusi. I'm
medical physicist, radiotherapy department, Uganda Cancer Institute. I'm glad to be part.
Name is Awere Karim, Uganda.
Morning, everyone. My name is Benjamin, member of the association, work with Metropolis Healthcare.
Let's keep the going.
Good morning, everyone. My name is Christine Sekaja. I am a hematologist from Mulago Hospital.
Morning, ladies and gentlemen. My name is Henry Dungu from the Uganda Cancer Institute.
For being part of the society.
Morning, my name is Sarah Komjuni from the Radiation Oncology Department, Uganda.
My name is Harriet Kevin, palliative care nurse, the institute.
Everyone, Sir Christine, palliative care clinic, such an
Morning, everyone. My name is Joy Kiriat.
To you all. I work with the Palliative Care Association of you.
Morning, everyone. I'm blessed to be here. My name is Dr. Mena. I'm the head of medical oncology at the Aga Khan University Hospital.
I think part of this.
Good morning, everyone. I'm Dr. Shomhanj Agnes. I'm a radiologist at
Good morning, everyone. My name is Joyce Balagade Kambugu. I'm a pediatric oncologist at UCI.
Good morning to you all. My name is Sisi Nasolo. I work with Uganda Cancer Institute in the Uganda National Cancer Program.
Good morning, everyone. I'm Rachel Nalunkuma. I'm a medical doctor at Mengo Hospital. Thank you.
You're all welcome.
Good morning, everyone. My name is Francis Sadi. I'm based at the Joint Clinical Research Center. I'm a hematologist.
Hello, everyone. Rosemary Byanyima is my name from Mulago National Referral Hospital.
Thank you for honoring our invite and thank you for being part of this society.
A very good morning to all of you. Jackson Orem from Uganda Cancer Institute.
Okay, thank you all, our distinguished guests and members of this society for coming, for being part of this major timeline in the entire history of Uganda. We will all remember this, the society will remember this, and our theme today is a new chapter for hematology and oncology in Uganda. I'd like to invite our chair, the organizing committee, Dr. Nixon Niyonzima, to give us the opening remarks.
Thank you, Veronica. As many of you will see, we have anthems on the program, but we plan to have the anthems when the minister comes to do the official launch. So it's not an oversight, but it's planning that when the minister comes, we sing the anthems. Like Veronica said, my name is Nixon Yonzima. I work with the Uganda Cancer Institute. And I'm exceedingly happy to welcome all of you today to our inaugural symposium as the Hematology and Oncology Society of Uganda. And this is a new organization. The Hematology and Oncology Society of Uganda is a new association. And when we started this journey, when we started this work, we did not know how it would end up. We did not know that we would have this symposium, it would be successful. As a new organization, you think about funds, where you can get the funds to host a symposium, are you going to get people interested? And what I would like to tell you is that we have a lot of interest in the Hematology and Oncology Society of Uganda. And our vision is actually to have an annual Congress of Hematology and Oncology in Uganda that brings together cancer scientists, cancer researchers, cancer and hematology advocates, basically everybody who is in the space. Our dream is to have ASH, ASCO type of congresses in Uganda, targeting Uganda, but also targeting the region. So it has not been easy to organize this, again, because it's a new association, but we've had a fantastic team of people who have done this organization, and I want them to stand up for recognition. Dr. Dungu, who has been our interim chair, so he has been our interim chair of Hematology and Oncology Society of Uganda. Dr. Dungu, some people don't know you, so would like you to stand up so we can see you. And he has passion for hematology and oncology, and he has driven us to where we are today. Dr. Kakungulu and Dr. Valeria, I don't know where they are. Valeria and Kakungulu, Valeria is over there. Please come for recognition. Valeria and Dr. Kakungulu have been immensely helpful in organizing this symposium today. They are the two who are standing in the back, and we wouldn't be here today. All the beauty you see here today, and I'm told Valeria has some surprises later in the day, but all the beauty you see here today is because of Edward and Valeria. I also have Dr. Kuku, who is not yet here, Dr. Mwesige Benjamin, Sister Rita Bafumba. Sister Rita, I saw you around. I don't know where you are. We have Dr. Balagade, Joyce. I also saw her here today. And of course, we have also had incredible support from many of our elders here today. Dr. M has been very supportive of this. Dr. Byanyima from Lago Hospital has also been incredibly supportive. And of course, for us coming from hematology and cancer, Professor Wen is also here, as you will see today, who has supported us immensely. So I hope you find this day exciting. This is a new chapter, like Veronica has said, for hematology and oncology in Uganda. Many of you will appreciate that for many years, hematology and oncology were synonymous with Uganda Cancer Institute. But as time has gone on, there are now many hospitals, many associations that are involved in this space of hematology and oncology. And we want to have this association of Hematology and Oncology Society of Uganda bring all these people together so that we can advance hematology and oncology care, research and training in the country. I'm sure later you'll appreciate what Dr. Dung will be presenting, the vision and mission of this society. But what we want really is to have a global brand that unites all hematology and oncology practitioners, advocates, patients in Uganda so that we achieve our common goal of ensuring that there is no death from cancer, no death from blood diseases. So allow me to, as I end, to also inform you about the 5th Uganda Conference on Cancer and Palliative Care. I hope the DJs can flash it up on the screen. So we have a biannual conference on cancer and palliative care, which has formerly been a partnership between the Uganda Cancer Institute and Palliative Care Association of Uganda. And we are hoping that Hematology and Oncology Society of Uganda will also be part of this. The conference is 10th, 11th, and 12th of September 2025. We hold it every 2 years, and we are still inviting you to participate. We want also this to be a regional cancer palliative care and hematology congress in the country. Of course, I cannot finish without thanking many of the people that have supported us put together this congress. We have a number of sponsors, AstraZeneca, who have introduced themselves, Adonis, we have OncoFarm, we have Hetero, we have Metropolis Labs, we have Ministry of Health, we have MSN, we have Mulago Hospital, Uganda Cancer Institute, and Zambia, as well as just our incredible partners in putting together this. So I'd like to end by wishing you wonderful deliberations today. And I hope for you, as it is for us, this is the beginning of a big new chapter. Thank you very much.
Thank you, Dr. Nixon, for these wonderful opening remarks. I'd like to invite Dr. Dunguri, the chair, to take us through the overview of the association, mission, vision, and the objectives. You're welcome, Dr. Dung. The ITT kindly our present.
Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. What a day. This day, I can't believe it's here. And I'm so glad we are all here. I'm so glad our dream is coming true of having a society of all professionals in the areas of hematology and oncology. Welcome once again. Today, as we said, we are talking about, oh, what have I done? Which one is the first one? We are starting from there. It's the launch and symposium of the Hematology and Oncology Society of Uganda. And indeed, it's a new chapter for hematology, oncology. Our vision is that no one should die from cancer, blood diseases. And the mission is to control cancer and blood diseases through research, education, care. And of course, we can break down all those into other ways of expanding them. This we can do through discovery, which is research and innovation. And when we do research and innovation, we are able to prevent diseases, and then we are also able to cure them. We no longer talk about cancer as an incurable disease, but as a disease that can potentially be cured, especially if we implement these ideas: research, prevention, and then cure. The objectives of the society are many, but we can think about promoting evidence-based practice and scientific advancements of hematology and oncology in Uganda, explore and implement strategies to promote the quality and accessibility of hematology and oncology services in Uganda, and promote education, training, and in this same area for all cadres ensuring quality, comprehensiveness, and equity. And also to promote cutting-edge research in this area, promote quality assurance in care, training, research, and service delivery, and represent, promote, and defend the rights of members of the society in Uganda, as well as synthesize, disseminate, and evaluate the impact of information of interest, the development of hematology and oncology country. Our membership is broad. You know, before coming here, I was speaking to my colleagues, and they're like, you're supposed to be a member of this society. We are all experts in this field, and we are members. These are just examples. Hematologists for both classical and malignant hematology. And oncologists. Here we talk about medical oncologists, surgical oncologists, gynecological oncologists, radiation oncologists for pediatric. Pediatric oncology, how come pediatric is not typed there? Because Joyce is there. But pediatric oncologists, there and so many others. We cannot do any of these without people like Dr. Nyakato, the pathologist. So pathology plays a huge role in our membership. Then we have people who are involved in the practice of hematology and oncology. Without them, you cannot do anything. We have our specialized oncology nurses. We have our palliative care nurses. We have, and here palliative care is a big thing. That's why I said, if I've written your name and it's not there, just know you're the most important. So oncology nurses, social workers, those in genetics, those who are doing counseling, the pharmacists, and here we're talking about especially the clinical oncology pharmacists, and then others with interest. Medical physics. You know, you cannot do radiation oncology without medical physics, without the radiation therapists, technologists and technicians. We have oncology imaging. Our radiologists are different from the general radiologists because they pay attention to a number of details. So all of you are members and potential members of the society. So if you think I did list your name here, as I said, you are the most important. And just know that you are part of this. We are legal. We are not here illegally, okay? We are incorporated. We have a certificate of incorporation as a fully registered society in this country. And Ms. Ogwal Stella signed that I certify that Hematology and Oncology Society of Uganda, HOSU. You know, when you hear about HOSU, this is the short form of the society. And we are limited by guarantee without share capital as member. And we are compliant with regulations. As you can see, we are duly registered with the Uganda Revenue Authority, and we have a trading license. Not that we are traders, but we are not supposed to practice without these regulatory compliance requirements. We have a TIN certificate. I think you can see it. When you're going to send us money, make sure that you use our tax identification numbers because we pledge to be compliant with regulations. Make sure that everything is okay. You know, yesterday we almost had a challenge, but I'll not tell you this. Sorry, I've told you. We almost had a challenge with our bankers because they're like, who are these people and how come there's money on their account? Of course, the money was very small. They said, how can you survive with such small amounts? So we still call upon donors to get us some money. Ladies and gentlemen, allow me to thank you all for being great. This is a special appreciation to all of you who have come in for the launch of the symposium. We have our platinum sponsors. I don't know if they're here. AstraZeneca, or Dr. Wambale. Thank you so much for being part of this. And indeed, they encouraged us to come up and set up the society. Adonis, I don't know if they're here. Adonis, are they here? Okay. Oncofarm. Oncofarm has come to support us. I don't know if they're here. Oh, thank you so much for being part of this. Hetero Uganda, they have also helped us, as well as the Aga Khan. I saw someone from Aga Khan. Oh, so nice to see you. And then Metropolis Laboratories. They have also supported us. Mulago National Specialized Hospital, Uganda Cancer Institute, Makerere University, MSN, and the Joint Clinical Research Center, Zambia Hospital, they have all supported us. But above all, you all who have contributed to become members have supported the official launch of the society. And please clap for yourselves. It's better to clap. Okay. So now that you have clapped, from now on we say it is HOSU. HOSU, standing for the Hematology and Oncology Society of Uganda. Discover, prevent, cure. Thank you very much. And before I leave, ladies and gentlemen, allow me to, with all due respect, request Dr. Rem come in and help me invite our next speaker, who is going to give us the keynote address on this day. I'll invite Dr. Rem to help me, because who am I to invite our keynote speaker? But Dr. Rem can do it for me. Thank you for.
Once again, as capacity, but and the fact that I have no our none other than Professor Charles and that made for him provide lecture society they taught on. I've known Professor Wayne quite some time. First, just hearing and reading about work at the Uganda, right from the time when doing name was there. Uganda Cancer Institute, very vibrant research institute that is early 80s. But reading more, found out that actually associated Uganda cancer research dated back late 60s, 70s, and of course 90s, because of situation here in the country, go outside and coming back 80s, fuming at the Uganda Cancer. Eventually, right around 2014, became interim chair, board directors of the Uganda Cancer. Eventually, becoming full chair of the board of the Uganda Cancer after the enactment of the Uganda Cancer Institute Act. And fairly recent. Now, Chancellor, Barra University of Science and Technology, very active, following up on issues, cancer in the country. Say is the person to go to. Never I hit any challenge as far as this. And so allow me to really call him the grandfather of oncology. And without further ado, welcome Professor Charles Olwe. Professor, you're most welcome.
I believe the end of the world has come. You may ask me why I think so. When I was at Mulago, at Makerere, and at the Uganda Cancer Institute, I always said that if you see Olwenyi arriving late, you know the end of the world has come. I arrived about 15 minutes late, and I apologize for not keeping time. I tried my best, but you know the situation. I even got stuck on the northern bypass half an hour. Dear colleagues, friends, invited guests, ladies and gentlemen, your letter dated the 10th of February 2025, inviting me to present a keynote address at the Hematology Oncology Society launch today, the 14th of February, was handed to me yesterday afternoon. And that was on the 13th of February, 2025. I wish to seek your indulgence and very sincere apology. I sincerely apologize just in case I do not meet your expectations. I sincerely did not have time to adequately prepare for this function. I warmly welcome all the guests who are here and all who have helped to arrange for this togetherness. I warmly welcome the establishment of the Hematology and Oncology Society of Uganda. This has been long overdue. This society will open the door of social aspects of cancer care and management. This society will open the door, as I said, of cancer care and management. The society is meant to lead you and to greater heights in your care for hematology and oncology patients. This is not only an opportunity for socialization, but take the advantage to improve on your social care and management. I will need to view your goals, guiding principles, and action plan for every year, or at least for the first year, and any other relevant documents that you might have in order for me to assist this new society get on. We need, as I said, to view your goals, guiding principles, and action plan for the first year. Allow me to share with you 2 articles that may help you to provide a sense of direction. They are the first one is effective communication with the cancer patients. The use of analogies, a suggested approach. You'll make copies to those who might be interested in this paper. The second one is quality of life in cancer care. Quality of life in cancer care. This was published in the Medical Journal of Australia, volume 158, dated the 15th of March, 1993. And tomorrow, the 15th of March. The effective communication with the cancer patients was published in the Annals of New York Academy. I'll give you copies of these, and those who are interested, I will ask for Dr. Rem, kindly make copies available to those who are interested. Your regular monthly and annual general meetings will enable you to meet new friends and renew old acquaintances. At your annual conference, ensure most presentations are focused on the theme of the theme selected for the new year. You are probably aware of 3 commonest causes of death globally. These are 1, accidents. And Uganda today is a leading country in deaths due to accidents. The second one is heart disease. And the third is cancer. Those are the 3 commonest causes of death globally, not just in Uganda, but globally. They are accidents, heart disease, and cancer. Your society is in order and very appropriate and comes at the time when it's most needed. You may or may not be aware that Rotary has an annual Cancer Run program. I would like to suggest that you engage with the Rotary and provide guidance and advice on the needed directions and the selection of your yearly theme. I will need to view your goals, guiding principles, and actions for the first year. This society is meant to lead you and caregivers to greater heights in your care for hematology and oncology patients. This is not only an opportunity to associate, but take advantage to improve your social care and management. This is indeed a new chapter for hematology oncology, and indeed long overdue. So I feel very privileged to be here, see the initiation of this new society. And I'm glad to hear it has been registered. It has all the necessary documents required for it to run as society, a public society. Some people have asked me, how did you become interested in oncology? We were the very first group to do the Master of Medicine at Makerere University. And we had to prepare a document, or at least present what we wanted to be in our dissertation. I had chosen typhoid fever as my topic. And when I presented this to our head of department, Professor William Person, said, Charles, sorry, there's nothing new in typhoid fever. You will not make a difference. You need to make a difference. He then advised that the Uganda Cancer Institute had just opened, and the new director arrived about 2 months ago. You go and talk to him. That's Dr. John Ziegler. Go and talk to him, and he may recommend something that may be useful. So I went and spoke to Dr. John Ziegler and told me that the Cancer Institute had just opened and that they were treating mostly children with Hodgkin's disease. They were seeing good responses. But they were not sure whether the same would happen to adults with Hodgkin's disease. And so suggested that I should do Hodgkin's disease in adults for my dissertation. And I worked very closely with him. And I used to go to the Cancer Institute that was barely 6 months old, twice a week, guidance. Now, it's Professor William Person who essentially directed me and said, Charles, there's nothing new in typhoid fever, but plenty. There are lots of new information that you need to have in the area of oncology and hematology. So my involvement started very early in my clinical training. As I said, we were the very first group to do Master of Medicine. And my choice was adult Hodgkin's disease as my dissertation topic. And I've never regretted. Never regretted. I found it useful, and I've moved around the globe And the reason I moved out of Uganda was not because of insecurity, but because I was the head of medicine at that time at Mulago and Makerere. And none of my colleagues were interested. None of my colleagues in the department were interested in tropical diseases. And so I said, when I leave, I'm going to ask for sabbatical leave. And when I go, I would like to go and do tropical disease. And I spent 2 years at the WHO Tropical Disease Research Center in Ndola. It is when I was there that I decided not to return. And I moved and moved. From there, I went to Zimbabwe. From there, I went to Australia. From there, I moved to Canada, spent 16 years in Canada. We were the very first, the founders of quality of life in cancer care globally. As I mentioned, oncology cuts across all disciplines of medicine. Cuts across all disciplines of medicine. And I would like to congratulate you for establishing this new organization. Timely, a bit late, still timely, never too late, especially when it comes to the kind of things you are doing and you are planning to do. As I mentioned, you may not be aware that Rotary has an annual cancer run program. I would like to suggest that you engage with Rotary and provide guidance and advice on the needed directions and the selection of yearly themes. I'll need your guiding principles and action plan for the past year. This society is meant to lead you and caregivers to greater heights in your care for hematology and oncology patients. This is not only an opportunity to socialize, but take advantage to improve your social care management. I would like to sincerely thank you all for being here today, and I thank you for inviting me. My presentation is very short, but it is because I only received your invitation yesterday afternoon. Thank you.
Thank you very much, Professor, for this address. Thank you for sharing with us knowledge, stories, wise in the world of oncology. We are quite privileged to listen to him. Professor, thank you, and may God protect you for us. He keep you alive, share with us through this journey. May May He bless you for your work you've done. Oncology, I am medical. You have mentored many, and indeed He has emphasized the need for said right time that we really, and at least He has promised to keep blessing us. So I'm sure blessings. Thank you very much, Professor, for braving the traffic. You with that, even when they invite an emergency. Thank you. Okay. I would like to invite Henry Do once again. And I thank you all for really being a nice audience. We are going into quite an interesting session with diverse team that will be led by Dr. Dung Henry. Thank you very much.
Thank you once again, Dr. Nyakato, for this. Indeed, as she said, we are going to get into, our program keeps on changing a bit, but we have to keep it as exciting as always. I want to welcome all of you who have just joined in. At some point, I'll greet each of you individually to express our session. I'm going to request a few experts come up here for panel discussion, and I'll start with the Executive Director of Mulago National Specialist Hospital, Dr. Rosemary Byanyima. If you don't mind to come up. And since you're with Dr. Sally, he can also join you. Professor Francis Sally from the Joint Clinical Research Center. I'll also kindly request Dr. Jackson Orem to join the group. Dr. Clara Odiambo, ably representing the CEO of Nsambia Hospital, come up here. Dr. Manel Haji, ably representing the CEO of Aga Khan University Hospital in Nairobi. Just going to have a light moment of discussions and, and someone is going to help me time this activity. We have our moderators, Vincent Sereko and Dr. Nyakato. They can help us to know the timing so that we don't overdo it. Okay? Ladies and gentlemen, welcome to the society, the Hematology and Oncology Society of Uganda. And we're going to have our show start. I'm going to randomly pick on people to tell us about a few things. Dr. Manel Haji, you're from the Aga Khan University Hospital. And indeed, you had the largest private enterprise investing resources in healthcare, particularly hematology and oncology in the region. What arguments do you offer in making an investment case for these services? Because everyone here says, oh, you're unwell, Aga Khan. How do you do it?
Thanks for having me with you today. First of all, congratulations on the new Society of Hematology and Oncology of Uganda. It's really a big achievement, and it's a step forward to really elevate and improve the standards of care in the country, but then also, I know, at a regional level. So, talking about our experience at the Aga Khan University Hospital, we knew that oncology, hematology is the future. So everyone is complaining about an outbreak of cancer, if I may use this word. And we knew that we had to be ready for it so that we can offer the best of treatment for the region without having our patients to really have to go overseas to access the treatment. And to be able to offer world-class treatment, we knew that oncology cannot exist without research, cannot exist without education. So we really invested in our educational system, our research system as well, so that we are not only offering treatment based on the international guidelines. We wanted to come from our own experience with our own population, so coming from us to serve us basically. And then promoting education and research, encourage collaborations at an international level, at a regional level as well. And I'm happy to be here so that we can strengthen the collaboration with Uganda and make sure that we are on this together. And then every single patient will have the opportunity of receiving world-class treatment at the comfort of their own home and their own country. So oncology, hematology is really a rapidly evolving field. And then I would encourage at the same time building up a good foundation for research and for academia to be able to have a continuous improvement of the standards of care in the country, but then also in the region.
Thank you so much. Dr. Jackson Orem, Executive Director, Uganda Cancer Institute. You know, as our keynote speaker said, Cancer Institute has been here for a long time. And UCI has been the only comprehensive cancer care provider in this country. And currently, we know that we're coming up with regional cancer centers. Do you believe a parallel system for providing cancer care, preferable integrating cancer care in the existing care systems of regional referral hospitals? You know, there's been an argument, I even saw it on the UMA forum, where they're thinking that we should have cancer care integrated into the regional referral centers. What's your take on that?
Thank you very much, Dr. Dungu, for that question. I think it's very important that an association like what we are witnessing today comes in to demystify some of the issues, which I think directly bring questions like what you have just asked. I should start by saying that unlike other conditions, the management of cancer is very complex. You know very well that the word cancer represents about 133 conditions. Each of these conditions has its own mechanism as well as difference the way they are supposed to be managed. So we can say that that word cancer is just a level of convenience for managing this. So if you are to effectively handle conditions, that means you must have the expertise that actually can kind of envelope all of them. So you can imagine that if you are supposed to treat tuberculosis, and tuberculosis is just one condition, to have an elaborate system for managing it. What about now for cancer? So diverse. So what I'm trying to say is that understanding of this, what should actually lead the mechanism, how we handle cancer. The best way that has come that everyone need to understand for doing this, what WHO calls comprehensive national cancer control. That should actually be the bottom line. And if we are to have that in place, that means what we as Uganda, and in particular the Uganda Cancer Institute, trying to do in terms of a decentralization of care or coming up with the regional cancer centers, just an approach in order to embrace or to envelope these diverse conditions so that we can manage it in a way which is in line, that envelope, which is the name that we have given it as cancer. So if you are going to say that you are just going to have, I would call it a way of managing it which is similar to what the other conditions are being managed, you are likely actually to misfire. So that is why the Uganda Cancer Institute has come up with the approach that we are handling.
Thank you so much. I think it is brought out so well, this comprehensiveness of care. Now, Clara Odhiambo, you are from Nsambia Hospital, and we know this is a private, not-for-profit. Do you think this is a suitable model for offering hematology and oncology services? And of course, we know you've partnered with Rotary clubs for infrastructure development and perhaps other stakeholders we may not be aware of. So how do such partnerships accelerate the process of building institutions like in Zambia Hospital Oncology Services?
Thank you, Dr. Dungu. Absolutely. As the previous speaker has said, cancer is very wide and quite big with enormous budgets, and the UCI cannot do it on their own, neither can Zambia do it on their own. So the inauguration of HOSU and having this is a really good step. Eventually the children will grow and form their own ways, but I think this mother step is very important. And as I said, cancer care, what I think really cancer care cannot be monopolized. So I believe in partnerships. I believe that coming together can help us in diverse ways. I think it's a good thing to do. We should not aim at monopolizing, cancer care. And when this grows, the children have to be allowed to grow. It's important for the parents to allow the children to grow. So I don't know how best to put it, but this is really beautiful. And 20 years from now, you'll be amazed at what this inauguration has done. So partnerships are indeed welcome.
Thank you so much. I think it is well stated. Uganda Cancer Institute started as, I think, a unit in the Department of Medicine, Mulago Hospital. And for you who have the history, Makerere University, Mulago Hospital, and the National Cancer Institute coming together to form a unit, as a professor has stated it. Dr. Byanyima, Executive Director, Mulago National Referral. Mulago shares a compound with Uganda Cancer Institute. You actually are there, eh? Offer hematology. I saw Dr. Sekaja here. I don't know if she has. And oncology services, different capacities. Before they come to the Cancer Institute, the surgeons have done their job, the hematologists have done their job. Do you think this is a duplication or it is an integration of care?
Thank you very much. I think the previous speaker has alluded to that. The need for care is enormous. And I want also to appreciate that you respect that you came out of Mulago National Referral Hospital, and we are proud to see the Cancer Institute grow and take up the mantle for cancer care and coming up with programs and coming up with such associations. I'm glad to see that members from or staff of Mulago National Referral Hospital who are involved in hematology and oncology care are here present and members of this association. I think in terms of care for hematology and oncology diseases, we need to widen the teams that are doing this work and aim at complementing each other. I think this arises out of the fact that we collaborate with Global Hope, and we've come up with a program that is taking care of children with hematology and oncology diseases. We've harnessed a lot from this collaboration, and many patients have gained. We've just renovated and furnished a ward 5C with state-of-the-art equipment, with patient monitors and all that it takes. When you look at that ward, it is a really soothing environment for children who are suffering from such diseases. We are also finalizing equipping a state-of-the-art lab that will also support the hematology and oncology programs. I think working together, we harness all that we need to improve the care of these children. So I think the aim should be about working as teams, but towards the same goal.
Working towards the same goal. We thank you so much. Dr. Francis Sali, you are a professor of hematology, you're a researcher, done a lot. I think everyone knows sickle cell anemia is a major issue. We know it's a key hematological condition that particularly afflicts our communities. The new therapies that have been approved, but they still seem to, be out of reach for Ugandans. Do you have any plans to accelerate the adoptions of technologies such as gene therapy, bone marrow transplant in this country as a leading research institute?
Thank you, Dr. Dungu. Yeah, I think we all know sickle cell disease is one of the leading hemoglobin have on the continent. I think in Uganda we are about like number 4 or number 5 among the countries that are affected by sickle cell. We have a huge burden. Many patients get access to care. Many children die before, maybe about 80% die before they are 5 years. Then the ones who survive, they have a lot of challenges, early adulthood life. So yes, I think we appreciate every effort that is done to make the life of families better. But just yes, we've been involved in some plans with other global partners to see how some of these emerging therapies can be accessed, even in a limited setting hours. And the approach is looking at simpler workflows which cut down costs, and also been trying to apply for grants to patients can access therapies, grants. I'll give you an example, not about sickle cell, but about hemophilia. we hope this year that we'll start a gene therapy trial. Yeah, in Uganda. The team also from Lago, and also for sickle cell, we hope that within the next years,
the therapies and what? You've told us that the presidential orders are affecting JCRS, is that right? So given that, limited funding in HIV and hematology, do you anticipate any challenges given the anticipated challenges in resource allocation?
Well, we live in a very uncertain world, but I don't think the services for sickle cell disease per se will be affected.
Okay. Yeah. Thank you. At least we are assured we are not going to be affected by that. But Dr. Jackson Orem, we know that Uganda Cancer Institute is the center of excellence within the region for oncology care research and training. And indeed, you have spearheaded the training of hematologists and oncologists in this region through this center of excellence. As you can see, the spectrum of specialists in the field is diverse. What is your vision for scaling up this training to address the dire need of this super specialized health workforce?
Yeah, thank you. I think that is a fantastic question. It is all about what the Uganda Cancer Institute stands for, and this is based on the strong foundation historically that people like Professor Charles Olweny, John Ziegler, and all the others have set up. From the inception, the Uganda Cancer Institute has been at the forefront, not only here in Uganda, but I think in Africa. And I'm glad that that has also been recognized in the setting up of the Institute as the East Africa Center of Excellence. And this Center of Excellence is mainly actually looking at making sure that the oncologists as well as our patients in the East African region are receiving care which is standardized, which is actually state of the art and in line with the realities or conditions which pertain in our region. So for that matter, the Uganda Cancer Institute is available to make sure that the management of cancer is comprehensive as it is actually across the world. And that is why the forming up and training of a multidisciplinary team, as well as that culture of doing things in a multidisciplinary manner, is inculcated. And I must say I'm really excited that this society is coming up to kind of fit in exactly that gap, so that cancer management, just like the world over, is in the first place comprehensive, and then secondly is delivered in a multidisciplinary manner. That means everyone part and parcel of the team. And our training program as the Uganda Cancer Institute should actually be geared towards making sure we come up with a workforce which inculcates these values. The second thing, which is most important that we must be looking at, is the quality of the care that we provide. So if you can look at these two aspects, I think in as far as the Uganda Cancer Institute is concerned, our main preoccupation is going to be ensuring that actually we stick these two principles.
Thank you so much for that comprehensive response, Dr. Orem. We are coming to the end of this panel discussion, but each of you, I'll kindly request you to give us what some people call a parting shot. We are not parting yet, but Dr. Sally, do you have anything you want to say right now following this discussion?
I think all I can say is that I'm very expectant of what lies ahead. At least there is some hope now. We see a glimmer of hope. I was reading a paper recently which was showing that in Africa we have over 3,000 oncology patients per oncologist. And I think in the US it's less than 180. And the figure was over 3,000. So you can imagine the challenges that the doctors go through, the treating teams go through, the patients' families go through, the patients themselves, to be able to get through that service, provide the service, and also to receive the service under those circumstances. So I think this is a very good step forward. I think it's going to give us a good platform to develop the service within our country and within the region. So thank you very much.
Thank you so much, Dr. Sally. Dr. Benyima, I think we shall follow that order.
Thank you very much. It's nice to hear what the different institutions are doing to improve services on hematology and oncology care. At Mulago National Referral Hospital, we are also not sitting back. Apart from the services that we offer for the oncology in pediatrics, we have also improved the care for sickle cell, and currently we are also starting to use our own budget to buy hydroxyurea, and we've set up our labs to improve them to be able to monitor these patients who are on hydroxyurea. We are also, with other partners, also improving the diagnosis and care for the hemophilia cases. So, and I don't know, for a long time we thought we had few cases, but as we improve in our diagnostics, these cases are picked up and are taken care of. We also pledge to continue to work with the other partners and in collaboration with the Cancer Institute as we take care of the oncology, the pediatric oncology cases. Thank you.
Wow, this is exciting. I remember a few years ago when I was in Mulago and we had the idea of starting a hemophilia society, which we actually, I can proudly say, I was part of, and now it is moving even to higher heights. Thank you so much for keeping the banner burning. Dr. Rem, your parting shots.
I think I'm really happy that things are beginning to take shape. We are beginning to work together, and then also to see that we are recognizing the different specialties, different professionals coming under one umbrella. I think to me is very exciting. Thank you.
Thank you so much. Yes, your parting shots, Doctor.
I would like to give an analogy of a family with 4 children. They are all different, but they bring something good to the table. So my vision is if we can complement one another, and as I said earlier, cancer care cannot be monopolized. So we all bring something special to the table. It's amazing that this society has now come up. So the onus is upon us to complement one another, to work together. I think the future of Uganda is great.
Indeed, the future of Uganda is great, and of the region, it's even greater. Going back to Dr. Haji, what do you have to say?
Yeah, so I would like to extend my congratulations again. This is really a big achievement, and then you will see it with time. And I agree with everyone, with all the speakers. It's really good to have a mother institution where you can have everyone together, where we can put our hands and efforts together, coming from a government hospital, coming from a private hospital, non-for-profit, with profit. I think we are all driven by one main goal, which is providing excellent services to the patients. And as it has been said before, 3,000 patients per oncologist. This is really horrific. So let us put our egos aside. So no egos in here, no conflicts of interest in here. There is a lot of work for everyone. We need to expand, we need to grow, and once we put all of our efforts together, we will just elevate the level of the oncology within the country and then within the region as well. As Aga Khan, coming from both sides, we have Aga Khan Nakawa here in Uganda, but then also we are from Kenya. I think our main goal should be to, number one, increase the workforce, get more oncologists, hematologists, pediatric oncologists as well, palliative care, and then putting in place a succession plan and then training plans so that we can have more oncologists to be able to provide excellent services. Also, I want to stress out and emphasize that it's overdue for us to just be applying data from the West on our patients from East Africa. So I think having our own data, understanding our own population, understanding our own risk factors, and then the response to the treatment, the outcomes, I think will really make us leaders also in oncology at an international level. So it's a good time for us to have our own data, our own research from us to us. That's what I would really want to say. And we are just one family, and I will extend it to the region, not only to Uganda. We are one family. We can put all our efforts together and then improve the outcomes with the main goal. It should be patient-centered and then education-centered as well.
Well, thank you so much. Before you go, the audience is actually thrilled and they want to ask you a few questions. Do you have anyone with a question? Do you have a microphone? Allow me to recognize the presence of Professor Lukande, our pathologist, and others who have just come in. I said when I don't mention your name, it means I have seen you. Okay? So do we have any questions to the panel? And remember, we are all part of this, so we all have questions. Okay. I'll still count a few and see if anyone, oh, there's a hand behind there. You can shout or you have a microphone.
Thank you. I would also like to add my voice to thank the panelists. I'm particularly intrigued by what Dr. Clara was saying, that cancer cannot be, no one entity can manage cancer in the country. And because this is a journey, I sort of wanted to ask high indulgence on how, as institutions working in the cancer space, in the hematology space, we can better work together. Because it seems that sometimes every institution is working on its own. We have the same objective, but can we work more collaboratively, closer together to improve the outcomes for our patients? And how can we do that?
So it's addressed to who? To everyone?
I think it's everyone.
Okay.
Yeah.
You know, when everyone is going to answer, it becomes a challenge. But let's hear from Dr. Mwesige.
This goes to the person representing Aga Khan. I'm sorry I didn't remember the name. I was wondering if you have better ways in which you can collaborate other than the referral system that is in place. Because I think at the moment we refer to you, but I doubt if you refer to us. But if we can make it much better.
Thank you very much. How can we, before she even answers, remember when we had a situation here, we took off to the Aga Khan, and they welcomed us so well. When, okay, I'll not go back to history, but the collaboration has been there. Any other question before they answer? Okay, let's start with Dr. Haji to answer that question. question.
Sure. So luckily, I have, for my defense, few friends over here. So I have Dr. Alicia, I have Dr. Najib Bougeri, Dr. Okoko. They can confirm that we do refer patients here, and we do collaborate a lot. Maybe we didn't have a chance to collaborate, but then what we usually do is when the patients come, because it's usually a patient-driven consult, so they come for a second opinion, or they happen to be in Kenya to do a PET scan because Kenya has the PET scans within the region. And then when they come for a second opinion, we go through the files and then we tell them the whole treatment is available in the country, so why don't you, go back home and then receive your treatment. Now, we can collaborate in a bilateral way. So, for example, whatever is available in the country, obviously, and you have experienced doctors and expertise in the country, we can always send back those patients. But then what we can help with is maybe whatever is not available in the country, we can just help with, for example, a PET scan, the genetic testing, so that instead of sending, overseas, it's so easy to send it to within the same region, and then you can get the results like in a timely manner in just a few couple of days instead of waiting months for genetic testing to come. And maybe I would say just working together. So we have a network. I have few contacts from Uganda, and we usually discuss the patients together, and we come up with a plan together. So maybe if we can emphasize and then reinforce this collaboration through our societies, actually, and I think that might reinforce our mutual collaborations.
Thank you so much. There was a general question. I don't know who wants to respond to. Yeah? Dr. Diambo, you want to say something?
Yes, I can. Interesting question and very good question. And how can we work together? We definitely have to work together. We have to work together. So these are a few thoughts that are coming to my mind right now. We have to listen to one another. I don't want to say my vision for HOSU because there's already a vision, but this is what is in my heart. We need to develop guidelines. For example, how do we want the radiologist to report on a rectal cancer? That means they have to sit together and come up with the way this is done. Then this is going to flow out of Kampala to Mbarara to Arua to Karamoja, and they're reporting the same thing. How do we want the pathologist to report on a breast specimen? It has to be one. So they have to sit and come up with what they think is, or they think should be done. So cross-consultation, training, we've all received training from different places, but we have to come together and forge what we think works for Uganda. As she was saying, it's not bad to follow a lot of what is happening. People have gone ahead of us, and we have to accept that people have gone ahead of us, but we can make things new. If we have our own data, then we can begin to also speak in these places. So, Nixon, this is what I think. HOSU should now be the catalyst for all this. I think really what we should start by doing is developing guidelines of how we want oncology care to be. And this should be cancer by cancer, from the head to the feet. And then when you have this, you disseminate them. Then someone who is in Karamoja needs not to do their own thing. They will know that this is how it's done. When I'm examining or suspecting a breast cancer, this is what I should follow. That's what I can say.
Thank you so much. It's very, very important, working together and doing things the same way. Any other
Actually,
comment?
the word is standardization. I think HOSU should catalyze the standardization of oncology in Uganda.
That's the word. Standardization of oncology services at all levels is extremely important. Any other comment? Yes, Dr.
Yes, just to add on what Dr. Odhiambo has said, is that I'm not sure if every institution has a multidisciplinary team meeting where they can discuss difficult cases, classic cases, but I think how to collaborate together is maybe to put in place multidisciplinary teams with each institution and then maybe grow it to a national, at a national level, have like, for example, a monthly meeting where we can discuss all those complex cases, come up together, pick up our brains together, and then grow it further with a regional multidisciplinary team where we can always exchange our experiences and then our expertise. And that's how we will really help putting in place and standardize our treatment plans and our patients management within the, we start at an institution level, then national level, and then regional level. I think that would be a very good start of collaborations.
Dr. Sal, you want to say something?
Yes, sorry. One way of bringing people together is just like we've had this meeting. Research is another another possibility where groups can come together, bring synergies, and I think that will build partnerships across various places.
Yeah. Research is extremely important. Did you want to say something? Yeah.
Thank you. I think already we are doing something, but at a rudimentary level. And whatever we do to scale up what we are doing in terms of sharing, especially the diagnostics, and having those teleconsultations, having the tumor boards, we should, as they said, standardize. But also we need to work on efficiency so that we don't delay care as we go through these consultations and discussions in tumor boards. But we have significantly improved. And what we are seeing as probably a rise in the cancer cases, which could be for real, but it's also because we have improved in our diagnostics. So we also need to step up and do the diagnosis early, do the treatment plan early so that we can get better outcomes. Thank you.
That's extremely important. You know, as a person on the receiving end, if they tell you it's going to take 4 weeks to get you know, your reports back, you remain very, very anxious. Dr. Rem, did you want to say something?
Thank you. I think what I can say is that we as Uganda, we are really very fortunate that we have been in this space for a very long time. And this has been marked by the existence of things like very robust cancer registration system, a very well-renowned, would call it Cancer Institute. And we have, of course, that means an institutional framework that we can actually draw onto. And then secondly, the development of professional capacity, which I think is now culminating in, for instance, this association. So what will be very important is for us, the institutions, the hospitals, or the centers that are beginning to see that, you know, they can develop cancer management capacity, to first of all look at themselves and see what they can do at what level. And then secondly, also the capacity that they have, so that, you know, whatever they're doing is actually in line with that capacity. And then, of course, also the mandate that they have. You cannot just begin to do things just because you think you can do it. And if we can have this, and there is a good hierarchy, as my colleagues have alluded to, guided by, for instance, guidelines, as well as referral systems, I think we can actually come up with a very good cancer management system in this country and then in this region, given that, of course, now we are working together as the East African region.
That is what I can say.
Wow, thank you so much. Thank you, everyone. Dr. Eki, you want to say something? Dr. Ekli Achikule. And now she cannot, she needs a microphone. Someone has a microphone, or someone has a microphone here.
Thank you very much indeed. I want to really congratulate the panel. You would think that they met somewhere outside and discussed what
Maybe
they
they
would
did.
say. But thank you so much. I want to just comment on a few things. One, ego shouldn't be negative. The bigger the ego, the better the treatment or services, really, we should be giving. But one thing I think is missing, Dr. Dungu, is the herbalists. I mean, we are eating everything from roots to leaves to what, if this is the anti-cancer and what. I think HOSU should really engage these people. We need to design our own clinical trials and make sure that we develop anti-cancer things from our own foods and leaves and whatever. I think that is, I want to encourage the HOSU to, because we are talking about discover, prevent, and cure. We need to use our own, do I call it foliage?
That sounds a good one, foliage.
Yes, foliage, because we are meant, a lot of things are being offered to us to eat. We can work with pharmaceuticals. I see several of them as sponsors without necessarily coming against these established ones.
Okay.
We should be working together with them instead of working them out of business. And I also appreciate using our own data, because I am supposed to be obese. So why can't we just use our own data and have our own BMI? Because I don't consider myself obese. And just because my BMI is in this region, and I'm supposed to be obese. So these are the things we need to really work out, and the society has the clout to do this, and I want to encourage it. I'm so excited also that we have a body through which we can have these innovations. Thank you very much. But the herbalists should be on board.
We need to bring herbalists on board. Who wants to comment on that? Now everyone at the panel here is, You can just touch the button, it turns red, you respond. There you go.
Yeah, thank you. I think I agree with what Dr. Kikule is saying. We need to see how we can reach out to those who are practicing that type of medicine. First, we can learn from them in that some of the remedies that they have can actually be, I would call them substrates for our research so that we can understand. But that requires us to develop, I would say, a very good approach to make them not defensive so that they kind of open up to us. That is how I look at it. So I think the society should find a way how we can engage them. And it doesn't really have to be adversarial. One time, one of them was actually brought to me by actually a bishop. So you can see that, they want to get in touch, but we should develop an open door so that
they don't fear us, they come to us so that we can learn from them. Thank you.
Well, when it came to HIV care, you remember how herbalists were brought on board and they did a really good job. Anyone wants to touch the button? To say something about we have genuine herbalists, and those that are not truly genuine. So HOSU will need to work with them to make sure that they all become genuine. If no one is touching the button, do we have any other question or comment? Yes, please. Where is the microphone? The microphone was somewhere. We need to have someone who can help move the microphone. As we welcome the Deputy Principal, Makerere University College of Health Sciences. Professor Idro, you're welcome. Yeah, go ahead with your question.
Thank you. My name is Lisa. Good morning, and thank you to all the panelists. My question is it in the mandate of HOSU to document the hierarchy that Dr. Orem has talked about, and we publish it because we have many players in the hematology and oncology spaces, and the loss to follow up and lack of continuity of care is real. So us as people that are at the community and ground level, is it possible for us in future to have these hierarchies documented such that if we find people, we know exactly where they can go? And I'm speaking for the community, but other healthcare providers that may not know what the different institutions might be providing.
So if I got you right, you're suggesting that the society, working together with everyone, comes up with a strategy of documenting the hierarchy of care. Is that right?
Yes, and publishing what the capacities that different are for the different players.
Yeah, these are the opinions that we are looking for and how we are going to build the site. Indeed, if you give us the mandate, yes, we are going to be doing that. Yes, there's another comment from a clinical pharmacist. Someone help me move the microphone really quick. Where were you? Oh, where the microphone is where you speak. I didn't know it was outside the other side.
Thank you very much. Good morning. My name is Shona. I'm a pharmacist interested in pediatric oncology. My question is about the research aspect, which has been touched on, and especially herbal medicines. I'm not sure, maybe I will need some education from the executive director of Mulago. We are told we have a laboratory that is supporting pharmacologists in finding new molecules and coming up with these medicines. Please throw more light on that, and also how are you intending to help new pharmacists that really want to engage in this kind of discovery, because according to the other speaker, it's something that needs to come on board. Thank you very much.
Thank you. I'll take just one blast question if it's there, just one, and make it summarized. We'll respond in the next 3 minutes. We have to end the session.
My name is Dr. Michael Lukoma. I had a general question about screening. Since we have all the leaders in front of us, I'm just wondering what we can do to make our screening programs more robust. I know some guidelines are there, but sometimes it feels like when you're in your consultation room, it depends on how holistic you are as a doctor. So I think there should be some national drive towards having more of the screening guidelines and having them, not just having them written down, but in being enforced for breast cancer, for prostate cancer, because I think that's one of the first steps towards prevention.
Thank you. Who is going to respond to those? There's a question that came to the Executive Director, Mulago Hospital.
Thank you very much for that question. always answering questions for all institutions on the Hill. When people hear Mulago, they think everything is Mulago National Referral Hospital. I think what you're talking about is one of the reference labs for National Drug Authority, which is at Mulago Hill, because they have the mandate of testing such molecules. So I think they would be able to give us more details, but that is not our mandate as Mulago National Referral Hospital. I'll comment a little bit about the screening programs. Yes, we can run screening programs, but we also need to educate our health workers and the public to have that high index of suspicion. This morning, I was talking to one of our pulmonologists at Mulago before I left. The patient was admitted on the pulmonary ward, had pleural effusions, of course had difficulty in breathing and ended up there. And they almost started the patient on anti-TB, but did further investigations, and guess what? It turned out a B-cell lymphoma. So having that knowledge and high index of suspicion, and then we do the relevant tests, we'll always get the right diagnosis and the patient will get the right care. So apart from the screening programs, even us as healthcare workers, we need to be educated and be on top of things and have high index of suspicion, do relevant tests so that we can have the diagnosis done, made in time. Thank you.
Thank you so much. Any other comment? Okay, Dr. Rem.
Yeah. On the screening, I think that's a very good question. And I think it's coming also to a good forum, given that we are a professional, I would call it society. We need to ask ourselves whether screening should be done across the board. The answer is no. Actually, screening, there are only two ways you can screen. If you do it the way now it is being done, that is called opportunistic. It's not scientific. So for that matter, it's not professional. Screening needs to be systematic. That means it is being done in line with what the disease actually asks for. There are certain diseases that are amenable to screening because screening will actually give you the outcome that you desire. But there are many more other cancers that are not. So for that matter, that means as a profession, we need to kind of come up with also guidelines that will provide our members with the knowledge to do the right thing. I think that is how I would look at it. Thank you.
Thank you so much. Dr. Sal, want to say something before we close?
Yeah, I think the last 30 years we've had in the country, we've been dealing with mostly with infections, diseases to do with infection. But as a country, we are transiting through a period now where we also have, diseases related to pollution, and cancer is a major component of that. Before we get to maybe the disease pattern that the people now have in the West, but so right now we have a mixture of a lot of diseases to do with pollution. Some of them also to do with some infections because some of the cancers are infection related. But I think for all of us as healthcare workers, we need to have that sense of awareness. And also we are also going through a population shift. We've been a very young population, but we're also a growing population. Maybe aging population, if I can say. So the incidence of cancer is going to be higher. So all of us just need to, I don't know, maybe the people who are in the nursing schools, the training, the people who are in the medical schools training, this awareness needs to go up.
Well, thank you so much. Yeah. Ladies and gentlemen, join me to thank our panel by a big hand clap. Thank you so much, dear panel members. Thank you for being part of this. Now we can let you go and have breakfast. Then even you can actually join for a cup of coffee. When you return, they will tell us what to do.
As we go for our coffee, the DJ has a special, the one in the, a special message from the MC team. Yeah, so joining the MC team, there is also Mr. Anserko with us, and we want to say that in good times, bad times, fun times, tough times, no matter what, you're always by our side. So as HOSU members, let's still be on that side. Today is a special day, and we'll always remember it for HOSU. Thank you.
All right. Good morning. My name is Vincent, and I'm very glad that I'll be flanking my co-MC. So right about now, we're going to have our break, and if you're interested in the break or break tea, you just go out through the doors. There's tea stations that have been set up right outside. Let's have our tea quickly and get back to the session. When we get back, we have an exciting opening ceremony that we'll be having, and then we'll pick up with the other discussions. For now, have a good morning. Good morning once again, ladies and gentlemen. I'll ask the people still on the outside to come back in. We resume our session. As I had promised before we broke, that we will have a very exciting opening ceremony right after the break. And our sumptuous meal coincided with the arrival of our honorable minister. So I'm just kindly asking everybody on the outside to come back to the room. We resume our seats and we get on with the opening ceremony. So I'll give it just a minute for us to all resume our seats and then we'll get started. All right. I'll ask us to be up and standing and ask the DJ to lead us in the anthems. DJ, I think you lead us. The key of my voice, if I led, everybody will go astray. So I'll ask the DJ to lead us first in the Uganda anthem and then the East African anthem. We can be seated. Honorable Minister, I was told I did not go to school long enough to welcome you, so all I can say is I'm happy to see you. But the ministers are people who have enough books stacked to welcome the Honorable Minister. So at this point, I would love to invite the President of the Hematology and Oncology Society of Uganda and a personal friend, Dr. Henry Dungu, who will in turn invite the doctor that will invite the minister. Thank you.
Thank you very much, ladies and gentlemen. We are so excited. And before I invite the person to invite who will invite the other one, I wanted to give a brief summary of what the society is about, and the person in the control room can help me project that short presentation so that our minister is, yes. So, Honorable Minister, today we are launching the Hematology and Oncology Society of Uganda. It is going to be the official launch and symposium for a new chapter for hematology and oncology in Uganda. We have come up with a vision that no one should die from cancer and blood diseases, with a mission to control cancer and blood diseases through research, education, and care. And we believe all this can be done if we are able to discover, prevent, and cure. Our main objectives are to promote evidence-based practice and scientific advancements of hematology and oncology in this country, to explore and implement strategies to promote the quality and accessibility of hematology and oncology services in Uganda, to promote education and training in hematology for all cadres. And during our panel discussion, this was emphasized, that all cadres that are involved in this field which we are going to promote education and training to ensure standardization of care. To promote cutting-edge research in the field of hematology and oncology, including bring on board our colleagues in herbal remedies, because we discussed that it's important, we bring them on board rather than sending them away, so that we gain from them. And to promote quality assurance in training, research, and care, and represent, promote, and defend the rights of members of the society, as well as synthesizing, disseminating, and evaluating the impact of information of interest to the development of hematology and oncology in Uganda. And we have a membership that is broader than what is here. We have hematologists, we have oncologists, we have palliative care experts, we have pathologists, and all those who are involved in the professional care of persons with blood and cancer illnesses. For example, we have specialist nurses, we have social workers, we have those in genetics and counselors, we have our specialized pharmacists, medical physicists, radiation therapy technologists and technicians, as well as oncology radiologists, among others. And Honorable Minister, we are working as a legitimate organization. We have been duly registered, and this is our certificate of incorporation as given by the relevant authorities, the Uganda Registration Services Bureau. We are also, let's clap, the ministers clapped, members clap, okay. Thank you so much. And we want to make sure that we are compliant in terms of regulation. So we have a certificate of registration with the URA and a trading license with the KCCA to make sure that all the businesses we are running are actually following regulatory requirements. Honorable Minister, we've not been able to do this by ourselves. As you will have realized, we are just a handful of promoters of the society, but we have come to all our friends who have supported us. We have sponsorship from different categories, including those who have registered to become members of the society. And we have pharmaceutical companies, AstraZeneca, Adonis, Oncofarm, Hetero Uganda, the Aga Khan, Universal Hospitals from Nairobi and from here, Metropolis Laboratories, Ministry of Health, Uganda Cancer Institute, Makerere University, MSN Laboratories, Mulago National Referral Hospital, the Joint Clinical Research Center, Nsambia Hospital, among others. So all these have come to help us to set up and launch the society that brings together all those involved in hematology and oncology. So our short name is HOSU, which has been registered, and our tagline is to discover. By that I mean we do innovative research promotion, and when we do research, we are able to prevent diseases, and if we are not able to prevent, we get them early, treat them, and cure them. So our purpose is to make sure that we cure all these diseases. It is not me to speak today. I was just giving an overview. And as I said earlier, with your permission, members, I'll ask the Executive Director of Mulago National Referral Hospital to help me invite our guest of honor, the Honorable Minister, who will officially help us launch this society. Dr. Byanyima.
Our guest of honor, the Honorary Minister of Health, Dr. Jane Ruth Acheng Ochero. our senior Professor Wen, colleagues, in the interest of time, ladies and gentlemen, Dr. Dungo has mastered the art of ambushing people today. I don't know. Even after the lecture by Professor Len, he still, oh, now he masters the game. But it's my pleasure and honor to stand before you and the Honorable Minister. This morning we had an interesting panel discussion. Representatives on the panel were JCRC, Mulago National Referral Hospital, Uganda Cancer Institute, Nsambia Hospital, and Aga Khan Hospital. And the discussion showed that we need to harness our strength and work as a team to diagnose and manage patients with hematology and oncology diseases. Without wasting time, I know you have limited time. I want to assure that this meeting, the attendance is good, as you can see, and it's bringing together different specialities. And the audience also reminded us that we forgot to invite the herbalists. Many times they have, I don't want to call them concoctions. They have what they call remedies that are potent, but at times when their remedies are subjected to our scientific research and to our labs, and they are found to be not potent, they think that we have taken their patent. So we need to work hand in hand and also bring on board the National Drug Authority. So this association will have many more players. And with a blessing from the Ministry of Health and all other players, we hope this will come to attrition. It's my singular honor and pleasure to invite you, Honorable Jane Ruther Cheng, to address this audience. We thank you for sparing time to come and be with us.
Thank you very much, Idi Mulago. Our senior Professor Lwen, together with the EDs of the various institutions, the esteemed medical professionals, researchers, partners, and friends. Good morning to you all. I was just asking Dr. Rem, and then Rosemary ambushed me. So I think the ambush is still continuing because I thought I was going to sit, you know, become part of the HOSU team, enjoy myself. But even before I have relaxed, I am being invited to come and talk. And then I asked that who are the executive members? I thought Dr. Dongo was going to introduce. And Dr. Rem answered that we are yet to elect. So the next question to him was, can I also be a member? But before he could answer, I was up. Nonetheless, it is my great honor to stand before you today as we celebrate a significant milestone. That is the official launch of the Hematology and Oncology Society in Uganda. Congratulations for starting this society. This society marks a new era of collaboration, innovation, and excellence in the fight against blood disorders and cancer. Cancer and hematologic disorders continue to pose a major public health challenge across the region. Every year, thousands of Ugandans, both young and old, are diagnosed with conditions. I'll name a few, like leukemia, lymphoma, and solid tumors. Many face late diagnosis, limited access to specialized care, and financial barriers to treat. Actually, if we think about it, I think care for such conditions is only within Kampala metropolitan area. It is not in my village, neither is it in your village. So it is very limited. As a country, we recognize that we cannot fight these diseases alone. We need strong partnerships, evidence-based interventions, and a committed network of experts to improve early detection, treatment outcomes, and patient support systems. The formation of this society is a bold step towards achieving these goals. This society will serve as a platform for collaboration, knowledge exchange, and capacity building among hematologists, oncologists, pharmacists, nurses, researchers, and policymakers. So please don't forget us. It will help to strengthen research and innovation to inform better treatment protocols. It will also promote continuous medical education to enhance the skills of healthcare professionals, advocate for policies that ensure affordable and accessible cancer and hematology care, and enhance partnerships and international experts and institutions to bring world-class expertise to Uganda. I therefore applaud the founding members for their commitment and vision in establishing this society. Your dedication will bridge critical gaps in hematologic and oncologic care, ensuring that no patient is left behind. The Ministry of Health remains committed to strengthening Uganda's capacity to diagnose, treat, and prevent blood disorders and cancers. And a few of the things that we have done: we have expanded services at the Uganda Cancer Institute to offer more specialized care. And we are still continuing with infrastructure there, although my ED there doesn't talk. So many people may not know what is at UCI. You need to get into the habit of talking, and that is not for him. All of you, you don't talk. You don't sell yourselves. We don't even know how many hematology oncology specialists are there. Ugandans don't know. We need to get into the habit of talking. And not only talking, but advertising what we do. We are working to integrate cancer screening into primary health care services to improve early detection. Allow me to correct my English there. We are actually scaling up because there is a lot of cancer screening going on in the communities. We are also supporting clinical trials and local research to bring innovative therapies closer to our people. And we continue to engage partners to increase funding for cancer and hematology programs. Through collaboration with societies like this, we can accelerate our efforts and ensure equitable health care for all Ugandans. Please, in all your work, remember sickle cell disease. and our children and adults with sickle cell disease. It is one of these areas that we need to focus on so that we can achieve the SDG target for reducing child mortality. So as we launch this society today, I urge all stakeholders, the private sector, researchers, healthcare professionals, and the entire government to actively engage in shaping Uganda's hematology and oncology landscape. Let us commit to continuous learning and innovation, support advocacy efforts to improve funding and access to care, encourage community outreach and awareness to combat myths and stigma around these diseases. Together, we can reduce the burden of cancer and hematologic diseases in Uganda. Let this society be a beacon of hope, excellence, and progress in the field of medicine. As I conclude, I congratulate the leadership and founding members of the Hematology and Oncology Society. The work that you do collectively saves lives, gives hope, and shapes the future of healthcare in Uganda. It is now my honor and pleasure to officially declare the Hematology and Oncology Society of Uganda officially launched for God and my country.
We can be seated. So I know everybody is anticipating where is the cake cutting or the ribbon cutting or the signing. Now that is going to come in just a bit. But in the hematology and oncology field, there's people who are outstanding, forefathers on whose shoulders that we stand, and institutions that have done have contributed very phenomenally to this fight. So we have some awards, and I guess I will invite the minister again, possibly to the stage, to give out these awards to these outstanding people.
Yes, Dr. Rem, kindly support the minister in this exercise.
All right, so the first recipient is Professor Charles M.L. Olwenyi.
Oh yes, so yes, please turn around for a nice picture. Yes, the next recipient is Professor Eli Katabira. Okay, and is Professor Eli here? Okay, the next is Dr. Alex Contino. In absentia, we appreciate their efforts in the field of hematology and oncology in Uganda and over in the entire region.
All right, and the list of recognitions continue. In absentia, we have Dr. Edward Katongo Lembide. He's not present here, but let's give him a round of applause because he's done a very phenomenal job in the field of hematology and oncology. And finally, I guess still in absentia, that's, present. Yes, also present. A resounding hand of applause for.
Okay, Professor Henry Wawinga is quite phenomenal in the field of hematology and oncology. He's a pathologist. So in his absentia, Dr. Lukande will represent and receive his award. A renowned teacher and mentor to many of us, at least Professor Wawinga.
There are, let's finish with that photo moment. So there are institutions that have also significantly contributed to the field of hematology and oncology. And of course, the very first one, Mulago National Specialized Hospital. I guess the executive director will receive the award on their behalf.
Okay. The next institution to be recognized is the Uganda Cancer Institute. So, Executive Director.
He did not participate in choosing who is going to be awarded, just to be clear.
Yeah, we can have other individuals joining us, Dr. Lutu. We are seeing Benjamin, you could also support our ED. We need the ladies, yeah, our ED works with the ladies too. So, yeah, Dr. Joyce, we can really support.
And the next institution we'd love to recognize is Makerere University College of Health Sciences, and we'll invite Dr. Idro to receive the award on their behalf.
We can have more members supporting him from this institution. Let's. Okay, the next institution would like to recognize is in Zambia Hospital. The CEO, the team, at least we had Dr. Clara around. Yeah, the CEO is here. So, Zambia Hospital.
Ladies and gentlemen, you will agree with me that the discussion, any discussion on hematology and oncology is not complete if we don't have the team from Hospice Uganda. So receiving the final award this morning is the team from Hospice Uganda, led by Dr. Eke Chigure. And the rest of the team of Hospice Uganda, please come up and receive the award.
Yes, let's support her. Let's support her. Yes.
All right, so Honorable Minister, we left you there on a cliffhanger at the launch, so I'll just ask you to look on your far right. Prepared there are a set of markers that have been consecrated, which will be performing the launch ceremony, where you'll be doing the official signing of the banner there that will mark our launch.
Professor Rain, kindly you join the minister. Dr. Rose Byanyimo also joined the minister in this signing.
All right. Honorable Minister, we live in a generation where if you don't take a picture of it, it did not happen. So to ensure that today happened, we'll invite you once again to come to the front. Well, we first take a group photo there, along with the signing, and then you'll come once again to the front and take another group photo. Oh, yeah. Yes, I'll invite you to just we'll ask the president to join you for the photo, and then yes, if you please, just the one more photo, just the one more over here at the front.
And we need to balance this gender nicely, and for hematology and oncology. No, we'll have a very biggest picture at the end. At the end, we'll have a very biggest picture with everyone. Yeah, a few people standing, we can join this team, the palliative, the hospice, Makerere University is represented, in Zambia Hospital, we can have, yes, I see the President Uma here. We are glad to have you here. Oh, before we go, we had the Aga Khan Hospital. Yes, I thought, yeah, to be in this photo. She really kept me safe. Okay, due to public demand, the minister kindly, Honorable Doctor, before you leave, kindly allow us to have the biggest picture right now with you present. So members, let's move very fast at the front. The camera people, please help organizing us teams. We can stand behind here. Let's be in this biggest photo as we mark the start of this new chapter. Let's move quickly, calmly. Let's all be in this photo. If you're as tall as me, kindly step up here at the platform and we have you in this photo. Okay, we see some members missing. The camera people are advising that we can have this picture outside. So due to public demand, we stay here. At least, thanks for the democracy. guess we are all in. Thank you very much. Thank you very much. At least we have evidence, enough evidence that the new chapter has begun. Another session.
That's the training.
So let's settle down. Let's settle down. The new chapter has indeed begun with the diverse specialization in hematology and oncology. Yes. So I'd like to invite you to yet another exciting session that we are going to have on training, education, and mentorship of hematology and oncology professionals in Uganda. Our chair will be Dr. Clear Chikule. Dr. Agre Semera and Dr. Chikule, you are taking us through this session.
Good afternoon, colleagues. As we discover, prevent, and cure, we cannot deny that as a country we need manpower to achieve that. Together with my senior and teacher, Dr. Chikule, I'd like to welcome all of you and recognize everyone, all protocol observed. Would like to invite our panelists, Sister Chandra Agnes Baku, Professor Moses Garukande, Dr. Robert Lukande, Dr. Charles Tusime, Mr. Nyamtale Peter, and the representative of the principal, I think this is going to be Dr. Idro. There could be some changes, but I'll be advised. Dr. Faulal, I've been requested to, and Dr. Alenyi. Yes. Kindly let's come and take up these nice seats. I'm told they were organized for you, but there's no order. Sit as you see fit. And for this session, so I'm going to say Sister Chandra Agnes Baku. I think Professor Galkandi might not be with us. Is represented by Dr. Fowler and Dr. Aline. Okay, and then the representative from Makerere University. We're going to talk about training, and as you can imagine, training takes various facets, and the aim for us is to create capacity to address our prevailing challenges. As you settle down, we have a few questions that we are going to request you to, think about and share your thoughts with us. But you could also ask questions between each other. The idea here is to have an opportunity to give us, as HOSU, some direction in how to plan and think about training going forward. And together with Dr. Chikule, we shall share the questions, and I think she'll be the one to ask the first questions to the surgeons. I wonder why they didn't put hospice people there. I'm thinking about counselors, bioengineers. As you can imagine, this can go very many directions because we're thinking it's a wide pool of people we need to, detect and treat cancer. Dr. Chikule, you want to take the first pool of questions to the surgeons?
There are two questions.
Yeah, we can do one at a time for that.
Yes, let's just go on. The first question is, most of the surgeons who treat cancer patients are not specially trained in cancer care. And the Cancer Institute has yet to develop the capacity to care for all cancer patients who do need surgery. Oncology surgery is more complex than surgery for benign malignancies. What should institutions do to train surgeons who can ably work on cancer patients without compromising oncological outcomes? Surgeons.
Hello. I think that is directed to me because I'm not seeing other surgeons here. My name is Dr. Rosa Leño. I'm a plastic surgeon. My boss is here. I'm just wondering why I'm on the same panel with my employer. And I think here I'm standing in the capacity as a representative of COSEXA. Maybe many of us don't know what is COSEXA, but it is College of Surgeons for East Central and Southern Africa. Our past president is rightly seated there. She'll probably be marking what I'm saying. But the college was started by majorly Ugandan surgeons within East Africa. It was launched on the 1st of December, 1999. And it now has 14 member states. And this was to answer the similar question that is being asked today, that how can we, finding ourselves in the middle and low-income countries, how can we scale up the practice of surgery? So COSEXA developed training manuals that allows people to train and gain maximum skills without translocating very far from where they are. So you could train in Uganda, you could train in your hospital, you could train in the region. And the target was to make sure by 2025 we have at least 1,000 specialists, which includes probably coming forward. So now that was achieved. We have over 1,000 specialists within this region. And these specialists are in plastic surgeon. I'm proud to be among the first plastic surgeon that sat the exams of the college. Thank you. And I think I'm doing pretty well. And there are many more plastic surgeons that have been trained. It's very expensive to try and train plastic surgeons in the developed world. But through COSEXA, this has been possible. Now we have neurosurgeons, we have cardiothoracic surgeons in training, we have pediatric orthopedics, so there are so many. And I think oncology, the society has come at the right time, where subspecialties are being developed within the college. And this is, my boss for Makerere is there. This is, they have their different objectives, but they have a common goal. So if
other details can be discussed, but this is a quick way to skill our region. It is cheap, and there are many volunteers, and we train ourselves within the region or within the country. So I think, and these trainings are introduced by need and capacity. So if, for example, in Uganda, we have the capacity, and the capacity means human resource and infrastructure to train oncology, COSEXA is open, and we just have to sit down and look at the curriculum and draw it up, and we'll be able to have oncology surgeons. Thank you.
Yes, thank you so much, but could you try to marry the two? You are a plastic surgeon. I have cancer. How?
Yes. I think we are part of Cancer Institute by default. Our job is to reconstruct or to repair the body and return it to as close as possible to its original form and function. So function is our priority, and then the look is different. Usually when we say I'm a plastic surgeon, people say, wow, you can do a facelift. But the people that need our services for facelift are 1% of the population. But the rest that need us is the cancer. And Cancer Institute can agree with us that we've tried to be as available as possible. When the tumor is too big, somebody has to remove it, which would have been done by the oncologist, but part of our training also offers us that. And then when you remove this tumor, you might have an open chest, you may have a wide open abdomen, you have most of the muscles gone, you may lose the breast, and that's where we come in. So we try to repair that defect that the tumor excision has left. Thank you.
Thank you so much. That sounds nearer home. This sounds like a fellowship training. Could you say more about that?
Yes, the training with the colleges gives you a fellowship, and if you're an academician that wants to do a PhD, then you're a university. But a fellowship in itself, some countries get specialists strictly, clinical specialists strictly by fellowship training, and others get it through the university. So it's close, but there is a difference. So the fellowship, if you wanted to be a surgeon, from a medical officer, you do a membership exams, which is 2 years, and then you specialize in the choice of field, which is 5 years. So a fellowship, I don't know, there's quite a high debate on whether it's a higher diploma. I don't want to go into that, but it's a skilled training.
I'm excited about the fact that it's driven by demand and need. And as a country, we may not have all the time it takes 5, 6, 7, 8 years. We might have to think creatively around how to get people skilled to sort out our issues. I'm just going to remind you, my kind colleagues here, as you can see, there's a mic there with a button. I think it only has one button. And just make sure the red light shows up before you start talking. Otherwise, you'll be whispering to yourself and you'll be trying to hear. But also, we didn't do this, but kindly introduce yourself a little just so that we know. And I'm going to move on because I know we have a lot of things to do today. Pathology, Dr. Lukande. We know that, pathology is where all things start with cancer. And we still have few pathologists. I've seen so many numbers and ratios, but they are not very encouraging. And both general and specialized, as you know, pathology has subspecialization as well. What measures are we taking to increase the capacity of first of all, the services, but also the expertise in the country? So there are sort of two questions in there. You're on, please.
Okay. Thank you very much. Robert Lukande. I am an autopsy and anatomical pathologist stationed in the Department of Pathology, Makerere University. Well, the numbers of pathologists in the country and in the region and on the continent are not very pleasing, and therefore the services that come under there. We've struggled quite a lot to clone the pathologist to a number that is sufficient to address the needs of the country, of the region, and of course, of the continent. As a person who has been quite involved in trying to scale up the numbers by way of education, we've tried to collaborate widely with the Royal College of Pathologists of the UK, with the International Academy of Pathology, of which I'm the current president of the East African Division, to mainly try to attract young trainees through the university training path. When this did not seem to work very well, we also took on the collegiate kind of training to be able to come up with people with fellowships, just like the surgeons have already shared with us. So within the region, we have the College of Pathologists of East, Central, and Southern Africa, which is COPEXA. We've so far held exams 3 times. The numbers are still quite small coming through, but we are making efforts in the positive direction because we ably recognize that without pathology, there is no medicine. And so we have to make this happen. Of course, we will need all your help, the Ministry of Health, the universities, to help us to eat this elephant piece by piece, but with a common goal of getting sufficient numbers. From the calculations way back, it is stipulated that it may take us over 50 years to get to the numbers where the US is. But I know with good effort, we can probably have this.
Thank you. As a rejoiner, I'm sort of involved in, actually, when Dr. Dungo was inviting me, and I'm a physician, and I'm in the HIV space, but I'm involved in trying to think about diagnostics for cancer. And so we interact a lot. So Dr. Dungo, there is a need for technology, and we need to enhance or leapfrog some of the challenges we are having. They have talked about telepathology, they have talked about AI-based interpretation of slides and all that. I mean, what will it take to harness that power, especially in this time, to try and even extend services? And you know, it would be important to hear from you from a training perspective. How can we harness this technology opportunity to overcome some of our challenges?
The central point here is the human being, and the human being that comes with the right skills and attitude, which eventually drives, of course, bigger goals and ambition, and behind it is also passion. As first of all, as a medical doctor, you know, I took on training in computer science, which has helped me to eventually link up with colleagues from the College of Computing and Information Sciences. We have some of them here within the audience, Dr. Rose Nakasi. And I have collaborated with you as a physician in trying to see that all this happens. So the human being that has the right skills and attitude has to eventually collaborate and cooperate in order to achieve the bigger goal. Of course, eventually everything starts and ends in leadership. This human being must also be driven to have the biggest goodwill for their society to move on. So copying best practices and also being innovative around the problems that we have. We may not take the conventional path and therefore have to take on to leapfrogging, but you may not leapfrog if you do not have the skills. So I have tried to arm myself in such a way that if you speak computer science, I can go there and be able to code for you. I can ably prepare the platform for AI and collaborate with courses at Makerere, and also bring you in as either a surgeon or a physician, and we begin to speak the same language, driven towards one goal. Thank you.
Just to rejoin, any hopes or current use of telepath? Because it's one of those I know that is happening in a couple of places.
Yeah. Quite a lot is happening on the scene in Uganda. You've heard of what is coming out of courses with Dr. Rose Nakasi. Started off with malaria, through TB. Now we are going for cancer cervix, using the AI algorithms that we have designed, of course, using the cases that are Ugandan. And also quite a lot is coming through the IDI with the Kaposi sarcoma. Soon we shall be having an algorithm that can help us to quickly diagnose Kaposi sarcoma. We are thinking of also going into the lung cancer cases. I have been also building an algorithm with the Makerere Lung Institute, because this is again work that we are doing locally within the university, and so we are generating this from our own cases and data. So there's quite a lot happening, and quite a lot is going to happen after this. Thank you.
So it means that our training won't stop on the Mulago site. Our training will cross over to bring computer science, informatics people, AI, and in other words, we have to be a little more welcoming to some new skills into the field to move this forward. Over to you, Dr. Chimwe.
Thank you very much, Dr. Lukale. I'm just wondering, here I am in Health Center 3. How can you, a pathologist, help me to expedite my diagnosis? Are you anticipating with your computer knowledge drones that can relay what somebody in Health Center 3 is looking at to you? I'm just looking at that patient there.
Thank you so much. We are already working towards that with some of the projects that Dr. Rose Nakasi is doing. The central theme is to decentralize pathology as much as possible. I am an individual who believes that science belongs to the layperson. The more we take science lower down, the better. As you talk about discovering, preventing, and curing, until the layperson understands and appreciates science, what we are doing may be futile. So regarding the expediting of the diagnosis at the lower level, Honorable Minister, pathology has to come down to the primary health care level. But of course, this is very difficult if you do not have the numbers of the right health workforce. And I know there are quite big challenges. So in the meantime, the technology is going to help us to speed up. And this is what we are trying to do with the colleagues from computer science to kind of task shift, again using technology, deploy the technology at health center 4. That is where we are basically trying to start and see how it comes eventually up to the tertiary level. And it's not only, by the way, cancer cervix. We are trying out also something with breast cancer through, again, a collaboration with the Mbarara University of Science and Technology, Mulago, Makerere, and then the Johns Hopkins group through the Department of Biomedical Engineering.
Thank you so much. At least the Minister for Health is here. And as we say in Uganda, Olopede police. So she will be able to do something about it. Mr. Nyamutale, could you tell us a little about yourself before I ask you these 2 questions?
Thank you very much, Dr. Ekeria Chikole, and my teacher at master's level. I'm called Nyamutale Peter. I'm the registrar of Allied Health Professionals Council, and I'm a public health specialist. I was invited in this meeting for this launch because some of the cadres that we have on the register, the cytotechnologists, the laboratory scientific officers, laboratory technologists, could also be members in this society as they offer hematology services and oncology services in the country. Thank you.
So thank you so much. In your capacity as a registrar, how does the council ensure that the training institutions are giving quality training? That is one. And after these people are trained, how do you ensure that they adhere to the code of conduct stipulated at licensure?
Thank you very much. To begin with, adhering to the standards for training, we start right away from developing the curriculum, and we set standards which must be followed. For instance, if I can mention the training of cytotechnologists, when we were developing that curriculum, we worked with the staff of College of Health Sciences, Professor Jolova and his team, and then we specified what these cytotechnologies should be trained on. So as a council, we make sure that these standards, which are specified, both in the practical aspects and even the theory aspects, are followed to dot. Then secondly, when the professionals graduate, they present their papers to Allied Health Professionals Council. We verify those papers from the last paper of an academic transcript, then go down to A level, O level, and confirm that all the entrance requirements were fulfilled. Then we put them on the register, and it is also our mandate as council to regulate their practice by checking where they are working from and giving them practicing licenses annually. My appeal would be that we still have only one university in the country, that is Makerere, which is training cytotechnologists. So we would also request other universities like Imbara University of Science and Technology and others to take up the course. Because my fellow speaker who talked of pathologists being few and is asking for decentralization, these cytotechnologists, their main purpose, their job purpose is to detect and diagnose cancer at an early stage in consultation with the pathologist. The cytotechnology does not release the results alone. After conducting the test, then confirms the outcome with the pathologist, and then it is the pathologist who releases the report. Thank you. And secondly, the public service. We thank public service of Uganda because they have created positions for cytotechnologists in district hospitals, general hospitals, and health center. It is only the number that we don't have, because currently on the register we have only 41 cytotechnologists, and the intake in Makerere is also limited. They are not admitting many. So we would ask Makerere at least to increase on the intake and also other universities to take up the course. Thank you.
Thank you so much. I would have wanted to plug here and trying to understand where the counselors fall in this whole thing, because one of the things I've seen is patients delay to make their care decisions while they are coming to terms with a cancer diagnosis. And I'm not sure whether we need special cancer counseling. And I don't know whether they are part of the allied health workforce. And where do these fit in our structure? So some innovation might be required. I don't know. A quick, can you?
They can be both counselors or health educators.
Mm-hmm.
The patients don't delay, but they don't know.
Exactly.
So they seek treatment for other ailments, not knowing that it will be cancer. So by the time they reach the level where cancer can be diagnosed, it is too late. But if we put these cytotechnologies in lower health facilities, then the chance of detecting cancer early will be achieved.
Clearly, we need to do many things. I want to turn to you, Professor Idro, and thank you very much. I want to turn to you, Professor Idro. Again, a brief introduction will be very helpful for audience. But I know that at Makerere, you do provide training, and I know some trainees may not really become oncologists or hematologists, but they do contribute to what we call the cancer care continuum, which starts off at primary care all the way through doing different things. And it would be important to hear from you how you have taken this into consideration at the university and how you are plugging that gap. Secondly, how can we increase the number of specialists? We are grappling. You're here now, they're asking us about psychotechnologists. We're thinking about oncologists. And if we go into oncology, there are all these subspecialty oncology services, as well as even, I was talking about bioengineers. I don't know how you are thinking about this and responding to the current challenge. Thank you.
Thank you very much, moderator. As introduced, I'm Richard Idro. I am the Deputy Principal of the College of Health Sciences at Makerere University and standing in for the Principal. This year, the College of Health Sciences at Makerere University, this academic year, starting October, is making 100 years. And we started initiatives to celebrate this in October, and we're going to celebrate it throughout the year, and with the highlights taking place in September. September 11th, when we'll have monuments launched at the college, and a big dinner on September 12th. I'm inviting all of you to these celebrations in advance. And as part of these initiatives, it has given us an opportunity to try to rethink some of the questions which you have put out here. Many of us have been on the Hill our space has hardly changed over the years. It is very difficult to expand some of the resources. But also there is a lot of resource limitations in terms of both space and human resource. So what are some of the things which we are doing? Of course, today here with us as we launch this Hematology Oncology Society, we have several initiatives. Over the past few years, we have been revising our curriculums. So our curriculums are changing to address the changing needs of the population. Earlier in the day, it was Professor, I think Dr. Sally who did mention that we are a young population, but we are also a rapidly aging population. So our national demographics is changing very fast. So part of our curriculum is starting to address those changes. Two, the curriculum is also addressing other changes to improve care. For example, in the surgical disciplines, which Dr. Alenyo here is in, the surgical training at the Masters of Surgery level has significantly changed. The curriculums have been changed. Ear, nose, and throat has gone to 4 years. Surgery is going to go into 4 years, taking into account even some of the technologies for minimal invasive surgeries, which will be able to support the care of, say, the patients with cancer. In the undergraduate programs, our big challenge is the labs. We are waiting for the announcement, but we are glad that government is going to support the institution to build for us a big lab unit and a training unit, which is going to sit on the compound. And hopefully in the next 2 or so years, we'll have this one starting on the compound. And if that one is to happen, it will change significantly the training which we are able to offer on campus. But there are things which we can do, and I think we are not doing it very well. There is opportunity. There are multiple, for example, labs on that hill. How can we synergize and use them better? For example, pathology, working with the UCI, the Fred Hudson Institute, and the different institutes, so that our students can go across the different units and do it better. We are glad that the fellowship in hemato-oncology, the pediatric fellowship, is now accredited and is running through our college. And I'm actually glad to report that in East and Central Africa, I think this fellowship program has been one of the greatest game changers for hematology oncology care in Uganda, in Kenya, in Tanzania, in Botswana, in Malawi, and South Sudan, because the graduates were all trained here in Makerere, and it is really expanding services in the whole region. Interventional radiology has been approved. It has been accredited, and our first group of trainees are soon coming out, and I think they're going to transform the services. HR remains a problem, and our call is initiatives like this, the Hematology Oncology, to support students for us with scholarships. Pathology, which Dr. Lukande has just talked of here, is really a foundation for the care. But we have very few pathologists, and then we have very few students in training. We need to encourage the younger professionals to take up these fields, but if we could provide them with scholarships so that they're able to go through this training, then we can have more people who can provide care, but who can also train other people. And really that in context is what we see happening as an institution. So groups, including the sponsors of the Hematology Oncology. We really welcome you to come and work with us, and we support the training of people. That is our mandate as trainers, providing care and community service. That is our tripartite mandate as Makerere University. We'll be very grateful to receive you. Thank you.
Fantastic. Thank you so much. Thank you so much. You can imagine, I'm such one of those privileged people who was training with Dr. Idro on the ward and Dr. Ruth Acheng on another ward. So I must be also a good person. Can I get some questions from you? So they were my SHOs at that time when I was training as a doctor, as an undergrad. Can I get some questions from the house? I think we have just a few minutes the organizers have given us, and I would want to know, do you have any burning questions regarding training, education, some ideas that HOSU can take on and champion? Okay, it looks like we did a good job. Did we? We answered all your questions. Thank you very much, our panelists. Let's give them another big round of applause. Oh, there is one? Okay, I can see Dr. Lukoma's hand is up there. Okay, only those two. I'm seeing two hands that are up. And there's also one here. You can bring the microphone. Make sure that microphone is switched on. Okay. Go ahead.
Thank you, Professor Idro and Dr. Lukande, for your presentation. It seems, if you talk to the current SHOs, the fellows, there's still a big challenge in terms of providing stipends or financial support for these students as they're working and training in these fields. So I would like to know what plans we have to help with the welfare of these people, because sometimes their families are breaking apart, there's illness, there's supporting their children. There are big struggles for these postgraduates as they're training and moving into these next levels.
Yes, thank you very much for the session. My question to the panelists is about the plan after the training. So we keep saying we don't have specialists in Uganda, and we are training for Uganda. But if we were lucky today, and God gave us 2,000 oncologists, will our problems in oncology be done? Are we ready to absorb them? Number two, when we are training all these specialists in the different institutions, is there a clear link between the person who is training and the person who is absorbing? Because sometimes you have all these specialists in the country, and the specialists are unemployed, but then also the patients don't have what? Specialists. So how can HOSU become that gap where both the trainer and the absorber and probably the patient create some kind of demand chain, in that if you need an oncologist and you produce the oncologist, you will then employ the oncologist who will train another oncologist, and the cycle goes on. Thank you.
Thank you, Dr. Najib. I think, one more. I think this is the last one, and then we shall wrap this up. Thank you.
Thank you. My name is Kadumbla Sylvester, medical laboratory specialist. My question is close to Dr. Najib's question. It is about the link between the trainers and really those who are absorbing, because right out from the beginning we realized
the Ministry of Education, they are coming up with the curriculums, more especially in Daylight. And way back, we could train, and you are growing up in the system of the health system. You are training as you practice. Right now, there looks to be a discrepancy, a disconnect between the Ministry of what the schools are doing vis-a-vis what the practitioners in the hospitals are doing. So I really want to hear maybe from Mr. Nyamtari and also the panel members, what efforts are there to ensure that there is a close linkage between the training vis-a-vis the practice.
Thank you, Mr. Kadumbula. I think the first question might be somewhere from Dr. Idro, and then the last question is about absorption of people we have trained. I know you, please.
Thank you for the questions. I'm not sure whether I have the answers to some of those questions, but there are a few things. Indeed, especially students who come for graduate training, they're adults. Many of them are family people with wives, with husbands, with children. And two, and especially in the clinical disciplines, when they come, like the ones in pathology, they are offering a service. Years gone by, they retained whatever source of earnings it was, and many of them came from government services, so they retained their salaries and they were supported through. But there has been a lot of changes over the years. Some of the changes are unfortunate, and that is why we're saying that, at least from the point of view from the university, that these students should really come with some form of scholarship. But there are other things which can be done. For example, in the training hospitals, if it could be worked better, maybe with public service, that there are positions which are specifically made for such individuals, so that the hospital advertises that position, and as universities or the COSEXA, that these positions are filled by these individuals. So they're salaried positions, they're offering a service, and they're training. That way, you actually hit several birds with one stone. The welfare of the training person is covered, the hospital needs are covered, and the person is also training. And then they are also easily linked to the different institutions. The concept of COSEXA actually makes it even better. If for example, if the person is training in Mbale and is within Mbale, is already a staff within the hospital, it actually even builds and caters for it better. Can these people be absorbed? Yeah. We have so many posts. Actually, if it was not the wage bill, the number of posts is just enormous. For example, pathology. We have all these regional referral hospitals. They need associate consultant pathologists. They need consultants. They need senior consultants. All the regional referral hospitals. We have 12 medical schools. They need these people. In Makerere University right now, we almost have no pathologists. There are 3. We are so strained. We really need to train people. So the positions are there, and a lot of these people can be taken. What about the linkages to practice? And this is also possible. Wherever they are working, that we can actually build this. And if we develop the networks better, for example, a person who is training there is linked to do part of the work in the UCI or the regional cancer centers. For us, we are able to rotate our students in the different places. Even our undergraduate medical students, they spend bits of their time in the health center 3s, health center 4s, at least 4 weeks in year 4, in year 5. Like the Masters of Public Health, they work in the district health officer's office. They go and spend at least 6 months in each of these. So the linkages are there, and it can really be built on practically and building the skills of the individuals. Thank you.
Thank you so much.
Yes, the linkage is there. First of all, at the Ministry of Health, we have the training committee, which looks at these courses, especially those courses for specialization. Then we also have interministerial committee of Ministry of Education and Sports and Ministry of Health. And we normally hold meetings once in a quarter, and those meetings are chaired by the PS, either PS Health or PS Education, to discuss the training component. And after these scholarships have been awarded in the Ministry of Health, we follow those recipients of the scholarships. And when they finish, we make sure that they go back, for instance, if they are from Mbarara Hospital or from Mulago Hospital, they go back and serve because they are bonded. Then secondly, as far as positions are concerned, as I had said earlier on, we have a number of positions in hospitals for these specialists. But the recruitment is in two categories. There is recruitment which is centrally by Health Service Commission. They recruit and post those regional referral hospitals. There is also recruitment by the district service commissions. You might find, for instance, a position is existing in Kitgum Hospital, maybe for a specialist. Now there, the duty to recruit is vested in the district service commission of that district, and they mainly base on two principles to recruit a person: availability of the wage and also availability of the vacancy. So for us as Minister of Health or as professional councils, our role is to guide on the recruitment and positions of these specialists. Thank you.
Thank you. We shall get one more from Dr. Lenywa and then Dr. Lukanda, and then we shall wrap this up. Thank you. Just a quick one, as you can.
Yeah, just a quick one. I think some of these questions is going to, as a government, and the minister is here, as a people, that we need to look at these policies. Because for us to develop, sorry about my voice, and grow, we need a healthy population. And we need to start all these. I think one of the objectives, I didn't cram them all, should also include the very question that he's asking. Not only training, but where will these trained people go? So that we take our government, our nation to accountability, that together, health is a priority, agriculture and everything is there. So Trump has brought it to our face. I wish he told the people 60 years ago so that I come and find when people have changed. But it's here for us now that anything is possible. We ourselves can work together. COVID showed us when people were asked to give, to contribute. People came up to contribute. And as long as accountability goes back to the people, they will support. So together, we need to work on this. This panel probably cannot answer that question. Even probably the minister doesn't. So it's going to take all of us to go back to the drawing board. Thank you.
Thank you. Dr. Lukande.
Okay, not all is gloomy. I'm trying to get back to Dr. Lukoma's concern about the stipends. There is something good that is happening so far, and I think the minister here can bear me witness, and also the ED Mulago. There are students who are receiving a stipend. And personally, as a trainer, I'm thankful that now we see motivated trainees. I didn't have an opportunity to get a stipend while I was training, but now I'm happy that these trainees can get something. The important thing, of course, even as the stipend comes, these people should really do the work. The person with the right attitude. And probably after then, the minister may increase.
Thank you. Thank you. Thank this panel. And let's remember the vision of HOSU is no one should die of cancer. All right? Thank you, everybody. Let's thank the team, and over to you, my MC.
Ladies and gentlemen, let's give them one more round of applause. Oh, no, it's yours. I could tell that was a very polished panel. Of all in my entire life experience, that has been the most calm way to ask for a salary increment. Yeah, that last submission, top notch. I'll ask us to just stand up very briefly, because I've seen some of us have started listening with our eyes closed. So let us please just be up and standing very briefly, and pick a neighbor, because this is what we're going to do. We're going to need 2 people. Pick a neighbor. Or if it's complicated, pick 3, make it at least 3 people. Now, while you're standing with your neighbor or your trifecta, please share. If you are not a doctor, what profession would you be? So the media team and the rest of us, you can sit this one out, because you're not doctors already. If you are not a doctor, what profession would you be? All right. Now I am going to ask. Let's listen. So if for people who say, if they are neighbors, if your neighbor told you something around engineering, be seated, take your seats. If your neighbor told you something around engineering, take your seats. If your neighbor told you something around accounting, take your seats.
And I may need to assist the MC. He has not told us what he would be.
Well, I am not qualified for the question because I am not a doctor. But if engineering, okay, accounting, they are seated. Music or in anything within the creative arts. If your neighbor told you something within the creative arts, be seated. Oh, okay. So a lot of you wanted to be artists. All right. If your neighbor told you something that is completely outside the education, like outside conventional education, please put up your hand. Food. Okay, the guys of food, please be seated. So a lot of you wanted to be in the creative arts and cook food. Anything? Yes? Do you want to go there? But now that, okay, the ones who wanted to take a career in politics, please be seated. All right, over there. Yes? Yes, you. Oh, pilot. I should have mentioned that one. Okay, pilots, please be seated. I'm wondering, what did your neighbors tell you want to do? Yes, please. A priest. Okay, let's all be seated. All right, ladies and gentlemen, we are coming close to the end. We have just a small discussion that we're going to have. So I would love to invite Dr. Bogere and Dr. Odiambo Clara to come and lead us through a discussion, very insightful discussion around research, innovation, and development. So ladies and gentlemen, let's put our hands together and welcome Dr. Bogere and Dr. Odiambo Clara.
Thank you, Master of Ceremonies. And as he said, my name is Clara. We welcome you to this plenary discussion on research, innovation, and development. As we all know, cancer research is very important, and it's an element that enables us to generate evidence that can support planning and effective implementation. There are many forms of research, but I will not go there. Allow me to invite our panelists this afternoon. Dr. Nixon Nionzima, Head of Research and Training at UCI. Please make your way to the podium. Dr. Rose Nakasi, please make your way to the podium. Professor Francis Sally, Deputy ED of JCRC, please make your way to the podium. Miss Helen Opolot, representing the Executive Secretary of UNCST, kindly make your way to the podium. Dr. Andrew Sechitoleko, CEO Nsambia Hospital, please make your way to the podium. Okay, as we have said, our plenary discussion is on research, innovation, and development. Panelists, you are welcome. I will give Dr. Bogere an opportunity to ask us some questions.
Thank you very much. I think I'll begin by asking Dr. Nixon. Incidentally, Dr. Nixon asked me, my first question at Uganda Cancer Institute, he's the one who asked me the question, so now I'm here to return the favor. So, Dr. Nixon, as the head of research and training, I know you love capacity building. Of course, my first question would be about capacity building. How can HOSU, probably an UCI, build capacity for research and innovation in Uganda? And if I'm to even be a bit more specific, how do we increase local funding? Funding without strings attached. We saw what happened in the recent past. Everyone who was doing research right now is not what? Is not settled, including the NIH. If the NIH is not settled, how about HOSU that we are launching today? So how can we build and improve local funding? It's not that it's not there. At UCI, I see people donating sugar. They donate needle. They donate bed sheets. They donate wheelchairs. It's not very common that locally people come to donate to research and innovation. What could be the problem?
Thank you, Dr. Boger, for that very insightful question. And I'll begin by sort of referencing a question that I got earlier this morning. One of the people attending this conference asked me, this symposium asked me, why don't we have gene therapy available in the market in Uganda? And my response was that the approved therapies for sickle cell, gene therapy for sickle cell, is about $1.6 million to $3 million per dose. And her other question is, why don't we build human resource capacity in Uganda to actually have gene therapy for sickle cell in Uganda? Which brings me to your question, that for us to answer the questions that truly matter for us as Ugandans, we need to build different capacities, and one of these is actually human resource capacity. We need to train the right kind of people to harness the science that is available. So, like was mentioned earlier, it's a multidisciplinary team. You need clinicians, you need lab scientists, you need epidemiologists, you need social workers, social scientists, so you need everyone. The challenge, however, is for the most part, we've only focused on the clinical aspect. That when you come and you say, I want to be a researcher, I want to train in clinical trials, you have to look for your own money. Even the clinical teams actually have to look for their own money for training, but the focus largely in recruitment and retention plans has been on clinical workforce. But the clinical workforce works with the research team. You need laboratories, you need laboratory scientists, you need every kind of personnel. And that's why we need to work together with our ministry and with advocates to actually advocate to have these kinds of personnel within our structure, but also funded and recognized by the government of Uganda. Secondly, we need infrastructure. One of the biggest challenges we have is actually research infrastructure. When you look for a CAP accredited lab, when you look for accredited biobanks in Uganda, especially for cancer and hematology, these are non-existent. We're trying to build some capacity at the Uganda Cancer Institute, but it's going to take time. And that's where HOSU and the other partners in cancer and hematology actually come in, that we can work together and build national infrastructure that can be accessed by any researcher in the country who wishes to do research on cancer and blood cancers, on blood diseases. And that takes me back to the question about sickle cell, that why can't we have the gene therapy in the country? I'm very happy Dr. Sali is here because maybe he will tell us about what they've been doing at JCRC this week, what they launched at JCRC this week. But to be able to do gene therapy here, we need GMP manufacturing facilities. We need a lot of laboratory infrastructure in this country to be able to, one, innovate those therapies. So you need to fund research to innovate those therapies. But also if they are patented or they are on the market, you need a GMP facility to produce the therapy. And this also goes for immunotherapy, that you need GMP manufacturing facilities. So we need a lot of research infrastructure in this country if we're to change the outcomes for cancer and blood diseases. And it has to be funded by the government of Uganda. If we're going to depend on donors, as Dr. Bogere has said, donors also fund their interests. So not every donor is going to come and fund what the government of Uganda is interested in. So for us to answer our questions, we need to fund our own research infrastructure. And I'm happy the government is actually beginning to realize this. If you're aware, Makerere University and most of these universities are actually now getting an innovation and research and innovation fund that supports research that's generated by their employees, by their staff. So the hope is that this can extend beyond the universities to the hospitals and to other research institutions. One of the ideas, I think, is we need to have a replica of the National Institutes of Health within our Ministry of Health. That is a department that is dedicated to identifying research and funding research and promoting local innovation, where a Ugandan who has an idea can actually apply for a research grant and get funded, get pilot data, and publish this, or have an innovation that can be used in our hospitals. Thank you.
We'll move over to you, Ms. Opolot, representing the UNCST. As an institution that is mandated to regulate research, you know, some therapeutics in cancer have been extracted from plant material, as we all know. And the communities are able to identify this, and they continue to use them. Needless to say, they have cytotoxic effects. Many of these molecules haven't been tested, and they have not even been prescribed for human beings. How can we work with scientists? You know, Dr. Ekiria really emphasized the need of bringing herbalists on board. So how can we work with scientists not to stifle innovation, but also to protect the community, you know, against some of these dangerous therapies?
Thank you very much for that question. As you note, Uganda National Council for Science and Technology, in this journey of research regulation, we don't work alone. We work in collaboration with the National Drug Authority. And in the aspect of your question, I think National Drug Authority is really an ideal institution to handle the aspects of drugs. But we as UNCST work with the National Drug Authority to see that all the systems that come to regulation of drugs, be it the conventional or the herbs, is done in the right way. So we have a research regulatory framework that consists of research ethics committees. We have the animal care and use committees, which facilitate the research processes. So before someone proves that their therapy in traditional medicine is going to work, they have to go through that. And National Drug Authority has those guidelines for research in herbal medicine. And we also have the Chemotherapy Institute in Wandegea, led by Dr. Nambatia. We work closely with them. And for all kind of such herbal medicine, it has to go through the right regulatory processes. So I think with such an established and robust process of having research that UNCST has established, we can have research in herbal medicine, and it can really facilitate hematology and oncology in the country.
And just briefly, Ms. Opolot, some people may not be aware of what your role as UNCST is in research, but how do you support scientists, in advancing healthcare, those who are here amongst us? How do you support us in advancing all this?
Okay, so UNCST, some of you are aware that we are the clearinghouse for all research in the country, and we have established systems, like I've said, the ethics committees, and particularly for oncology and hematology research, which overlaps the gene therapy research. We have the National Biosafety Committee, we have the institutional biosafety committees that we encourage institutions that are conducting such research to establish. Particularly the Cancer Institute has an IBC. They also have a research ethics committee, which facilitates the research that is conducted at the institute. I also implore the Zambia hospital that works together with the Cancer Institute to establish one, the IBC especially, since it also works with such pathogens that really need the Institutional Biosafety Committee. The UNCST also develops guidelines for the country to facilitate research. And if Dr. Sali remembers, they had the first gene therapy symposium. And at that symposium, the UNCST informed the stakeholders that we are in the process of establishing a national guideline for gene therapy research in the country. So I'm happy to inform you, our stakeholders, that UNCST conducted the research, and we have the findings ready. And I think this is the right audience. We are going to inform you in March. We are going to give you an invitation to inform you about the findings that we got about the perceptions of using gene therapy in the country. The general perception was the country is ready for a regulatory framework for gene therapy in the country. So further details will be given to you in March.
Thank you very much. I think I'll take on the next one to Dr. Nakasi, the AI specialist. Of course, we know that AI is being used globally now. There's no place that doesn't have AI. And I would like you to tell us really a brief about the challenges and opportunities for using AI in cancer management, and those ethical concerns that we should be that we should look at when we are adopting AI in cancer research. And I think the ethical concerns right now are the things that make people a bit jittery. How far should AI go in cancer management? How far should AI go in research? Can I write my MEd thesis using AI? Would you give me a degree? Thank you.
Thank you very much, Bogele, for the engagement. Once again, I'm Rose Nakasi from Makerere College of Computing. I'm an artificial intelligence expert, specifically in health, and currently I do lead the artificial intelligence in health laboratory at the College of Computing. Further to that, I also lead a topic group under the WHO, WIPO, and ITU focus group, Artificial Intelligence in Healthcare. It's an honor to be part of this society, oncology and hematology. It goes back again to the multidisciplinary kind of collaboration, and I think this is a good step for involving different expertise from different domains, and we see how we can come together to bridge the gaps in our healthcare system. And I think on top of that, we should have membership also coming in from the ICT. That is just Kalango. Back to the question on artificial intelligence, I know that a big community here may not necessarily be from the computer science domain, but to put body to what artificial intelligence is, and then I'll dig deeper into the opportunities in healthcare, specifically in hematology and oncology, but also the challenges that we face currently that have been highlighted already in the research space. Artificial intelligence is a branch of computer science. What it really does is that we are able to train computers, what I would call machines, to be able to analyze and learn patterns out of data. So what that means is that we really and much more rely on the data, and then the algorithms are able to pick out patterns out of that data that are specific to a condition that we're looking for. And then once it has learned those characteristics or patterns of the objects that we're really looking into, then it can be able to make predictions. So what that really helps is that if I've trained a model, an artificial intelligence model, to be able to learn, for example, characterizations of malignancy over a big data set, that means it has been able to learn the characteristics of that particular object that I'm looking at. When I bring any new test to this model, it is able to predict it very fast, consistent, but also with improved accuracy. What does that then mean in health, specifically in cancer? One of the challenges we've looked at, and I think it was highlighted by one of the speakers, that when you look at the number of experts, especially when it comes back to the context of Uganda, you'd find that the ratio of patients to specialists in the country, not only in the country, but also in the region, is very big. And I think the projection was 3,000 patients against one expert. What that means is that either some of the patients are not going to go with a diagnosis in a particular day when they actually need it, but also the burden that comes onto the specialist is very huge. So how does artificial intelligence then come in to support in some of those limitations? We want to usually advocate this as a decision support. So where we have so many patients for cancer coming at a particular healthy facility looking for a correct diagnosis, can we be able to rely on the capabilities of artificial intelligence to support the pathologists, the oncologists, or any other person who's related to that particular condition be able to quicken the way they do the work that they are supposed to do, but also giving them enough, time to be able to give more extra time to their patients, and that, I think, is one of the objectives that we're looking at here, to be able to improve the quality of life. In terms of opportunities, I think that is one major thing that we've done at the Artificial Intelligence Health Lab. And we've been collaborating closely with the Uganda Cancer Institute and the College of Healthy Sciences. It all began from understanding what are the standards in terms of, either diagnostics, treatment, or patient care. We want to really replicate that, but in a more faster and more consistent manner by capabilities of artificial intelligence. It goes beyond just looking at diagnostics, and I think that is the core, as we have been listening to the previous speakers, that diagnosis is what will determine the treatment and later on the care that comes after that. What artificial intelligence, as part of the opportunities, is that it may not necessarily stop at the the diagnostics, to be able to look at, for example, a histopathologic image and be able to analyze it. But then how do they report? We know that after the pathologist has been able to, analyze the slide, it will then go further to the reporting. The information that either goes to the patient or to the person who is going to give the treatment and further care. So again, artificial intelligence, as part of the opportunities that we want to leverage on, is that we are automating that process to be able to provide quicker interpretation for the reports. We know that as we look at care for the patients, we want to look at the context of our patients. Some of the patients may not actually even know English, and in which most of these reports or interpretations are given. So again, by the capabilities that come with artificial intelligence, we want to be able to communicate to them, because communication is one of the core aspects, I believe, when we're giving care. So we're trying to be able to communicate to them in languages that they do understand, and as part of the use case, we've already done that for Uganda, and a scale-up is in the pipeline. We've heard of cancer boards and how they really are able to, for example, if they have a very complicated case to discuss, we are in different ecological systems and environments. So again, telehealth platforms that are powered by artificial intelligence come in so handy. First of all, to give an opinion to which the experts can be able to draw attention to, but also to guide them. Not only that, having them discuss a case remotely or wherever they are. So those are some of the capabilities that come with artificial intelligence. The other question was, what are the challenges? Of course, we've heard about challenges that come and associated with artificial intelligence. And I think those are some of the ethical concerns that come up to propel the different biases that come with the artificial intelligence models. One of the aspects that we want to advocate for is not only using artificial intelligence, but ethically proven artificial intelligence models, I think, should be the way to go. What that then means is that we want, in whatever process for generation of those models, we want to incorporate in an aspect of responsibility and auditing, so that if there is any bias that may sprout out of the data, because sometimes it comes actually from the data. In computer science, we have garbage in, garbage out. Whatever you give the model, if it has bias, if it has errors, then don't expect any miracle at the end. So it, again, stems from all the entire pipeline, and we are doing this by way of having always the experts in the room. Because as computer scientists, there may be some aspects that we may miss out, but then the expert is able to, look out for that. One of the participants up here said that cancer is very diverse. Just relying on one image may not necessarily be the end to all means of whatever decision that is going to be done at the end. Sometimes I may need the clinical data, I may need the, the slides, I may need the history of the patient. So can we, as we're building artificial intelligence models, be aware of all those processes so that we are looking at ethically and responsible generated models? When it goes to ethical, of course, we do comply with most of the ethical guidelines. That is to go through the IRBs, the Ministry of Health clearances, and the UNSSD, and I'm glad that we have been involved in those engagements. But more so to it is that the solution, whatever it is, has to be for the well-being of the patient. So as we develop these artificial intelligence models, can we, before we put them out there, be able to answer any questions that are either not related or not putting the patient as a priority? And then once we answer all those, then that is when we shall say that there is accountable artificial intelligence, but then also responsible artificial intelligence. Thank you.
A lot from you, Rose, there. I knew the discussion on AI was not going to end soon. But swiftly, moving to you, Professor Sally. Kindly highlight for us, in the briefest of moments, some of the breakthroughs you've registered in research of hematological conditions at the JCRC.
Thank you very much. Perhaps I need to correct, I am not employed by any university, so I'm not a professor. I am one of the doctors like you. In the field of hematology, hematology is a very exciting field. It's one of those fields that is a frontier science in medicine, as it were. At JCRS, we've been looking at, we're doing a number of studies, but one of the things we've been looking at is to see if we can get a cure to some of the currently, the diseases that we've not been able to get a cure to. Some of these are genetic disorders, like sickle cell disease. Another hematologic disorder is hemophilia. And then infections as well, chronic infections, even HIV itself. And we've been trying to explore the frontiers now of gene therapy. I think it's a big thing. As I told you, we are not going to be the first to do it, but like for gene therapy for hemophilia, we already have a product. It's not our own product, but it is an adenovector-associated viral vector product. And it delivers a payload that can correct the hemophilia defect within the liver cells. So, and where it has been used in the trial, where it has been used, the participants have been able to get from like less than 1% factor activity to, sustainably, a majority of them to more than 40%, and being able to get rid of the need for regular hemophilia factor injections, and also being able to get rid of the risk for bleeds. So I think that is transformative. The other aspect, I'm sure you had, there was a talk about the gene therapy for sickle cell disease. Right now in the world, there are so many clinical trials going on with gene therapies. And most of these are in countries actually which have very few patients with those conditions for which they are doing the gene therapy. And here, where we have the largest majority of patients, if you look at the papers published, if you look at clinical trials going on, the numbers are very, very low. So I think two things are happening in that how we've got involved. We've got involved with a team of other individuals all over the world who are also concerned, and they are interested in access to these life-saving treatments. You heard Dr. Nixon mention that I think one of the gene therapies for sickle cell disease is $1 million, which even in the Europe or even in the US, you must have very good insurance or be part of the NIH program. But there are so many reasons why that cost is up. First of all, there are few centers where cells are processed. So one has to collect cells by apheresis, keep them alive, feed them, and ship them several thousand miles to the center where they are going to be worked on and transduced. And some of the cells lose viability, so they have to collect a large number of cells. So those are the things that have been driving the cost very much up. But there are new technologies that are emerged. I think the earlier technologies you've heard about are using the CRISPR-Cas enzymes. These are enzymes that are used to dissect DNA and deliver the correction of the gene product. The other one is using lentivector. These are like ghost viruses. You get like an empty shell of an HIV virus, which can't infect, can't survive, can't cause disease. But viruses are very efficient at delivering genetic material into cells. So they are being used, and even adenovectors are being used. The CRISPR-Cas was borrowed from bacteria because bacteria use plasmids to share genetic resistance material. And so these are what is happening. I think just a few weeks ago, we got hold of some very new technology which is going to use microbubbles to do the transduction. And what it's going to do is that the cost is going to move from the $1 million you've had to about $10,000. So we're very optimistic that within about 2 years, we should be able to get even the sickle cell disease trials going on here.
Very exciting future, very exciting for HOSU as well. Of course, last but not least, Dr. Andrew Sechitoleko. I think my question to Dr. Andrew is, he's in a position that I think as doctors we are not very used to. He's the head of a faith-based hospital. You know, as doctors, we tend to sometimes be, how should I say it?
Ghost virus.
Yes?
Ghost virus.
Ghost virus, yes, that's what they said. So how do you, or how do we balance scientific advancements and religious beliefs when introducing these new treatments? They are telling about gene therapy, and yet they tell us we are perfectly and wonderfully what? Made. How do we then have these conversations where scientific advancements and religious beliefs are in harmony? An imam or a bishop will stand here with Dr. Nixon presenting his p-values, and both of them will nod and say that, yes, that is true what you have said. How do you do it at Nsambia? Because I know there's research that is being done, but also the faith that is there is also going on well.
Thank you. I didn't see that jab coming. I thought I'd sat here in my role as a physician or something. Anyway, the first thing I want to say is that, you know, faith is part of our society, and everybody where they sit has a belief they profess. And then very many times when people fall sick, faith comes to the forefront of what they are thinking. but also these institutions that are faith-based were the first to introduce medicine in the country. And they've nurtured even the public system over time to become the providers of healthcare. But to put it simply, well, Jesus healed the sick. And he made it important to know that suffering was not meant to be permanent. And that's what faith believes, that suffering should not be something that we stay with. It must be alleviated one way or the other. Somehow he didn't cure everybody. He left some for us to treat. To talk to faith leaders many times, we have to make our message relevant. And relevant means to address the things that are affecting society at a particular time. Today, cancer and the discussion we're having here is something every imam, priest, and leader will understand that is a pertinent problem of society. So it must be relevant. Number two, we must simplify this message. When we researchers speak, we sometimes confuse people. Yesterday I was in an argument of absolute, you know, when people are giving statistics, and someone says there's 30% chance of it raining today. What does that exactly mean? Is it that it will rain in 30% of the area? Is it that 30% of people who analyze this might be correct? So how do we interpret science results? So it must be simplified to them, and the message must be that's something they understand. Otherwise, if we exaggerate, as many times research tends to do, it might paint a picture of a gloomy situation, yet actually the problem is a minor problem. So we must make it relevant. And lastly, applicable. Applicable means affordable and accessible to everybody. That way, even the bishops then listen to us many times when we ask them to put a budget for research. Thank you.
Well, I told you. So I think we can accommodate a few questions before our lunch. They've told me 2 questions. Yes, Dr. Fadil Geriga.
Hello?
Would like to record you on our cameras.
Yeah, thank you. Mine is coming from a background of an observation that I see as a challenge. A few years ago, one of our colleagues, Dr. Kwaro, wrote his book. And the book, one thing he highlighted was less than 5% utilization of some of the research work done in Makerere. I want just to inquire what advice will the panelists give to this baby called HOSU in trying to do it different in this country, that when we talk about research, it's not just for having good lunch at the end of it, but it will have to be implemented. Thank you.
Thank you very much. My name is Benjamin from Metropolis. My question is too much of pathological, especially to Dr. Nixon. We're in a situation where we all know pathology is bread and butter when it comes to treatment, but it's unfortunate that locally here in an African setup, pathological tests are very expensive tests. So as people who have been in this field, how do we plan to make sure that even when most of these high-end tests are not available locally, how do we make it affordable to everyone who really need it for treatment? Otherwise, when we find it's not affordable, there's a large number of people who are going to find themselves not getting or benefiting from the better treatment for better diagnosis. Do we have a plan for private-public partnership to make sure these high-end tests can be affordable? Do we have a plan of making sure we bring locally the high-end technologies, especially the fish, the flow cytometry, and making sure they can be implemented locally for everyone to benefit, just like my mother deep in the village, to benefit locally without putting too much cost in it? Thank you.
Absolutely. Thank you for those questions. We'll allow our panelists to answer. Whichever red button can go on.
Dr. Nixon, how do we use the research that we want to do?
Thank you, Bogere. Yes, so the question of less than 5% of research is utilized. Maybe the first question is, was that research relevant to the entity where it was done? So many times, where I sit, you find students and their supervisors write research proposals. They come to you, we need administrative approval to conduct this research at the Uganda Cancer Institute. And I'm sure it's the same with other hospitals. But nobody has made an assessment of whether the research you're doing is relevant to the entity where you're doing the research. That's the first issue. The second issue is, what are the costs of implementing the recommendations in that proposal? So one, we need to do research that is all involving, collaborative. You work with the people who are going to implement the research so that it's important to them. But also we have to factor in the implementation costs. And implementation costs come from the institution planning deliberately to actually change some systems, some things that are to be identified, and it requires us to actually work together while we're developing these research concepts. Many of the research concepts that we write, NIH makes a call or somebody makes a call and you apply for a grant. And there's nothing wrong with applying for a grant. I also apply for them. But you're answering the questions they have set for you, which may not necessarily be relevant to the entity where you're conducting the research. So those are some of the challenges that I see, and I'm sure we have encountered many of these things. Now, to the question of pathology, Benjamin, this is a very, very good question, and I don't know if Dr. Lukande is still here, but he touched a bit on this, that pathology needs to be accessible, needs to be affordable, and it's not just pathology, but the diagnostics. You cannot treat cancer without a diagnosis. So the CT scan, the MRI, the lab diagnosis, the pathology need to be affordable and accessible. When I started medical school, I think the only pathology available in the country was at Makerere University. And that time they were doing about 12,000 tissues per year for the entire country. But we need to democratize or decentralize pathology so that it's available at the lowest levels. Why does somebody need to do pathology in Kisoro, in Arua, and then wait 2 months to get a diagnosis? But also we need to deliberately invest in pathology services, in diagnostic services. For most of our facilities, we invest in purchasing the drugs, but we don't invest in making the diagnosis. But I'm happy to tell you, Dr. Byanyima has talked about this, that Mulago is setting up a specialized lab that is going to support diagnosis. Cancer Institute is doing the same, that some of the technologies you talk about, flow cytometry is available at the Cancer Institute, but we need to make flow cytometry more affordable. Sequencing, PCR, all these technologies are actually available within Mulago, different entities. But I think for HOSU, it's to make sure that these entities are actually coordinated, that we work together to make these services available and accessible. It doesn't make sense for Mulago to do one flow cytometric analysis a year, and Cancer Institute is doing one. Can't we combine and do two so that they are cheaper? You have economies of scale. But also looking at which entity is best placed to do some of these services. And the other issue is, of course, human resource. If you look at, for example, hematopathology, we have less than maybe 2 or 3 hematopathologists in the country. You have a population of 46, 47 million, and all the hematopathology slides either are coming to a general pathologist or are waiting for that one hematopathologist, who is going to be expensive because, I mean, the demand is enormous, but also may introduce delays. So yes, we need more investment, but also need to train people to actually handle these services. And to make an advert for the Cancer Institute, which I work for, we actually deliberately investing in laboratory diagnostics. And we hope that by the end of this year or early next year, we're going to have a lab that has what we want to term as every test for every cancer patient. And by cancer patient, even hematology is included. Thank you.
Thank you. Some parting shots, Dr. Andrew.
So I wanted to pick it from the guy from Metropolis to say healthcare is not cheap. It's very expensive to train a doctor. It's very expensive. The technology we are using in health is very expensive, more than most industry. Sensitive and expensive. Research in healthcare is expensive. The infrastructure we have to put is expensive. And we're hoping to pay this out of pocket somehow. So let's intensify the debate on healthcare financing. We must find ways, smart, innovative ways to pay for healthcare. The rest of the world is solving this by healthcare insurance. The minister was here, and 2 years ago, she promised us at the HIHA Awards that the bill was closed, and it seems to be getting, further away. But maybe we don't have to answer this with healthcare insurance. We have to, the word innovation and research now must go into healthcare financing. And I respect people who are trying to bring the costs down. Dr. Asali has said the cost for gene therapy is coming down. That's good, but that person is having to sacrifice something. I don't know. I'm thinking maybe to do what they have to do to get what they have to get, they have to put in a lot of investment. And somehow, okay, the faith-based thing comes back. Healthcare providers, we have been looked at as the people who can charge little. Anytime, I go to a lawyer, I'm given a $200 bill for an hour, and you tell a patient 20,000, they're like, you guys are expensive. Why is it that healthcare is always made to look the one that must be begging? My parting shot.
I hear it's a calling. Absolutely. Thank you, Dr. Andrew, for your parting shots. Yes, Dr. Sally, as we conclude in the next 2 minutes.
Yes, I'd like to make a comment. Borrowing from the HIV experience, when we started antiretroviral treatment, it was costing about $2,000 a month. And only very few people here could sustain it for 6 months. But just the global scales, global economies of scale, there are so many countries that are importing from one manufacturer at one time. And this has been able to bring down the cost of the medicines. It has not been so much for most of the lab equipment, but for some of the lab tests, like viral loads, which were like more than $200 a piece, they came down to about $5. And why? Because Uganda, Kenya, Tanzania, all of us buy in bulk from one place, and then we bring these consumables to our populations. And I think we need to get to borrow the similar models even for the cancer diagnostics. Otherwise, currently, it is more expensive to diagnose it. For a hematology patient, for instance, to make a very pristine diagnosis, it's much more expensive than the treatment, what the treatment is going to cost. Then for the dissemination of the information, I would really propose that we get a journal for this, for the society. Because all of us subscribe to very different journals, we have different readerships, and we may never be able to know, to collate what actually goes on. And I think it will be a very good source of information for guidance, for guidelines and everything. I think it will be a very good start.
Thank you, Dr. Sally. At this juncture, allow me to thank all our panelists, Dr. Sally, Dr. Sechitoleko, Ms. Opolot, Dr. Nakasi, and Dr. Nionzima. Thank you very much. Thank you, audience, for all your questions. Baby HOSU, you have been born to the world that is full of trouble, but you will overcome. Thank you.
Let's give another round of applause to our panelists and the moderators. There's a proverb I came by during COVID, and it went something like this: a meeting without lunch should just be an email. So, to make sure we are not worthy of just an email, in a bit we're going to have lunch, but there are some special recognitions that we want to make that have made this day possible, that have been very, very instrumental to this journey. So I'm going to invite my co-MC to come and make them. But as we head out for lunch, and she's also going to direct us on how we're going to go for lunch, please remember our sponsors have different booths right outside the room. So as we are making our way to the lunch, right outside the room, please pass by the sponsor booths. There's some things that are exciting, probably even prizes that you could be able to grab. So please make your way to the sponsors booths right outside. So right about now, I invite my co-MC to make the recognitions and tell us how we're going for lunch.
Okay, thank you very much. I would like to recognize the presence of Dr. Ruswata Herbert, the president of the Uganda Medical Association, is here with us. And we would like to recognize Dr. Jane Farrell, the past president, COSEXA. She's also the head of the Uganda Medical Council. So you're welcome. And when we're giving awards, we talked about individuals that have contributed to this field of hematology and oncology in Uganda and the entire region. So there was an individual that was missed, but Dr. Orem and Professor Charles, they'll be here to give this award. The individual is Professor Harriet Mayanja Chiza. Kindly, Dr. Rem, you'll come to give out. And in her absentia, Dr. Sekaja Christine will be receiving the award. Yes, Professor Ren is giving the award, and our Dr. Rem is assisting. He's giving us the support. Thank you so much for accepting. Yes, this is for Professor Harriet Mayanja Chiza. Well, thank you very much for being a great team as we start this new chapter. And it's the right time. We are going to have lunch for 40 minutes. As we walk out of this room, we are going to use this, both the exits. We'll be getting our coupons, and we move to the left towards the restaurant is Kololo Restaurant. So they'll be directing you at the door. Kindly let's keep time, 40 minutes, and we are back. So that means that at 2:50, we are back to the room. Thank you so much. I've been assured that our items are safe in the room. But if there is something so precious that you really can't
afternoon. I invite you to put your hands together to welcome Dr. Nixon Nyozima.
Thank you, MC. So we're going to two very exciting sessions, and this is real science. We're not talking about now launching. We have launched, we have grown. Now we're going to begin seeing the fruits of the growth and the launch of HOSU. And we have two sessions, one on breast cancer and another on prostate cancer and improving oncology patient care. So breast cancer is, as you know, most of you, and I can't talk about breast cancer when Dr. Fowler is here, but breast cancer is the second commonest cancer in Uganda. And we'll have a number of sessions looking at the latest trends in management of breast cancer. And I've been informed that we're starting with the online session, which is supposed to start precisely at 3, the international session. And the format is going to be, we'll have the presentation, then the presenters will come and sit up here, and then we'll have one round of questions to a number of speakers. So we'll have several speakers presenting, and then they'll sit up here, and then we'll have one round of question and answer. So our first session is on Faslodex, the new standard of care in the management of hormone receptor positive, HER2 positive metastatic breast cancer. And our presenter is virtual. I'll ask the ICT team to put up this presentation for us. Please take note of your questions, and then we'll have one round to answer all the questions. And as that is happening, we'll have Dr. Bogre also get ready to talk about HER2 negative metastatic breast cancer. This is about HER2 positive metastatic breast cancer. But I'll ask Dr. Bogre to get ready as we put this up on the screen. And we're going to try and redeem time. For some people, somebody has prepared flowers, has prepared dinner. We need to make sure that people are able to make the dinner. We also have a Valentine's prepared for you. I hope it will come in time. Yes? Dr. Falal has already got his, but we want to make it extra special. ICT team, are you ready? Or we start with the first presentation, with the first physical presentation? Okay, so the first presentation is from Dr. Ahmad Shah on hormone receptor positive, HER2 positive metastatic breast cancer. Dr. Shah, please go ahead.
Thank you so much. I really appreciate to be today with my colleagues from Uganda. It's really a pleasure to be together in the important of the launch of the Hematology and Oncology Society of Uganda. It's really a pleasure, and unfortunate that I'm online, but next time I would love to come to Uganda and host other colleagues from Uganda as well. So I would like to thank AstraZeneca for giving me the opportunity to discuss with eminent colleagues from Uganda today about the first line hormone positive HER2 negative metastatic breast cancer, maximizing the outcomes with the Faslodex, and how I claim that it is the preferred standard of care. So this is my disclosures. And I would like to remind remind everyone with the hormone positive HER2 negative metastatic breast cancer, the treatment goals that we look every time to have for our patients. Definitely, we are not talking about cure, but we are talking about survival. So the aim is to live as long as possible with the best of quality of life for our patient, to do the maximum disease control and to maintain or improve the quality of life of patients and to prevent serious complications. And to do this, we need to have an improvement to the response to the endocrine therapy that we have, prolong the duration of the progression-free survival, and delay start of chemotherapy. Doing though using evidence-based strategy on tumor biology to choose the most effective treatment approach. And really, I think that our goals, everyone, is to make our patient journey safe, comfortable, and easy. So what the guidelines states, in patients who are first-line hormone positive, HER2 negative metastatic breast cancer, giving chemotherapy will not add to patients. So endocrine therapy is the mainstay, except in the presence of the rapidly progressive disease. And thus, all the guidelines, the NCN, ABC, and the ESMO guidelines, even in the presence of visceral disease, you start with one endocrine therapy, go for the first line, then to have some response to go for the second line and the third line. And at the end of the day, when it is refractory or a rapidly progressive disease or symptomatic, you need to shift to the chemotherapy. Or if the patient is visceral crisis from the start. And really, it's a definition that it is very wide, and according to the ABC consensus, that it is considered as the severe organ dysfunction that is assessed by signs and symptoms and laboratory studies and the rapid progression of the disease. And another parameter which is important is to define the sensitivity to endocrine therapy. So typically, the majority of the patients will start on, after finishing their adjuvant therapy, is to have the adjuvant endocrine therapy. If the recurrence happens within the first 2 years, then we call this is de novo resistance. And if the recurrence happens 3 to 4 years, then this is what we call the acquired resistance. If after 1 year of finishing the adjuvant endocrine therapy, this is late recurrence, and this is typically in the endocrine intensive, beside those who are first to present without any prior therapy. This definition is arbitrary. It can be changed with the extended adjuvant therapy. However, this is when we define the treatment goals that we have for our patients in the first line therapy for the metastatic breast cancer. What's happening in real life, despite every guideline says that the endocrine therapy should be the mainstay of treatment, you can see even in Western societies, patients can receive chemotherapy, and the main co-founding factors is to have younger patients, those who have less comorbidity, and those who have visceral disease. So even in Western societies, they tend to give them chemotherapy. But unfortunately, this is having a detrimental impact on the progression-free survival and on the overall survival of the patients. So you think that you are doing good to the patients, but that's not the true. It is actually you are making more harm to your patients. So should we blame oncologists? Unfortunately, due to the treatment paradigm that we had till the 2010, actually what we were there with the tamoxifen or the AI, the maximum of the 3 AIs have superiority over the tamoxifen, but actually they didn't exceed the 12 months time to progression or progression-free survival. And that also has been shown to have no impact on the overall survival, with the maximum of a median overall survival that can we get of 34 months. So what actually is the most effective single agent? So this is a question that comes to up. So we all know that we had tamoxifen, then we moved to the AI, until we have the selective estrogen receptor degrader, which is the fulvestrant. But unfortunately, in the early clinical trials, the suboptimal dosing of the fulvestrant on a 250 milligram showed no difference in response, progression-free survival, or overall survival when compared to the anastrozole or the exemestane. And that was shifted till we have the full dose, the higher dose, which is the 500 milligram. But let's revise how the fulvestrant have an evolving story and treatment landscape change. Actually, we know that the majority of hormone positive, those who are endocrine positive, will have the androgen receptor as being the main stay for treatment. The fulvestrant has a dual mechanism. The first of them that it combined competitively binding with the estrogen receptor, and it's 100 times greater than the affinity of the other endocrine drug classes blocking the estrogen binding. But also it has another area that it goes to the acceleration of the degradation of the endocrine receptors. So that means it reduces the estrogen receptors, and that will have an impact that those treatment can overcome those who became an androgen independent folk. So reviewing this, as I mentioned earlier, when the dose was 250, what you can see that the low dose has no desirable effect, no study drug level, and that's why it showed that it didn't show the activity. When the introduction of the day 14 mechanism, but still with a lower dose, you can see that there is a desirable effect, but the steady drug level is not there. However, in the confirmed trial, and that was in subsequent lines, when you start with the 500 milligram at day 0, followed by the 500 milligram at the 14th day, and that's what we call the loading dose of the fulvestrant, continuing by the day 28 and every month to have the 500, then you achieve a standard dose and having a desirable effect and steady drug level. So actually moving this from the hypothesis into the second line, into the first line therapy versus the aromatase inhibitor, and this was a phase 2 trial, but it's a proof of concept when fulvestrant was given in the dosing of the 500 milligram intramuscular on day 0, 14, and 28, and every 28 versus the anastrozole with a primary endpoint clinical benefit rate. It showed the approvals based on a trial that it met the primary endpoint. However, here I'm sharing an info that those who didn't have a prior endocrine therapy was actually having a standard of an overall survival of 54 months. So now we are observing an increase in the survival in those patients. However, that moved the famous phase 3 trial of the Falcon that enrolled postmenopausal women with hormone positive, HER2 negative, advanced breast cancer with no prior endocrine therapy to be randomized to either the fulvestrant or the anastrozole in a phase 3 trial. And that was a double-blind phase 3 trial, primary endpoint, progression-free survival, and secondary endpoints is the OS, the overall response rate, the clinical benefit rate. And to do stratification versus locally advanced versus the metastatic and prior chemotherapy for the metastatic breast cancer and to have a measurable disease. And you can clearly see that the trial met its endpoint with a median progression-free survival gain in favor of the fulvestrant, and you can reach up to 16 months. But then trying to identify in a certain subgroups what worked better. If you see on the right side, those who are with the without the visceral disease, you can see that the fulvestrant have a median progression-free survival over 22 months. And that was the first time to see such enhancement in the progression-free survival. And that was a remarkable that those patients who are naive from endocrine therapy and actually having bone disease or no visceral disease can have a progression-free survival over 22 months. And bear in mind this this progression-free survival is it comparable to the progression-free survival that we see with other molecules. But unfortunately, this is not the reality always. Usually, the majority of patients goes with the endocrine therapy in the early breast cancer setup, and then at some point they were recurred. And 67% approximately of patients who relapse on after endocrine will have endocrine resistance. And you need to understand how this is very important to see it, and you can see that it is associated with poorer prognosis. The Italian group from randomized clinical trials for adjuvant phase 3 randomized clinical trials try to assess the impact of endocrine resistance on sensitivity on the overall survival. And they enrolled in this study 6,600 patients. And you can see clearly how dramatically is the fact that you see that how dramatically there is an impact on the survival based on the endocrine sensitivity. And you can see that it drops down to 27 months in those who are primary resistant, or 38 months on those who are secondary resistant. But actually, then it comes up that we understand that it is not only endocrine therapy or E2 dependent, and actually, we need to think of those factors which is E2 independent. And that's the ESR1 mutation and the ER phosphorylation which happens. So here it plays the third itself when it being combined, the fulvestrant, when you combine it with the endocrine therapy to have this alteration for the treatment. And again, for patients who are for patients, I'm sorry for this delay. I guess that there is something in the connection. But anyhow, that's... Yes? I guess it's now clear. Can you hear me clearly?
Yes, we can hear you. Please go ahead.
Okay.
And now we can see you without the slides. ICT, is there a problem? Yeah, sometimes these kinds of virtual presentations, you have hackers and all those things. So as we advance, they also advance, and some of these are challenges that we have to be prepared for. But I hope it's getting resolved. Please share the slides again and go on the presentation. I think the issue has been resolved. In the interest of time, I'll ask the ICT team that we proceed as we rectify this. So in the interim, we're going to have also a virtual presentation from Dr. Mariam Mutebi, who is a consultant breast surgeon at Aga Khan University, and she has a recorded presentation. And after Dr. Mutebi, Dr. Bogere Najib will give us the local context of management of hormone receptor positive, HER2 negative metastatic breast cancer.
Ladies and gents, distinguished guests, all protocols observed, it's truly an honor to be with you today, albeit virtually, to celebrate this very auspicious occasion. My name is Miriam Mutebi, and I'm a breast surgical oncologist based at the Aga Khan University in Nairobi, Kenya, and the president of the African Organization for Research and Training in Cancer, AORTIC, which is the largest continental body that is dedicated to changing the face of cancer control in Africa. As we gather here today in the vibrant city of Kampala, it is essential to acknowledge that cancer knows no borders. Whether it's in Uganda, Tanzania, Kenya, or any part of the world, cancer impacts individuals and communities alike, demanding our collective action, dedication, and expertise. This launch provides a vital platform for all of us to come together, share knowledge, discuss innovative solutions, and make progress in the fight against cancer. Cancer is a growing challenge across the globe, and East African countries face unique obstacles in combating this disease. I think, however, there is a tremendous opportunity to transform how we approach cancer care in our region. The launch of the Uganda Society for Hematology and Oncology, HOSU, reflects both the challenges we face, but really our vision for the future. Proper training of healthcare professionals is the cornerstone of improving cancer diagnosis, treatment, and care. And we must ensure that our doctors, nurses, laboratory technicians, and any healthcare workers who are involved in cancer control are adequately prepared to handle the growing number of cancer cases with expertise and compassion. Furthermore, I think innovation plays a crucial role in transforming cancer care in East Africa. So it would be useful to look at how we can leverage technologies, whether it's telemedicine, precision treatments for patients, in order to ensure that irrespective of where they are, all our patients have access to equal care in a timely fashion. We do know that we have faced significant challenges regarding health infrastructure, access to essential medicines, and some progress has been made in early detection and treatment. But we do know that despite these efforts, a significant number of our patients are diagnosed with advanced disease and often do not complete their care, which is why, as an East African community, we must prioritize initiatives that enhance access to care, raise awareness of prevention, and create health policies that are responsive to the unique needs of our countries. No single organization, government, or institution can tackle the cancer crisis alone. Collaboration is key to overcoming the challenges we face, and the AORTIC has been dedicated to fostering partnerships with governments, international organizations, the private sector, and NGOs. And I strongly believe that together we can mobilize the necessary resources, share knowledge, and advocate for policies that improve cancer diagnosis. Throughout this meeting, I'd encourage everyone to share their experiences and expertise, and by collaborating across sectors, think about how we can find and develop innovative solutions that will ultimately benefit cancer patients in our regions. I don't think it's a coincidence that this particular launch is on Valentine's Day, because I think I would urge each of us to think about cancer advocacy being our love language, where we keep patients at the center and we think about how we can reflect on the patient journey and how we can amplify how we can continue to amplify this across our different settings to ensure that each individual patient has access to safe, timely, compassionate care. On behalf of Aortic, I want to thank everyone again for your commitment to this cause and for your participation in this critical launch, but more importantly, your continued dedication to the need to improve care for our patients. May this event serve as an inspiration to us all, and may it be, the beginning of renewed determination to strengthen the training of our healthcare professionals and drive innovation in our fight against cancer. I would like to once again extend a warm congratulations to you all and to invite you to our biennial conference that is happening in November this year in Tunisia to continue this conversation. From Aortic, we are pleased to see the launch of HOSU and looking forward to continuing to work together to really impact lives in our setting. Thank you all for your attention.
So Dr. Mtebi has emphasized the point that's Valentine's Day. And I have a team ready to re-emphasize the point that it's Valentine's Day. So for those of us, I hope I'm not one of them, who have nobody to buy flowers, HOSU has bought some flowers, please accept them. So each one of us is going to go home with a rose. If you have to explain where you got the rose from, please call me. I am ready to give the explanation of, and I have video evidence of where you got it from. Dr. Bogere, please come and give us the local context unless we are ready to continue with the other presentation. Are we ready? What we are seeing is Dr. Kakungulu, and I'm sure he's not the one presenting. Okay, so we're going to continue with the presentation. We can see you and we are ready to resume.
Can you allow me to share my slides?
We're not yet seeing the slides, but let's allow you to share. Please allow him to share his slides. Okay, so we can see your slides. You can go ahead.
Okay. So as I was stopped here, that the other modality is to have the combination of the endocrine therapy and the other molecules, including the mTOR inhibitors, the CD4/6 inhibitors, and the PI3 inhibitors. So revising the data about the CD4/6 inhibitors in combination with the fulvestrant or aromatase inhibitor. So in the endocrine sensitive, it showed that the CD4/6 inhibitor in combination with the AI have a marvelous response that was actually in the data for the Paloma, Mona Lisa, and the Monarch, whether you combine the AI with the Palbo, the Ribo, or the Abema. But as well in the endocrine resistant, and that's very important to show that the integration of the fulvestrant in combination with the Palbo, Ribo, or the Abema showed a similar hazard ratio ranging from 0.46 to 0.59. And actually, this is the first, again, increase of the overall survival that has been shown with the Ribo and to the lesser extent with the Abema and the palbociclib at the lesser extent, whether in the first line or in combination with the endocrine resistant. And you can see clearly that there is an enhancement of the overall survival whether in the first line or in the second line. Again, in the second line, when the palbociclib when the CD4/6 inhibitor is combined with the fulvestrant. And that's even thought through when combining the CD4/6 inhibitor and the fulvestrant plus a PIK3CA inhibitor. And actually, as you are all aware, that PIK3CA mutation is relevant of approximately 30 to 40% of the hormone positive patients have the PIK3CA mutation. And clearly, what this does, that definitely the meta-analysis of 11 clinical trials of patients with hormone positive, HER2 negative, the OS, the median OS will shorten in those patients who have a PIK3CA mutation. And you can see that the integration of one of the PIK3CA inhibitors can actually enhance the treatment outcomes. And that's led to the integration of the CD4/6 inhibitor plus the palbociclib plus the fulvestrant. And clearly that was a marvelous response that was presented in the New England Journal of Medicine 1 year ago. And you can see clearly that the enhancement of those median PFS up to 15 months. And there was a trend that was seen at the first presentation at the San Antonio, but again that we have a very recent newsletter showing that the trial also have an updated overall survival, and probably it will be published in the upcoming ASCO. And actually, that will result to my take-home message that clearly what we have observed in the evolution of the treatment therapy for endocrine sensitive population, the tamoxifen was only providing of 8 months. The AIs in the sensitive population of a median progression increased up from 14 to 15 months. The fulvestrant alone in the intent to treat is from 16 to 18 months. If you consider the bone-only disease, it's up to 22.3 months. And if you combine the AI plus the CD4 case, you will have almost the similar progression-free survival. Even though in those, if you integrate the fulvestrant plus the CD4/6 inhibitor in the sensitive population of the Mona Lisa trial with the ribociclib, you can see that there is an integration of approximately 3.36 months of a median progression-free survival. Similarly, the resistant part, you can see that the exemestane will only give you 3.4 months, but the fulvestrant will give you 6.5 to 9.3 months, and the fulvestrant plus the CD4/6 inhibitor plus or minus the Inavo will have a progression-free survival of a 9.5 to 16.4 months. So ending with 2 case presentations, there is a lady that was treated in March 2016 where it was diagnosed. She was a left breast cancer patient, pathological T2N1, grade 3. She received, underwent surgery followed by adjuvant chemotherapy and radiotherapy and received 5 years of adjuvant anastrozole. Back in May 2023, she had only CT bone scan, small lymph node and bone metastasis that was having a bone biopsy that was confirmed to be endocrine positive HER2 negative. And the question at that time, what would be the preferred? I guess what I showed you, that the subgroup of the bone-only disease of the falcon can have an advantage, and you can go with the fulvestrant because this is a sensitive population. Similarly, if this patient have a treatment relapse after only 4 years, so this is a secondary resistance, and actually what you will give to this patient is definitely the combination of the fulvestrant and the CD4/6 inhibitor. So there's now the standard of care, and that's actually the fact. And thank you so much for your time and listening.
Thank you, Dr. Ahmad, for this wonderful presentation. Please, if you have any questions, write them down. I'll have the question and answer session at the end of all the presentations. And at this juncture, allow me to invite Dr. Bogere. Dr. Bogere is going to give us the local context of management of hormone receptor positive, HER2 negative metastatic breast cancer. It's really not, I think it's just an overview of what we're doing here in Uganda in relation to the global standards. Dr. Bogere?
The slides, please. Those are not the ones.
Dr. Okuku, I hope you're getting ready. I've seen your name as we look for Dr. Bogere's slides. We wanted to finish all the breast cancer presentations and then very quickly, yes, so this is Dr. Bogere.
All right, welcome back everyone. The way I'm going to approach the presentation, we'll just present what is ideal, what we are doing now, and probably where we are hoping to go. And yeah, this is a sponsored session, but as already said, that if a patient comes in with metastatic breast cancer and it is hormone receptor positive, chemotherapy is now going much lower. We want to begin with endocrine therapy and a CDK4/6 inhibitor. At the Uganda Cancer Institute, I know we have tamoxifen, anastrozole, letrozole, exemestane, which is the endocrine therapy, and they are also available on the open market. The CDK4/6 inhibitors like palbociclib, ribociclib, and abemaciclib are not yet available at the Uganda Cancer Institute, but they are available on the private market. Now, the price now has started going down. It's, I think, around $200, $300, thereabout. But the first line is endocrine therapy, CDK4/6. So in absence, I think right now, because most of our patients present with rapidly progressive disease, they get upfront palliative chemotherapy, and then endocrine therapy is given probably after the visceral crisis has reduced. If a patient progresses on the endocrine therapy and CDK4/6 inhibitor, if they have no driver mutation, you switch to an endocrine therapy and another CDK4/6 inhibitor called ribociclib. And then if you don't have those, you can give still endocrine therapy with everolimus. We have another mTOR inhibitor at Uganda Cancer Institute called temsirolimus, and I think that's what they're using now. Then, of course, there have been new trials of elacestrant, and then chemotherapy. I think that's what we do at Uganda Cancer Institute. Then, if they have a PIK3CA mutation, fulvestrant and either alpelisib or capivasertib. Then, if they have other driver mutations like BRCA, we can give them olaparib or talazoparib. Talazoparib is available at the Uganda Cancer Institute, free of charge. If they have an NTRK fusion, larotrectinib or entrectinib, that one is not yet available, even on the open market. And if they have microsatellite instability, we give them immunotherapy like pembrolizumab. Beyond that, we give them single-agent chemotherapy because the treatment is palliative, or TDXD. TDXD, I think, currently is not yet on the open market, or sacituzumab govitecan. I'm going to skip these slides because they were presented, but we wanted to just, in this slide, wanted to just demonstrate why people are moving, why we are moving towards endocrine therapy and CDK4/6 inhibitor, especially now that the price of the CDK4/6 inhibitors has started dropping to nearly the prices of the chemotherapy. When you look at column number 3 with ribociclib, patients who are postmenopausal in the first-line setting and they were metastatic, they got ribociclib, and the hazard ratio was 0.76, and it was statistically significant. That was in the Mona Lisa trial. In the Monarch 2 trial, we had some patients with first line, and some few patients on second-line treatment. Majority were second line, some were first line, but you can still see the hazard ratio was statistically significant. If you look on the second last column from your right, still ribociclib, fulvestrant, and ribociclib with any of the AIs or tamoxifen was also associated with greater median OS and a better overall response rate. There's a trial that was done, and this was presented in last year in ASCO. This was done in, you would say, not very low income setting, but it was done in like Mexico, so not very rich as well, where they got patients who were the typical patient that we get in Uganda. And the reason we wanted to present this trial is because maybe then we should take a step back and think about how we treat our patients now. Their median age was 44 years old. Our median age when we did retrospective chart review was about 46. 78% of the patients had visceral metastases, and 52% were fit the definition of what? Visceral crisis, and 67% had symptomatic visceral metastasis. So these looked like patients that we see at Uganda Cancer Institute. And there was one arm where they gave them ribociclib and endocrine therapy, and another arm where they gave them combination chemotherapy, of which one of them was capecitabine with docetaxel. There was single-agent docetaxel, vinorelbine. There were different types of chemotherapy, but you can see clearly that in the chart A, that the progression-free survival was better in the ribociclib and endocrine therapy arm compared to the combination chemotherapy arm. And when you look at this plot on your right, you can see that ribociclib and endocrine therapy was favored in most of these patients. The only, I think, patients who didn't respond so much were the patients who had estrogen receptor status less than 50%. But in most of the other parameters, ribociclib and endocrine therapy worked better than combination chemotherapy. Resistance to these drugs is very common. Here, I just wanted to show you that resistance is in two ways. It is either estrogen receptor dependent or estrogen receptor independent. If it's estrogen receptor dependent, of course, then you go for drugs that still target that pathway, things like fulvestrant, elacacentrant, and then if it's independent, then you go for the other molecules. And when patients progress most times on endocrine therapy, you ask yourselves, what do you do next? There was a trial called the Maintain trial where patients who had progressed on a CDK4/6 inhibitor were given another CDK4/6 that was ribociclib and fulvestrant. And we can see on the chart A that the progression-free survival was better in the ribociclib with fulvestrant compared to fulvestrant with placebo or AI with placebo. So if a patient progresses on first-line endocrine therapy with a CDK4/6, you don't immediately have to rush to give them what? Combination chemotherapy. What this means is that slowly but surely, treatment for endocrine receptor positive, hormone receptor positive breast cancer, chemotherapy is taking a more, even in metastatic settings, it is taking a further step behind, and endocrine therapies are coming closer, and yet we know that the toxicities that they have are slightly less than the ones that they have on combination chemotherapy. The other patients, another trial that tried to test treatments in patients who had progressed on first-line treatment with endocrine therapy and a CDK4/6. These ones added, they gave fulvestrant, palbociclib, and avelumab, which is immunotherapy. And you can see that in the green line is above most of the lines, that patients who are given the combination of fulvestrant, palbociclib, and avelumab fared much better than the other arms. We can see that the other arms really are nearly mirroring each other. So when a patient progresses on endocrine therapy and a CDK4/6 inhibitor, this gave us the signal that probably it is a study that would be very good at the Uganda Cancer Institute. There are very many ongoing trials in patients with hormone receptor positive breast cancer, and I'm happy to say that I think one of them, the last one, Lidera, we have participants at the Uganda Cancer Institute who are enrolled in the clinical trial. We hope to wait to get the results, but it shows that the landscape of treating hormone receptor positive, HER2 negative breast cancer is changing, and chemotherapy is slowly but surely taking a more reserved, or is being phased out, if you would say. This was a summary, but I'll skip it. But in summary, this is what we've talked about, that in the first-line setting, we should be using endocrine therapy with a CDK4/6 inhibitor, whether a patient has visceral metastasis or not, unless the patient is worsening very fast. And this, because the audience also has people in the private setting, then it means that even the practice in the private setting should start changing, because at least at Uganda Cancer Institute, we can say that maybe some of the drugs have, the CDK4/6 inhibitors haven't yet been introduced. But then what would you tell the patient in the private setting now that the drugs are available on the on the open market? Thank you very much.
Dr. Bogere, please don't go. Please sit up here. People may have questions for you. The stairs are the other side, unless you want to jump over. But I think one thing that Bogere has highlighted is the need for standardized protocols across the board, that whether in the private sector or in public sector, the patient needs to get the best care possible. And so one of, I think, the responsibilities we need to give to the Hematology and Oncology Society of Uganda is to develop standardized protocols that anybody in Uganda can use to manage patients. At this juncture, please allow me to call Dr. Kuku Dr. Cook is a consultant medical oncologist at the Uganda Cancer Institute, and will be telling us about the role of Zoladex in breast cancer and prostate cancer. Dr. Cook.
Good afternoon, and thank you. We will restrict ourselves to breast cancer. The number of cancers that are driven by hormones, and because these cancers are driven by hormones, we use hormonal therapy to treat prostate, breast, uterine. Those are among the commonest cancers that are driven by hormones. I wanted to interest you. We have the oldest cancer registry in Africa. I think, is it 60 years? Jackson, is it 60 or 59 years now? 60? Almost the age of the Cancer Institute, or the age of the medical school probably. So every 4 years, they publish data on cancer trends in Uganda. And my interest today is to show you breast cancer. Okay, I hope you can borrow an eye of faith so you can see those graphs there, but the main point here is to show that the trends of breast cancer are on the rise, and just like prostate cancer, we do have an annual increase of more than 3%. If you compare that to cervical cancer, which is the commonest among women, you may find that there's a decline in cervical cancer because there are many mechanisms of fighting that, including vaccine. But for breast cancer, we expect that cancer to go up in the next few years and probably become the #1 cancer among women in the next few years. So breast cancer is of interest. We cannot talk about Uganda without talking about the world. And you can see the blue is the incidence and the red is the mortality. So incidence is simple, it's the number of new cases. And look at Africa. So we have Eastern Africa, that's of our interest right now. You compare that with the developed world, you can see that our burden may not be as high, but also most of our people don't come to hospital, so we may not have the correct picture of our burden. I think many of our people come very late, and so we may not have the correct, but from this data that we have, it shows that probably our incidence may not be as high as in the developed world. But you may note that our mortality is a little higher. So take note of those two. Now let's switch a little bit of gears and focus on endocrine therapy and how did this begin. So it began in 1896, there was an article in the Lancet, and there was a surgeon who removed ovaries of a 33-year-old lady with metastatic breast cancer, and she responded for about 42 months. At that time, they did not know why that had happened. But that was the beginning of the connection between the hormones playing a role in the growth of tumors. And this is the whole journey, how scientists have developed hormonal treatment over the many years. We've just heard the previous speaker talk about fulvestrant. Now let's focus on Zoladex. This molecule is the cornerstone of treatment of prostate cancer. But it has a role in treatment of breast cancer. And that is our focus today. So it is a synthetic agonist, a natural occurring luteinizing hormone releasing hormone, which results in suppression of your ovaries. So the ovaries are the equivalent of the gonads or the testes in a man. So while the testes produce the androgen hormones, the ovaries produce the estrogen hormone. And this molecule has extensively been researched in breast cancer and has been licensed for treatment of breast cancer. And it's given on a 28-day for the 3.6, but we also have the 10.8, which is a 12-week interval. So it has a role. It's used in treatment of premenopausal women with estrogen-positive breast cancer. So for those of you who are not familiar, when we get a patient, we take a biopsy, and that is taken to the lab. We expect two types of results from that. We call that the histopathology. So we expect a confirmation of the cancer, and most times we will get an invasive ductal carcinoma, which is the commonest type of breast cancer, histologically. And then we expect what we call a breast profile. The breast profile will give us three, at least for now, three main categories of disease: the estrogen receptor, the progesterone receptor, and what we call the HER2, or otherwise referred to as the human epidermal receptor subtype 2. That is the complete breast report, histopathological report. If we do not have the breast profile, we will not know how to treat the patient. For this case, we are interested in the estrogen mainly, because most times 80% of the positivity is with the estrogen hormone. Progesterone does not play a big role. So we are interested to know what is the estrogen profile of the tumor, and those are the only patients who will respond to this molecule that we're talking about today. So it suppresses the ovaries and also may protect this during chemotherapy. So when you shut down the ovaries of the young ladies while they're on chemotherapy, we may preserve their fertility. Most times, women who are in the late 30s or 40s, once they get chemotherapy, they go in immediate menopause. And so this molecule may play a big role in that. So this slide, just to tell you how it works, hypothalamus from the pituitary down to the ovaries. This is a summary of this slide. And of course, as I've mentioned, it provides an effective alternative to oophorectomy. So the first slide I showed you, they did a surgery to remove the ovaries. But this is a good alternative to oophorectomy. Our radiation colleagues also do apply radiation. They can burn off your ovaries. I don't know whether, Dr. Lutu, you still do that practice? Looks like it's outdated. So radiating the ovaries is outdated, and we prefer to use this hormonal treatment to achieve that. So it has a role in pre- and perimenopausal women with advanced breast cancer. It's well tolerated. No withdrawals due to its possible adverse reactions as expected. The estrogen suppression can lead to those effects: hot flashes, loss of libido. But despite that, it provides an effective, well-tolerated treatment for women with advanced disease. It's preferred to use it together with another agent, another hormonal agent, and in this case, we're talking about tamoxifen for these young ladies. And the data as shown here, it shows that we have a very good median follow-up period of over 7.3 years. There is no drug without a side effect, and it does have some side effects. Most of our men with prostate cancer complain of a heat wave, and the ladies do get as well a heat wave, but I'm told ladies tend to get moody more than men. I think probably it hits them a little more than men. Arthropathies, these hormonal agents, whether being used in breast cancer and prostate cancer, do have an effect on your bones. And so arthropathies, joint pains, so we tend to supplement with calcium, and vitamin D supplementation is a must when we are on these treatments. This is an analysis, meta-analysis of several trials comparing the efficacy of this agent and tamoxifen, just to show that it's significantly greater when it's combined with tamoxifen. These are trials. The Zebra trial was designed, randomized. It was open multi-center trial where they gave 3.6 milligram of Zoladex every 28 days for 2 years, compared with CMF, combination of chemotherapy that we commonly use. CMF was either given orally or IV. And these results, as you can see, demonstrated that there was superiority, that the human or the hazard ratio was below 1.2, demonstrating that Zoladex is not inferior to the chemotherapy combination in terms of overall trial, overall survival. Is our hacker still on? Okay. I think in conclusion, we want to emphasize that there is fast induction of amenorrhea in young ladies when you use Zoladex. There are higher rates of amenorrhea, and that's what you want to achieve when we are treating hormone-driven breast cancer. It's convenient, it's less complicated, and the overall survival and quality of life in the first 6 months is definitely compared to the CMF or the chemotherapy, as emphasized there. I will refer you to the current guidelines of the NCCN. If you have time, you can peruse through that and get more information about Zoladex. Thank you very much.
Thank you, Dr. Kuku. I'll invite you to sit here. Maybe somebody has a question or two at the end. Next, we'll have Dr. Manuel Mansour, who's going to give us a presentation on advancements in cancer care.
Yeah, they do. Okay, good afternoon, everyone. I hope you're still energized from the lunch. So, as I'm waiting for the slides to be projected, so you've listened to 3 different speakers, Dr. Imad, Dr. Bugiri, Dr. Okuku. So, it's all about breast cancer. Breast cancer is among the top 3 cancers in our region in East Africa. It's number 1 in Kenya. In Uganda, I know it comes behind cervical cancer. So we'll try and put in practice what you have learned from the previous speakers. And I'll also use this opportunity to share with you a bit of our experience. So one of the topic of Dr. Bogheri was, where are we now? And I think one of the answers should be, we are in the era of precision oncology. So, and as oncologists and as the new Society of Hematology Oncology of Uganda, it should be our role and our duty to not accept a lesser oncology for our patients than what is happening in the world. And it's our duty to create opportunities for our patients to access those expensive or cutting-edge and innovative treatment modalities. So I arrived yesterday from Kenya, and I didn't come empty-handed. So I came with 3 cases from our clinic that I would like to share with you. And please, I would like to make this session as proactive as possible. Which one is the next? All right. So case 1, RMI. RMI is a 50-year-old lady. She has no comorbidities. She had her menarche at the age of 12, menopause at the age of 45. She has 2 children. She breastfed both of them, 2 years each, and from both sides. No contraceptive pill use, no alcohol or tobacco use, no family history of cancer. She presented with self-detected breast lump 7 months ago, quite a classic scenario in our setting. On examination, she had a good performance status, and there was a 3 centimeter, 6 o'clock left breast mass with no skin or nipple discharge. So there was also a 1 subcentimeter palpable axillary node, no supraclav node, and the rest of the exam was unremarkable. So we gave it a clinical staging of T2N1. T2N1. So this is her mammography. As you can see, there was a 3 centimeter, 6 o'clock mass with speculated margins and a solitary prominent left axillary node. So this was given a BI-RADS 5, highly suspicious for malignancy, and the right breast was unremarkable. So we went ahead and did a biopsy that has confirmed that this was an invasive ductal carcinoma, grade 3, ER strongly positive, PR positive 10 to 20%, HER2 score 0, so was negative, and Ki67 was low, 5 to 10%. We went ahead and did the CT scan staging since the patient was node positive and there was no features of metastasis. So RMI was discussed in our breast tumor board that happens weekly, and we've decided to offer her breast conservative surgery and axillary lymph node dissection. And the final pathology came as PT2PN1. IDC grade 3, ER 90 to 100% positive, PR 40 to 50% positive, HER2 negative, and the low Ki67. Now, the largest tumor dimension was 3 centimeter, LVI were present, DCIS was present, and margins were clear. So out of the 10 lymph nodes removed, 1 lymph node was positive with macrometastasis, and there was no extracapsular extension. Question to you, what should be the best next step? Should we consider, you can just raise your hands, should we consider adjuvant endocrine therapy? No one. Adjuvant radiation and adjuvant endocrine therapy? No one. Please, I want you to treat the patient. So adjuvant chemotherapy followed by adjuvant radiotherapy and endocrine therapy. Node positive, I would give her chemo. Yeah, I can see 3 people agreeing with me. Or we do an Oncotype DX to guide the next steps. No one agrees. Oh, 2, 3, okay, perfect. So correct answer is Oncotype DX. So we went ahead and did the Oncotype DX testing for this patient, and I'll share with you the data why we did that step. Her recurrence score came as low as 9. So we used the data from the R-Expander trial. The R-Expander trial has looked at patients who have ER/PR positive HER2 negative breast cancer, 1 up to 3 positive lymph nodes, no evidence of distant metastasis, and the patients do not have any contraindication for receiving adjuvant chemotherapy, And they had a proper axillary staging, either with the sentinel lymph node biopsy or axillary lymph node dissection. Those patients were, had their oncotype test done, and then they were randomized. So excluded the patients who had a high-risk recurrence score, because those ones definitely will benefit from an adjuvant chemotherapy. And they kept the patients who had a recurrence score between 0 to 25, and they were randomized into 2 different arms. Arm 1 will receive chemotherapy followed by endocrine therapy, and Arm 2 will only receive endocrine therapy. And then they stratified those patients into 2 different recurrence scores, from 0 to 13 and then 14 to 25, and then based on their menopausal status pre versus post, and the axillary lymph node dissection. Primary objective of this study was the effect of chemotherapy on the invasive disease-free survival, whether the effect was influenced by the recurrence score, yes or no, and then also they had some secondary endpoints, included distant relapse-free survival. So as you can see here on the left side of the screen, the postmenopause, for the postmenopausal patients, there was no added benefit in terms of IDFS of adding chemotherapy for those patients who had 1 to 3 positive lymph nodes with a recurrence score between 0 to 25. While on the other hand, on the other side, so right side of the screen, for the premenopausal patients, there was a statistically significant benefit of adding chemotherapy to the premenopausal patients with a hazard ratio of 0.54. When we look also at the stratified subgroup analysis, so based on the recurrence score, postmenopausal versus premenopausal. For postmenopausal, whether you have a recurrence score of 0 to 13 or 14 to 25, there is no added benefit of chemotherapy. While in the premenopausal group, there was still a statistically significant benefit of adding chemotherapy for both recurrence score between 0 to 13 or 14 to 25. In terms of 1 node versus more than 1 positive lymph node, 2 to 3, same findings for postmenopausal, no benefit for chemotherapy, while for premenopausal, whether you have 1 or 2, 3 lymph nodes, that is sufficient enough to indicate chemotherapy, and unfortunately not include that group of patients in the de-escalation protocol. So conclusion of the RxPonder trial is that if you have a premenopausal woman with 1 to 3 lymph nodes, please do not waste her money, do not waste your time, her time. Don't ask for a recurrence score testing, just proceed, go ahead with your chemotherapy. While for postmenopausal patients, even if you have 1 to 3 positive lymph nodes, you might still find room for sparing them the toxicity of the chemotherapy. So our patient had a happy ending, and we managed to spare her the chemotherapy. She's doing perfectly okay on the endocrine therapy, coming regularly to her follow-ups. Second case, SMA. SMA is a young lady that presented in 2017 at the age of 36 years old with a PT2PN0 M0 breast cancer. The tumor size was 4.5 centimeter, grade 3. It was an invasive ductal carcinoma, ER 50 to 60% positive, PR positive, and HER2 was negative, score 1 on IHC. LVI was present, Ki67 was low, 5%. She had a breast conservative surgery, sentinel lymph node biopsy, and then at that time there was no access to oncotype. So the initial oncologist went ahead and prescribed for her adjuvant chemotherapy, 4 cycles of TC, followed by adjuvant radiation and then tamoxifen. 2021, so 4 years after the initial diagnosis, while she was on her tamoxifen, there was a clinical palpable lymph node, and then I went ahead with a PET CT scan in view of the suspicion of disease recurrence, and the PET CT scan has confirmed nodal and skeletal metastasis. Biopsy showed that this was exactly the same initial primary with ER/PR positive, HER2 negative at a score 1, and Ki67 was low. So what would be the best action plan? Should you prescribe chemotherapy, just single agent taxane? This is metastatic disease with skeletal metastasis. Of course, we will add some biphosphonate. No one wants to give chemo. CDK4/6 inhibitors, ovarian function suppression, and aromatase inhibitors. You can raise your hand. So 2, okay. Capecitabine, it doesn't really compromise her quality of life. No one. Fulvestrant, single agent. No one. So I can say the majority, who was just 2 hands, agreeing on option 2, and that's the correct answer, as you might have seen from the previous speakers. So we gave the patient palbociclib, letrozole, and Zoladex used for her OFS. And as you can see, after 6 months of treatment, there was a good partial treatment response. We continued with the same treatment, but unfortunately, 18 months later, the patient had the disease progression. So what do you think should be, of course, all those steps are discussed in our breast tumor board. So what should be the next best option you can offer the patient? She got CDK4/6 inhibitors and aromatase inhibitors, OFS, chemo, taxane? No one. Capecitabine? No one. Test for genomic alteration? Yes, I can see some hands. Or fulvestrant CDK4/6 inhibitors? I can also see some hands. Okay, so I'm pulling for you the ESMO guidelines, and I'm afraid that it's not very clear on the screen. But as you can see, when you have a progression after CDK4/6 inhibitors in the first-line setting, the next best step is to do your genomic testing. So you need to look for germline mutations, you need to look for some markers of hormone resistance, such as the PIK3CA, the ESR mutation, so that you will be able to tailor your treatment based on that particular patient. So unfortunately, the patient could not afford the test for genomic alteration at that time, so we went ahead and we gave her fulvestrant. So the 2 options were actually valid. Now, for SMA, and for 24 months later, there was evidence of disease progression, but luckily for her at that time, we had few clinical trials for breast cancer at the Aga Khan University Hospital. So, and she was eligible for one of those clinical trials. You might have heard of it, the KRAS G12C trial, where we enroll any patient with metastatic disease looking for the particular mutation of KRAS G12C, because that trial was offering the investigational drug that blocks the KRAS G12C at that time, but then it was open for any type of breast cancer. So we managed to screen 140 patients for that trial, and just to share with you our experience and also update you. So when we screened 140 patients, regardless of the type of the cancer, only 3 tested positive for KRAS G12C. And guess what? 2 out of the 3 were Ugandan patients who benefited from the drug. None of the Kenyan patients benefited from this trial. And then the 3rd patient was an Ethiopian patient. So as you can see, that's why I'm saying we have to be the instigator of creating opportunities for our patients. So those patients, just as an update, benefited from this drug while they had no other option, which has prolonged their progression-free survival and their quality of life. But back to this patient and to many other patients, the other 140 patients, basically when we screened them, majority of them ended up having some positive findings. So for example, for lung cancer, we managed to pick up few mutations for some of the patients, and we adjusted our treatment accordingly, and it was a life-changing game for those patients. For this patient in particular, we managed to identify the ESR mutation. Remember, this is, as was presented by Dr. Ahmed, this is really the standard of care. You should test for it so that you can tailor your hormonal treatment for those patients. I managed also to rule out any BRCA mutation, any germline BRCA mutation for this patient, so I was really able to plan my and tailor my treatment plan based on her genomic findings. So ESR mutation, as you might know, we have a new drug, which is elacestrant, that is FDA approved for those patients after the use of fulvestrant or without the use of fulvestrant. And this has, the FDA approval has come up through the EMERALD trial that has shown a benefit in the progression-free survival for those patients. Elacestrant, just as an introduction, is a new molecular non-steroidal selective estrogen receptor degrader that is usually used in the ESR mutation setting or even without the ESR mutation setting. And the EMERALD trial, the primary endpoint endpoint, which is the progression-free survival, has doubled. It might look a bit minimal because of the patient selection, and then it came after several lines of treatment. But as you can see in the new guidelines, the use of those selective estrogen receptor degrader is increasing. So we offered her ESR1 mutation, we offered her the use of elacestrant, but unfortunately the cost was significantly prohibitive, so she couldn't afford it. And as you might have heard from the previous speakers, we should not jump into chemotherapy unless you exhaust at least 3 lines of endocrine therapy. So for this patient, the next line that we offered her was everolimus and exemestane, and she did a very good 6 months period under this drug. She's a young lady who has a managerial role in her company, so she was really able to be productive in the society, productive at her family setting, take care of the kids and everything. So after the use of everolimus and exemestane, she progressed again, very good quality of life. And remember, I told you she was HER2 negative, but 1+ on IHC. And we got the recent FDA approval of Enhertu, trastuzumab deruxtecan, in this setting. And because the patient was successfully promoted, she got a better insurance, and now currently she's receiving Enhertu. And I know those drugs are really significantly expensive, and this is a call for the pharma company that is here, and I know Enhertu is one of AstraZeneca products, which is being launched in Kenya and hopefully in the region. But then also we are really working together with the pharma company to make sure that we have access program for our patients, and of course we'll update you once this happens. So also another happy ending for the patient. She still has an excellent quality of life, still being productive at a family level, but then also at the society level. Third and last case, NA. NA is a 27-year-old lady. She has no comorbidities, menarche at the age of 12. She was premenopausal. She has 2 children that she breastfed, and she didn't use any contraceptive pills, no alcohol or tobacco or any high-risk behavior. She had an older sister that had breast cancer at the age of 40, and she presented with a self-detected breast lump while breastfeeding. On examination, she had an excellent performance status, and there was a 4-centimeter breast lump, 9 o'clock, no skin or nipple changes, and there was an ipsilateral axillary node palpable. No supraclavian node felt on the exam, and the rest of the exam was unremarkable. So we gave it a clinical T2N1. And we went ahead and did a core biopsy. It was an ERPR negative, HER2 negative score 0. Ki67 was significantly high, 70 to 80%. So this was in keeping with the triple negative breast cancer, IDC, grade 3. And the CT scan was negative for any skeletal or visceral metastases. The lymph nodes were also suspicious and present on the scan. So discussed in the tumor board, we went ahead with the neoadjuvant dose dance protocol. She received 4 cycles of AC and 12 weekly paclitaxel with an excellent clinical response. Next step was to offer her a breast conservation surgery. So we offered her genetic testing at that time, but it was out of reach. So we went ahead with breast conservative surgery and axillary lymph node dissection, adjuvant radiation. For your information, she had a complete pathologic response, and she was on her follow-up. A year later, as part of her follow-up, the PET scan picks up a right hilar node and the left upper lobe lung nodule. Biopsy confirmed, unfortunately, that this was a TNBC recurrence. So what should be the next step? Should we consider taxane-based chemotherapy as a first-line treatment, triple-negative breast cancer? Capecitabine, low disease burden. Yeah, sounds a reasonable option. Gemcitabine carboplatin. No. Or should we test for PD-L1, BRCA1, and 2? Okay, I can see some hands. So that's the correct answer. Before you decide on your first line of treatment following the international guidelines and our local, hopefully once it's published, our local guidelines, we should test for theranostic markers for triple-negative breast cancer. So your first line treatment in the metastatic setting will be guided by your theranostic markers results. So we need to test for PD-L1 to see if the patient is eligible for immunotherapy, pathogenic BRCA mutations, And then if they are both negative, and then you will be able to still tailor your treatment. So for our patient, we did a BRCA gene mutation and it was positive. And for your information, the tests are available at the Aga Khan University Hospital in Nairobi. Turnaround time is just 3-4 days at most. And we can apply, and this will not delay the patient's treatment, but it will actually help you tailor the treatment options and then prolong the survival of your patient and cause unnecessary and spare them unnecessary costs for unnecessary treatments. And for this patient, we have used the results from the Olympiad trial that has enrolled patients who are HER2 negative, so either ER positive or triple negative breast cancer, who had a confirmed deleterious BRCA gene mutation, germline. They received 2 or less prior lines of treatment, and prior anthracycline and taxane were allowed. And then for the patients who are HR positive, they should have at least progressed after 1 line of endocrine therapy. And if the patient received platinum, there should be no evidence of progression while receiving the platinum. And then those patients were randomized into 2 different arms, so 302 patients, either PARP inhibitor or olaparib at the dose of 300 milligram twice daily, or the physician's discretion choice of chemotherapy, or primary endpoint progression-free survival, and secondary endpoints overall survival, quality of life, and objective response rate. And as you can see from the Olympia trial, there is a clear benefit in terms of the progression-free survival for the patients who will receive olaparib versus chemotherapy with a hazard ratio of 0.58. The overall survival was not positive for this study. So in conclusion, precision oncology in breast cancer is the way to go. And as a take-home message, I would just want to wind up and wrap up. For localized HR-positive breast cancers, HER2 negative, there is room for sparing some patients the side effects of chemotherapy. So if you have a postmenopausal patient, even if they do have 1 to 3 positive lymph nodes, you need to associate your clinical pathological risk factors with the genomical risk factors. So Oncotype DX recurrence score calculation might guide you and help you select which are the patients who will benefit from chemotherapy, which are the ones that will not benefit. Premenopausal patients, please forget about it. Lymph node positive, high risk features, you give your adjuvant chemotherapy. But you can still apply the precision oncology for those premenopausal patients if you have a node negative based on the TAILORx study, where you can, based on the risk stratification of the patients, decide whether you need to give chemotherapy, yes or no. Metastatic setting for HR positive patients, there is a lot of role for precision oncology in here, and then as you can see, after a progression on a CDK4/6 inhibitor and AI or endocrine therapy in the first line, and the second line should be guided by your genomic findings. So you can tailor your treatment to offer the best outcomes for your patients based on the findings that you have. If you have a germline BRCA mutation or a PIK3CA, where you can consider alpelisib. If you have an ESR mutation, go for the elacestrant, or there is a new molecule actually that has just been FDA approved recently following the San Antonio updates. So precision oncology does really help us tailor the patient in the benefit of tailor the treatment, in the benefit of the patient. Now for HER2 negative, whether triple negative breast cancer or ER positive, in the metastatic setting, biomarkers will really help us. And those are biomarkers that we can easily access and achieve in our setting. IHC-based, ER/PR negative, PD-L1, those ones we can easily do, together with the germline BRCA gene mutations and the other mutations. But I really need to acknowledge the challenges that we are still facing in the implementation of precision oncology, and this needs to be addressed. And this is really an open call for all the East African societies, pharmaceutical companies, to put our efforts together so that we can bridge the gap in accessing the testing, but then also accessing the cutting-edge medications. And then we really need to have our own African genome to assess the applicability of those studies that most of them have been tried on Western patients, Caucasian patients. And if you look at the subgroup analysis, African patients are actually this minority that might not have been really represented. So just to share with you also one of our studies done at the Aga Khan University Hospital. So we did this analysis of transcriptomes of Kenyan African patients, African American patients, and Caucasian women. And clearly, our genome is different from the African American, different from the Caucasian. So I think this, just to emphasize that it's really overdue. We really need to have our own data to be able to tailor our treatment based on our patients. And then just to wind up, I just want to share with you two photos. Number one is Ons Jabber. I don't know if any one of you is fan of tennis. So this is our Tunisian African best player. And she's very known for her precision drop shots. So she's very precise. I think we have it in our genes as Africans. We can follow the precision and then make sure that we offer the best for our patients. And this is the team. You're just seeing one face from a big team, and including the radiologists, the pathologists, we usually collaborate, put all of our efforts. This is my wonderful team of the Aga Khan University Hospital. And of course, we are happy to collaborate as a region. And please remember, if you want to go fast, go alone. But if you want to go far, go together. So let us please go together so that we can achieve brilliant goals. Thank you for your attention.
Thank you, Dr. Mansour. We are coming to the end. I see some people are tired. Has everybody got a rose? Please raise your rose if you've got a rose. If you haven't got, my team is there. We want to show that while we're here trying to fight cancer, we also have some romanticism within us. Yeah. So we're going to the last presentation. If you have questions, please prepare them. And the last presentation is from Mr. Vike Ashok on partnering for improving oncology care. And we'll ask that the presenters try and summarize their presentations because people are getting quite tired. And we still have a short session left after this. So I'll ask Mr. Ashok to come and give us his presentation, and then we'll go into question and answer.
Good evening, and thank you for giving us this opportunity. I represent Dr. Reddy's, the partner of Adonis. I request all of you to visit our stall. And so I'll be very brief. Dr. Reddy's is the biggest oncology company third biggest oncology company in India. And we have been working with many countries. And if you see, we established oncology quite long ago, 40 years. And we have been working in several countries. As company, we have touched around 700 million patients. And we are one of the best known companies in India. Our strength is on innovative assets, and our core business is generics, biosimilars, and API. And we have been working with different business models in 76 countries, and we have partnered with Adonis to bring several cancer drugs to Uganda. Dr. Reddy's has several partnerships which are successful, and we plan to work to bring several of these partnerships to Uganda as well. Dr. Reddy's is the first Indian company to bring CAR T-cell and cell and gene therapy capabilities in India, and we are working on a multiple myeloma CAR. And we have been working with several innovative assets of our own. And why all of this matters is that like Uganda, India also has a challenge of patient survival. While survival in countries like US is improved significantly because of higher screening rate, earlier diagnosis, and earlier access to innovation, in low resource settings countries, including India, survival is less than 50% in many cases. This remains to be a major challenge, and Dr. Reddy's work to address this in India. We have been working on several key therapy areas like breast cancer, prostate cancer, colorectal cancer, ovarian cancer, and hematological cancer. And we have introduced several brands which have become leaders in India and other parts of the world. And coming to Uganda, we have recently introduced rituximab. Dr. Reddy's is the first company in the world to introduce the first biosimilar rituximab with the brand name Reditex. And it has been approved by the European Medicine Agency. And this is the only biosimilar rituximab which has real-world evidence in pharma publications of more than 12 across the world. And we have introduced lenalidomide with the brand name Linangio now. And Linangio is the brand with a significant brand presence, with significant market share in US. And in the US, this is having the highest amount of market share. The same quality lenalidomide is available now in Uganda. And as a company keen on improving healthcare, we are working to improve screening, and we have partnered to improve screening through a novel technology called thermalytics. And this, we believe, is a way to forward in increasing the screening in other countries as well. And as a company, we believe in improving awareness about cancer, not only amongst the general public, also amongst other specialties, other physicians who practice general medicine, because they are the first portal of entry where patients come with symptoms. And we have done several programs to improve the oncology education, and we look forward to partnering with the association here to create real-world evidence as well as create educational programs. This is a snapshot of our pipeline, which includes several drugs, and we will be soon introducing world's first oral immuno-oncology drug for lung cancer, which is CA-170. And like I mentioned, we are the leader in hematology with the first CAR T-cell therapy, which is going to be available by end of the year in India. And what we believe is that right from the stage of awareness to adjusting to life after post-treatment, there are several challenges. We are working to make sure that we partner at each stage to improve the patient's life, and we have designed several programs. And one of the earliest programs is on the increasing capacity of the team which is working for oncology, which is training for oncology nurses on how the chemotherapy should be prepared, administered, and what precautions must be taken. This is a program which has several modules. We have developed this as a self-learning module, and we are very keen. If the association is interested, we will work with you in this. And we have several digital platforms for medical education. And as Dr. Reddy's and Adonis, we want to partner with you to be part of this educational initiative. And finally, we have created several awareness material of various cancers which can help improve the early diagnosis of cancer. We look forward to working with you as part of Dr. Reddy's and Adonis. And thanks for giving me this opportunity to present to you. Thank you.
Thank you. That was the last presentation. And in the interest of time, I'm only allowing one question per presenter. And we have 4 presenters. So, and Dr. Lutu was the first to put his hand up. So, yes? Dr. Lutu, you specify who you're asking. We also have Dr. Shah online, in case you have a question for him.
Thank you very much, Chair, and thank you very much, all the presenters. To Dr. Bogere Najib, it's really a compliment. It's not a question. When you are presenting, Dr. Najib, unfortunately, I don't know whether you're a good teacher because you didn't look at the students or the participants, but I felt so nice and sweating because this is exactly what I heard last week in Cape Town. Exactly what you talked is what is done elsewhere. Thank you very much. Thank you very, very much. Thank you very much. I got a lot of heat when you are presenting. Secondly, to Dr. Okuku, thank you too.
Dr. Lutu, we are going to be democratic.
Yes.
Maybe we'll find Dr. Okuku after.
It's quick.
Yes.
About Zoladex, the flare in female. Is it the same as the flare for men? And what do we do in female? Thank you.
Thank you, Dr. Lutu. We allow only one question per person. But because the first one was a compliment, we will allow it. Any other questions? Going once? Going twice? In the corner, yes. Deo? Dr. Lutu, that one has voted you out.
Okay, thank you very much, Chair, and thank you very much to all the presenters. Mine goes to Dr. Okuku, and it's about the percentage ER receptor expression. Does it inform choice of giving the Zoladex, or any ER receptor percentage qualifies a patient to get Zoladex as long as they are premenopausal? Thank you.
Thank you, Deo. Okay, Dr. Lutu, since there's nobody else raising their hand, you can ask the final question.
You presented, but a simple question. Case number 1, did the patient receive adjuvant radiation therapy? The 50-year-old with high-risk features. Thank you.
So I think we'll start with Dr. Okuku, Dr. Mansour, and Dr. Bogre last.
Thank you. The heat wave. The heat wave is in Zoladex is due to hormonal imbalance after you get the injection. My experience is from the men. For the men, we do medroxyprogesterone. It's a good alternative to bring down the heat wave. We usually do that based on how bad the heat wave is. If you are sweating too much, I saw a man who was carrying a towel to the clinic. We will tell you to take 10 milligrams 3 times. It's quite effective. If the heat wave comes once or twice in a day, maybe 10 milligrams is good enough. I do not see a lot of that in women. I don't see a lot of that. Maybe Dr. Mansour or Dr. Faulal here will tell us her experience. I don't see a lot, so I haven't prescribed medroxyprogesterone for women. The other question from Deo is about the estrogen percentage and whether that will inform you to give Zoladex. Not really, but I do know that it matters when we are doing the hormonal therapy for women. 10% or less may not be as effective as 100%. But regarding Zoladex prescription, I don't know. Maybe Dr. Mansour, you tell us, because it may not have much impact, really.
Okay, Dr.
Thank
Mansour.
Thanks for those good questions. So going back to the heat wave or the hot flashes, so it does affect the quality of life of our young patients, and it's usually one of the major complaints. But of course, you know, we are not able to give them some hormone replacement therapy because that might increase the risk of having a recurrence. So we usually do a lot of comportamental changes and then physical activity. We encourage our patients to do a lot of physical activities. And usually with time, it subsides. So it's usually bad in the first couple of months, 3 to 6 months, but then the patients will definitely adjust to this new condition. Now, coming to the Zoladex, the ERPR status does not really guide the indication of Zoladex, yes or no, but it's usually based on the risk features of recurrence. So when you have a patient, luminal type breast cancer with high features, such as positive lymph nodes, young patients, 35 years old and around, so based on the text and soft studies, you have to indicate OFS because clearly it improves the outcomes of the patient. Also recently, last year, there was a release of a meta-analysis showing that regardless of the age, if you have a patient who underwent treatment for breast cancer, but then at some point she gets back her periods, OFS actually does help the outcome. So we used to keep the OFS for the younger patients with node positive, high-risk clinical pathological features. But in fact, this meta-analysis has shown that even if the patients are, they didn't, like the chemo did not induce a menopause on those patients and they have back their regular periods, adding an OFS might help actually improve on the outcomes. Now, the question that was directed to me regarding the first patient, yes, she underwent an adjuvant radiotherapy. Maybe if I didn't mention it, it was an oversight from my end, but she definitely received radiation, yeah.
Dr. Bogere, any final comments? Maybe to say thank you to Dr. Lutu?
Yes, thank you very much, Dr. Lutu. And yes, Dr. Lutu is my boss at Uganda Cancer Institute. So good things are coming.
So I think next time you look at the audience. Dr. Fowler, any comment? I think Dr. Cook had directed a question to you. Microphone.
Microphone.
I think I've seen 3 patients with that heat wave. They were all females. But one thing I noticed was the hair change, the patterns of the hair. And you know, they had like drops, the hair completely changed. If you take, for instance, when you have complete alopecia for chemotherapy, those 3 patients had just drops of hair on their heads, and I thought it was quite strange. I don't know if you had the same with the rest, but they did well on exercise, plenty of fluids, and counseling, and they were okay.
Yeah, for the hair, it's really a big challenge for our patients. So initially, I remember in my earlier career in oncology, I used to tell my patients, while talking about the side effects of chemotherapy, that you might end up having a complete hair fall, but then I promise you, you will have a better quality of hair after chemotherapy. But I think with experience and as you mature, I'm no longer promising that to my patients because I know it's not always the case. Some of them will have better quality of hair. So some of the elderly patients, they used to have white hair. Now it grows stronger, smoother, and then it's black sometimes, while the other way around can happen. Younger patients had a completely black hair, thick hair, and then after the chemotherapy, she's struggling to have back her long hair, thick black hair, and it even can grow as white. But hormonal treatment does affect actually the quality of the hair, and sometimes some of the patients, as much as they started having the hair growing back during the surgery, the radiation phase, now you give them another round of hormonal treatment and that affects the quality of the hair. And you know, we are in the era of not, you know, being so happy, saving lives from cancer. We know 80% of our patients will really survive their cancer. So you really want to have them back to their good quality of life. So like the life after the cancer should be as similar as the
pre-cancer life. So there are a few solutions to this kind of patchy hairs, and then those missing hairs in the skull. Some complements can actually help stimulating the growth. Natural oils, castor oil, rosemary oil, olive oil, and then also a bit of minoxidil, and then to help a bit stimulating the growth and the vascularization of the skull will definitely help improving the quality of the hair. I really pay attention to the quality of life of my patients, the quality of their hair, their sexual life. So I usually monitor my patients after the cancer, and I still walk with them that journey with the help of psychologists. We do, with the help also of supportive groups, where people share their experience to, so that they can spread the knowledge on how to get back your life after cancer. Physical activity is really mandatory. So I usually encourage my patients to have at least 150 minutes of physical activity in a week. A diet which is less rich in carbohydrates, and then when I say physical activity, it's just moderate intensity physical activity. Yoga has been proven through studies. Walking has been proven through studies. Meditation also helps. Less carbohydrate and then less processed food. No tobacco, alcohol, of course, but those are like lifestyle improvement that has been proven with solid data to improve the overall outcomes, the overall life after cancer.
Thank you, Dr. Mansour. And I would like at this juncture, yes, Dr. Kuku?
Yeah, very interesting experience. While, the heat wave, while for us in prostate, we have a drug. It looks like in breast cancer, we don't have a drug to prevent the heat wave. Very interesting, because for us, our patients do respond to the medroxy, progesterone, very well.
Okay, thank you, everyone. And I would like us to give a big round of applause to our panelists. So this concludes the plenary session and also concludes the symposium. And I would like to ask our panelists to take their seats, but also to invite Dr. Chibude to take us through the annual general meeting, the first annual general meeting of the Hematology and Oncology Society of Uganda. Dr. Chibude?
Good evening, everyone, colleagues and senior colleagues. Welcome to this special session, the annual general meeting of HOSU. For this session, I know we are time barred. We are going to go exactly to the important items of the agenda. I know we've all read the objectives of this society. They're very important to all of us. I'll give a brief background about the journey of this society over the last 6 months, and then we shall elect members of the Electoral Commission. Will be returning officers, 2 of them, and then we shall receive nominations for each of the following posts. This will include the president, the president-elect or the vice president, the general secretary, treasurer, publicity secretary, and representatives for the different societies or disciplines within oncology. So we shall have representatives from medical oncology, from surgical oncology, hematology, radiation oncology, oncology nursing, pathology, radiology, pharmacy, gynecological oncology, and others. Without further ado, I would like to recognize the key role of specific members who started this effort. We would like to thank the Executive Director of the Uganda Cancer Institute who mentioned the idea of the society, and then I heard it again from one of my supervisors, Dr. Lutu, and then Dr. Dungu. And over the last 6 months, a team led by Dr. Dungu have worked tirelessly to lead us to this day of the launch of this society. Would like to thank members, specifically Dr. Nixon Niyonzima, Dr. Edward Kakungulu, Dr. Benjamin Mwesigi, Dr. Valeria Nabosa, Dr. Joyce Kambogu Balagadde, Dr. Najib Bogere, Dr. Fred Okuku, Sister Rita Bafumba, myself, our sponsors, and you, our dear members who are here to witness the launch of HOSU. Thank you very much. At this juncture, we'd like to nominate 2 members to act as returning officers for the Electoral Commission of this exercise. It can be by show of hand.
Excuse me, Dr. Solomon.
Yes, Veronica.
Yes, before we proceed, we have an issue that has just come in from this end. Allow me to hand in this microphone.
Sorry, it's just point of information. If you notice, this table is full of pediatric oncologists, the 2 tables, and we don't see pediatric oncology and hematology report represented up there. So we request that we have pediatric oncology properly recognized. Thank you.
Thank you very much, Dr. Akulo. Thank you very much, Dr. Akulo and Dr. Lutu. Will include pediatric oncology and palliative care. So at this juncture, I would like to nominate returning officers for this exercise. Yes, Mr. Kadumbula Silva. Noted, thank you. Laboratory is indicated. Okay, thank you. We'll include, we've amended representatives to include 3 additional categories. That is laboratory, medical physics, and radiation therapy technologists. At this juncture, I would like to nominate 2 members who will be returning officers. One will do the tallying and one will do the counting. Any nominees? Dr. James Kafero, you seem to be in agreement. Any other person? Dr. Natukunda, if you're around, please, you can come over. Okay, so returning officers, please, you can take a seat. So at this juncture, the floor is open for nominations for the post of president of HOSU. Members who will be nominated will be requested to briefly stay out of this room. Then we shall proceed with voting. Of note, there's no campaigning. I believe we know these people very well, so there's no campaigning. So nominations are open at this juncture for the post of president. Yes, Dr. Fred Okuku.
Dr. Dungu, Henry Dungu,
who has been our interim chair.
Thank you very much. Nomination has been received of Dr. Henry Dungu. Any other nominees for the post of president? Maybe Dr. Dungu, you can step out, please. Thank you. Dr. Fadil Geriga, you can go ahead.
I nominate Dr. Jackson Orem for the post of president.
Thank you very much, Dr. Geriga. However, the executive director, Dr. Jackson Orem, has declined. There's conflict of interest. Any other nominations? Okay. Dr. Lutu also seems to have declined the nomination. Any other nominations? Yes, please.
Can I please? I thought I was loud enough, but can I please nominate Dr. Rem for the position of the president, since I have no conflict whatsoever?
Thank you, Lisa, for the nomination. Maybe at this juncture we can hear from Dr. Rem to expound his conflict of interest.
I think, Lisa, it is not because of the person, but it is because I originated the idea. Yeah. So again, to be nominated as the first president, that is purely selfish. So that is the conflict of interest. Thank you.
Thank you very much, Executive Director. Any other nominations? The last round of call for nominations for the post of President of HOSU. Yes, Dr. Kafero. I suspect you have conflict of interest. Okay, if there are no further nominations, I think it's the last call for any other nominations for the post of president.
Yes, I nominate Dr. Nyonzima Nixon.
Once again, louder please.
Dr. Nixon Nyonzima.
Okay. Nomination has been acknowledged for Dr. Nixon Nyonzima. Dr. Nixon Nyonzima, kindly step out. Any other nominations for the post of president? HOSU? If there's none, we shall proceed to voting. We have two nominees for the post of president of HOSU. The first is Dr. Henry Dungu, whom you well know. He's a hematologist and senior consultant, physician at the Uganda Cancer Institute. And the second is Dr. Nixon Nyonzima. He's a consultant and head of research and training at the Uganda Cancer Institute. At this juncture, let's proceed to voting. It will be by show of hands. Members, there's no absconding in this type of vote. And remember that it's free and fair. Yes, please.
Hold on, Dr. Nixon seems to have something to say before the voting. Dr. Nixon, are you declining?
No, I am standing down in favor of Dr. Dungu.
Okay. Thank you very much, Dr. Nixon. That has been acknowledged. Without further ado, I think Dr. Henry Dungu is our president for HOSU. Let's welcome him in with a round of applause. Dr. Dungu, please come in. The next post is for the president-elect or the vice president of the society, HOSU. Nominations are open for the post of vice president.
Good afternoon. Thank you for the opportunity. My entire table has agreed that we nominate Dr. Valeria for this.
Thank you very much, Dr. Valeria Nabosa, President-elect, nominee 1, acknowledged. Other nominations for the post of President-elect? Yes, please.
I'm nominating Dr. Clara Odiembo.
Thank you very much, Dr. Clara Odiembo from Zambia. Okay. Thank you for the guidance, Dr. Kuku. Can we have secondments for Dr. Valeria Nabosa? Okay. Those are acknowledged. And for Dr. Clara, any secondments? Okay, noted. Any other nominees for the post of president-elect or vice president? Thank you. If there's none, we shall ask the two nominees to step out, and then we'll go into voting. Dr. Valeria Nabosa, kindly step out, and Dr. Clara. For those who don't know the nominees for President-elect, Dr. Valeria Nabosa is a consultant oncology imaging specialist. She's a radiologist by background, and she's the head of imaging oncology at the Uganda Cancer Institute. And Dr. Clara is a surgical oncologist and head of surgical oncology at St. Francis Hospital in Zambia. Any other nominees for the post of vice president? Okay, if there's none, let's proceed to voting. By show of hands, who of you would vote for Dr. Valeria Nabosa? No abscondment. The returning officers will count independently. Okay, thank you. And then who of you vote for Dr. Clara Diembo, surgical oncologist at St. Francis Hospital in Zambia? By show of hands. It's too late. Members, don't abscond from this exercise. This is our society. Okay. Thank you very much. Voting has been closed for the post of president-elect. Would ask the candidates who are outside to come in and join us. We'll go to the next post, which is the post of General Secretary. At the moment, the floor is open for the post of General Secretary. Yes, Dr. Dungu.
Yes, thank you, Chair.
Yes, please.
I would like to nominate Dr. Nixon Nyonzima for that post of General Secretary.
Acknowledged. Any? Yes, Dr. Kakungulu.
I second Dr. Nyonzima for that position.
Acknowledged. Thank you. Any other nominees for the post of General Secretary?
I nominate Dr. Kakungulu Edward for position of General Secretary.
Secondments for Dr.
Someone wants to
Kakungulu
bribe
Edward.
us. I want to second.
Sorry, Dr. Chibude, I've just nominated someone, so I can't be nominated for the same post. Oh, I stand down for Dr. Nixon.
Acknowledged. Other nominees for the post of General Secretary? HOSU. Dr. Dungu, you had a nomination. Would you like to nominate your candidate again?
Still, the person I'd nominated was also nominated for president-elect. So now I don't know if we can nominate someone twice before we get the results of the first. Because I thought if we got results for the post before, we'd go to the next one.
Okay.
Maybe we could announce, then if someone hasn't gone through, then they go into another one.
Sure. Thank you. With the guidance of the President incoming, I didn't want to announce these results until the end, but we shall have an official announcement. But tentatively, the President-elect or Vice President winner for this post is Dr. Valeria Nabosa. So any other nominations for the post of General Secretary? We have one nominee so far, Dr. Nixon Nyonzima. Any other nominees? Secondments for Dr. Clara Odiambo.
Okay, seconded.
Thank you. Any other nominees for the post of General Secretary? I kindly ask the nominees to step out so that we proceed with voting.
Due to my own conflict of interest, I am nominating Clara for General Secretary. .
Acknowledged Dr. Nixon Nyonzima. If there are no other nominees, Dr. Clara Odiambo is unopposed for the post of General Secretary of HOSU.
Chair, excuse me, Chair.
Yes, Dr. Lotu.
I can see purple, dark blue, then blue, and as we go down. But number 3 was missed. Was it included for the person who initiated the idea? And if so, I nominate and close the nomination. That's Dr. Jackson Oriam.
Thank you very much, Dr. Lutu. Any objection about the motion by Dr. Lutu, who has nominated Dr. Jackson Orem for the post of past president HOSU? Yes, Dr. Dungu.
So
you.
I think once again, my conflict of interest stands. You can see it is already bringing a bit of, so I stand down. Thank you.
Okay, acknowledged. The post of treasurer. Treasurer, as you know, is a very key post. We welcome nominations for the post of treasurer. Yes, Mr. Henry Wanome. Nomination received of Dr. Edward Kakungulu, although his hand is up. Dr. Kakungulu, can you say something?
He's now fired then.
Thank you for firing me. And now I can nominate in peace. I nominate Dr. Nixon Nyonzima. He's already been our treasurer, so he's very good at holding money.
Secondments for Dr. Nixon Nyonzima.
No campaigning, but I second Dr. Nixon Nyonzima.
Noted. Any other nominees for the post of treasurer?
I nominate Dr. Shona for the post of the treasurer.
Secondments for Dr. Shona. Noted. Thank you. Any other nominees for the post of treasurer?
I nominate Rita Bafumba.
Nomination acknowledged. Secondments for Rita Bafumba. Noted. Any other nominees for the post of treasurer? At the moment, we have 3 nominees, Dr. Nixon Nyonzima, Dr. Shona, and Rita Bafumba. Any other nominees for the post of treasurer? If there's none, we kindly ask the nominees to step out. Nominees, kindly step out. This is very competitive at the moment. I know you're all excited and eager to vote. As you know, Dr. Nixon Nyonzima is a consultant and head research and training at UCI. Dr. Shona is a pharmacist with interest in pediatric oncology at the UCI, and Sister Rita Bafumba is the head of the lymphoma treatment center or the pediatric oncology ward at the UCI. Voting for the first candidate, Dr. Nixon Nyonzima, by show of hands. Voting is open for Dr. Shona by show of hands. Thank you. Voting is open for Bafumba Rita. Members, you're encouraged to vote. Remember, this is your society. So if you abscond, it's not good. Let's invite the candidates in. The results show that Dr. Nixon Nyonzima has scored a total of 35 votes and is leading Dr. Shoana, who is at 7, and Sister Rita Bafumba at 3. So join me to congratulate Dr. Nixon Nyonzima, the new treasurer for HOSU. At this juncture, we shall proceed to the post of Publicity Secretary. Nominations are open. As an observation from the previous round of voting, members who nominate a certain candidate shouldn't be seen voting for another candidate. It creates interpersonal bias. So nominations are open for the post of Publicity Secretary.
I nominate Dr. Vero for Publicity Secretary.
Secondments for Dr. Veronica.
I want to declare a conflict of interest that I cannot be in that position.
Acknowledged. Other nominees?
Thank you. I nominate Dr. Kakungulu Edward.
Seconded.
Acknowledged. Other nominees for Publicity Secretary? If there are no other nominees, Dr. Kakungulu is our new post of Publicity Secretary. Unopposed. At this juncture, would like to get nominations for medical oncology. I've been advised that people who are here have shown exceptional commitment towards HOSU and would like to nominate where possible members for these posts, especially if they're here. It shows exceptional commitment towards HOSU.
Chair, we had amendments for the representatives. It's just that our IT has not allowed us to edit that. So we remind the team of the amended other posts that we amended.
Those include pediatric oncology,
Yes.
laboratory, medical physics, and radiation therapy technologies, and research and palliative care. Those are 15 representatives. The floor is open for medical oncology nominees.
I nominate Dr. Wogere Najib.
Sorry, I'm second.
So, okay, acknowledged. Any other nominees for medical oncology?
I nominate Dr. Semei Sechtene.
Secondments?
I nominate Dr. Najib.
It seems Dr. Sechten has turned down the nomination. Other nominations for medical oncology?
I nominate Dr. Barbara Natkunda for medical oncology.
Dr. Barbara cited conflict of interest.
Thank you so much. I nominate Dr. Anna Kulo, medical, pediatric oncology.
Thank you. There's a special section for pediatric oncology. We are yet to get there. Any other nominees for medical oncology? Would like to hear from medical oncologists here, just to give an expression of support. We've heard from Dr. Sechtene, other medical oncologists here. Dr. Namaganda, any comments, especially from medical oncologists here? Okay, I think without any further delay, Dr. Wogere Najib is nominated unanimously as the representative of medical oncology to HOSU. Second, we received nominations from surgical oncology. This is general surgical oncology. Dr. Edward Kakungulu can nominate the candidate.
I nominate Dr. Lois Asimwe as our representative for surgical oncology.
Secondments for Dr. Asimwe Lois.
I second Dr. Asimwe Lois.
Okay, acknowledged. It's a strong nomination by two surgeons. Any other nominations? Yes, Dr. Dungu.
Dr. Rose Alenyo, plastic surgeon.
Dr. Rose Alenyo, I'm not sure if she's around. Okay, nomination, secondments for Dr. Rose Alenyo. Secondments, acknowledged. Any other nominations for surgical oncology? Representatives, yes, please.
I nominate Dr. Okedi Francis for surgical oncology.
Dr. Okedi Francis is a surgical oncologist now based at Yumbe Hospital. Acknowledge secondments for Dr. Okedi Francis Xavier.
Seconded.
Acknowledged. Any other nominations for surgical oncologist? Representatives of surgical oncology to HOSU. If there's none, we kindly ask Dr. Lois Asimwe, Dr. Rose Alenyo, and Dr. Francis Xavier Okedi to step out briefly. Voting is now open. The first candidate is Dr. Lois Asimwe, surgical oncologist at St. Francis Zambia Hospital. Members, please participate in the voting. It's very important. This is just our society. Voting closed. Voting is now open for Dr. Rose Aleño. She's a plastic surgeon and with interest with oncoplastic breast surgery based at Chirudu Regional Referral Hospital. Thank you. Voting is open for Dr. Okedi Francis Xavier, surgical oncologist based at Yombe, very enthusiastic for the Arua Regional Referral Hospital. Members, please participate. This is our society, it's your society. Your vote counts. Members, you're encouraged to participate in the voting because our vote tally is just about 45 to 50, yet we are more than that in this audience. So the outcome of this voting exercise for the representative of surgical oncology at HOSU, Dr. Lois Asimwe, has emerged the winner with 32 votes, followed by Dr. Francis Xavier Okedi at 5 votes and Dr. Rose Aleño at 4 votes. So the representative of surgical oncology to HOSU is Dr. Lois Asimwe. Please invite the nominees, the candidates in, and join me to congratulate Dr. Lois Asimwe. Congratulations, Dr. Asimwe. Next, we'll receive nominations for the representative for hematology on the Hematology and Oncology Society of Uganda. Okay. Secondments for Dr. Sally, acknowledged.
I have a nomination also.
Yes, please.
So I'm nominating Dr. Deo Munubi. I don't know where he is. So he has stepped out, so he can't accept. There's Dr. Namazi Ruth.
Secondments for Dr. Ruth Namazi, seconded. Any other nominations for hematology?
I nominate Dr. Priscilla Namaganda.
Secondments for Dr. Priscilla Namaganda.
I can't accept. Please accept my no.
Dr. Namaganda has declined. Any other nominations for hematology? Again, I would seek your advice from the audience. Hematology has got both adult and pediatric. The two candidates we have, one is an adult hematologist, Dr. Francis Sally, who presented earlier here, is the deputy director at JCRC and hematologist and physician. And Dr. Ruth Namazi, who also presented here earlier, is a pediatric hematologist, lecturer at Makerere University College of Health Sciences. With your advice, should we have one nominee for both adult and pediatric, or should we have pediatric hematology as well as adult hematology? Okay, again by show of hands, should we have separate nominees for pediatric and adult hematology? Those who say yes, by show of hand. And
Those saying yes, please put your hands up.
I thought of 15. And those who say, thank you. For those who say no, hematology should have one representation for both adult and pediatric. By show of hands. Members, please participate. It's very important. Representation of either adult or pediatric. Okay, from the vote turnout, the majority of us recommend one nominee to represent both pediatric and adult hematology. At this juncture, voting is open for the two candidates, Dr. Francis Sally, who is an adult hematologist and Deputy Director at JCRC, and Dr. Ruth Namazi, who is a pediatric hematologist and senior lecturer at the College of Health Sciences, Makerere University, Lagos Pito. Voting is open for Dr. Francis Sally. Dr. Ruth, if you're in the audience, please step out. And Dr. Sally, we kindly ask you to step out. At this juncture, voting is open for Dr. Francis Sally by show of hands. Members, you're encouraged to participate. This is your society. Thank you. Now, voting is open for Dr. Ruth Namazi for representation. Thank you very much. The candidates can both come in. The results of this voting exercise for the representative of hematology on HOSU show the majority are in favor of Dr. Ruth Namazi with a total vote of 24 against 18 for Dr. Francis Sally. So ladies and gentlemen, join me to congratulate Dr. Ruth Namazi, who is the representative of HOSU for hematology. Next, would like to get nominations for the representative of radiation oncology on HOSU.
I nominate Dr. Solomon Chibude.
Before,
I second, and I can take over his role.
Which one?
Of presiding.
well, it is a bit tricky here. There is a conflict.
I nominate Dr. Lutu.
Second nominee, secondments for Dr. Israel Lutu.
I nominate and second.
Thank you very much. But I nominate Dr. Chibude Solomon.
Thank you. Any other nominations?
Any other nominations, ladies and gentlemen? Going once? Okay, I think Dr. Solomon Chibude has been voted the representative for radiation oncology. I know Paul.
Thank you very much, members. I know we're extremely few, and when Dr. Lutu recommended, the other person is not here, Dr. Kanyike, so the options are limited. Now voting is open for the representative of oncology nursing for HOSU. Representatives for oncology nursing.
I nominate Rita Bafumba.
Secondments for Rita Bafumba. Seconded.
Here. Rita, stand for people to see you.
Other nominations for oncology nursing?
I nominate Nabakoza Susan.
Thank you. Secondments for Susan Nabakoza.
I give my vote to Rita.
Okay. Nomination withdrawn. Any other nominations for oncology nursing? Thank you very much. At this juncture, Rita Bafumba is unopposed as the representative of oncology nursing for HOSU. Next, we'll nominate representatives for pathology.
Yes, I would like to nominate Dr. Lukande Robert for pathology.
Secondments for Dr. Robert Lukande. Okay. Other nominations for yes, Dr. Leta.
I nominate Dr. Okecha Tony.
Secondments for Dr. Tony Okecha. Okay, acknowledged. Other nominations for pathology? If there's none, voting is now open. Dr. Robert Lukande is a senior lecturer, the head pathology at the College of Health Sciences, Makerere University. And Tony Okecha is the head of pathology lab at UCI. Kindly, Dr. Lukande and Dr. Okecha, can you step out for voting?
They are both not here, but at least they were called. Dr. Lukande was called and he's okay with the nomination.
Okay. Thank you. Voting is now open for Dr. Robert Lukande. By show of hands. Members, you're encouraged to participate. This is your society. Thank you. Hands down. Voting is now open for Dr. Tony Okecha. Members, you're encouraged to participate. Representation is extremely important. At this juncture, I would like to declare Dr. Robert Lukande as the representative of pathology at HOSU. He garnered a total of 28 votes against 12 for Tony Okecha. Let's proceed to the next representative for radiology on HOSU. This includes radiologists, radiographers, both diagnostic, although therapeutic falls in a different category. Nominations for radiology?
Yes, I nominate Dr. Chomhanji Agnes.
Secondments for Dr. Chomhanji?
Seconded.
Other nominations for radiology? Nominations for radiology? If there is none, Dr. Chomhanji is unopposed as the representative for radiology at HOSU. Let's proceed to pharmacy. Representatives for pharmacy, oncology, pharmacy.
Deo Chambade as a solo candidate.
Siko John.
Secondments for Dr. Chambade Deo, noted. Secondments for Dr. John Isiko.
I'm nominating Dr. Shona Arao, gender balance.
Conflict of interest.
Secondments for Dr. Shona.
Conflict of interest. I've been nominated, but I'm seconding Deo for this.
Noted, Dr. Isiko. Secondments for Dr. Shona Alaro. Noted. Other nominees for representative of pharmacy at HOSU? Nomination closed. We kindly ask Dr. Chambade and Dr. Alaro to step out so that we proceed with voting. For gender balance, we'll start with, by show of hands, who of you nominate Dr. Shona, vote for Dr. Shona Alaro? Members, you're encouraged to participate in this voting. It's extremely important. Shona. Yes. Okay, thanks. Voting, who of you vote for Dr. Deo Chambade as the representative for pharmacy? The two candidates can come in. Ladies and gentlemen, join me to congratulate Dr. Deo Chambade, who has garnered 32 votes and is the representative for pharmacy at HOSU. Next, nominations are open for oncology, gynecological oncology, or oncology. Nominations are open.
Letter, did you have your hand? Letter? Dr. Letter, did you have?
I nominate Dr. Origa Martin.
Secondments for Dr. Martin Origa.
I'm nominating Piers Malamira.
Secondments for Dr. Mlamida.
Secondments, please.
Secondments? No secondments. Any other nominations?
Yes, I'm nominating Dr. Namuga Jane from Women's Hospital.
Secondments for Dr. Jane Namuga. Noted. Any other nominations?
I'm nominating Dr. Izama Wilfred.
Surprisingly, all the oncologists are not in here.
Noted. Secondments for Dr.
I'm told
Izama.
Dr. Izama was around and someone's coming. But did we call them to confirm?
Noted. Any other nominations for oncology? At this juncture, would like, by show of hands, who of you would nominate, maybe briefly about the candidates. Dr. Martin Origa is a consultant and head of oncology at Uganda Cancer Institute. At the moment, I think he's on leave, possibly was unable to come here. Dr. Jane Namuga is a gynecologist based at Uganda Cancer Institute and the Uganda Women's Specialized Hospital. And Dr. Wilfred Izama is a gynecologist based at Yombe Hospital. He trained at UCI. At the moment, voting is open for Dr. Martin Origa by show of hands. By show of hands, who of you vote Dr. Jane Namuga to represent gynecology at HOSU? Thank you. By show of hands, who of you vote for Dr. Wilfred Izama to represent gynecology at HOSU? Thank you. Ladies and gentlemen, join me to congratulate Dr. Martin Origa, who has been voted as the representative of gynecology at HOSU. Next, nominations are open for pediatric oncology. Nominations are open for pediatric oncology.
Thank you, Chair.
Yes, please.
I nominate Dr. Joyce Balagadde Nakiyingi Kambugu.
Secondments?
No, I want to, there's a very, very big conflict of interest in my nomination. I want to nominate Dr. Anna Kulo.
Secondments for Dr. Anne Akulo. Noted. Other nominations for pediatric oncology.
Thank you, Dr. Lutu, for helping some of us because we have other people to also nominate. And you have helped me say Dr. Joyce has declined. Thank you, Lord. So I can now give it to Dr. Geriga. I nominate Dr. Geriga.
Secondments for
Seconded.
Dr. Fadil Geriga. Noted. Other nominations for the post of pediatric oncology.
I would like to nominate Dr. Kasiria Philip.
Secondments for Dr. Philip Kasidie.
I will request to step down for Dr. Anne Akulo. My name is Geriga Fadil.
Secondments for Dr. Philip Kasidie.
Chair, I also request to step down for Dr. Anne. Thank you.
Any other nominations for the representative of pediatric oncology at HOSU? If there is none, ladies and gentlemen, join me to congratulate Dr. Anne Akulo, a pediatric oncologist. At this juncture, nominations are open for laboratory representative to the HOSU executive.
I nominate Mr. Kadumbula Sylvester.
Secondments for Mr. Kadumbula Sylvester. Noted. Other nominations for laboratory?
I nominate Mr. Henry Wanume.
Secondments for Mr. Henry Wanume. Noted. Other nominations for laboratory? Okay, if there's none, we shall proceed to voting. Mr. Kadumbula and Mr. Wanume kindly step out to allow us vote fairly. Members, you're encouraged to participate in voting. It's extremely important. HOSU is meant to be an umbrella society that will represent the entire fraternity involved in oncology and hematology in Uganda. Mr. Kadumbula is in charge of the UCI laboratory, and Mr. Henry Wanume is in charge of the molecular lab at UCI. Voting is now open for Mr. Sylvester Kadumbula. By show of hands. Members, you're encouraged to participate. It's very important to vote. Thank you.
More votes here. There are more votes here that she didn't count.
Okay, let's vote again. Voting is now open for Mr. Sylvester Kadumbula.
Yes. Vote, you guys. Vote.
Thank you. Thank you. Voting is now open for Mr. Henry Wanume.
Yes, members, we vote. Let's participate, all of us.
Let's participate. Voting is important.
This is our society.
Henry Wanume. Let's invite the two candidates back to the room. Ladies and gentlemen, join me to congratulate Mr. Sylvester Kadumbula, who has emerged the winner with 19 votes against 16 for Mr. Henry Wanume. Congratulations, Mr. Sylvester Kadumbula. It was a very stiff and competitive vote. Next, nomination is open for the representative of medical physicists. Medical physicists are backroom personnel in radiation oncology. They prepare radiotherapy plans, check equipment, output and performance.
I know of only one, Dr. Kauma Aus, and I nominate him for this position.
Secondments for Dr. Kavuma Awusi.
Seconded.
Other nominations for medical physics? Okay, ladies and gentlemen, join me to congratulate Dr. Awusi Kavuma, who is unopposed as representative of HOSU. I believe our head of division will inform him. Next, nominations are open for RTT, or radiation therapy technologists. These are imaging radiographers with a bias to therapy. They are stationed at equipment that are used to treat cancer.
Thank you, Chair. As guided at the beginning of this session, we have, most of them are not around, but there is one person who is around, Mr. Karim Mawerere. So I nominate Karim Mawerere, who has been with us since morning. Thank you.
Secondments for Mr. Karim Mawerere. Noted. Other nominations for RTT representative to HOSU? If there is none, join me to congratulate Mr. Karim Mawerere, who is a newly qualified RTT, requalified RTT from University of Ghana, just returned from training. Congratulations, Mr. Mawerere. Nominations are now open for the representative for research.
I would like to nominate Dr. Francis Sally from the Joint Clinical Research Center.
Secondments for Dr. Francis Sally. Noted. Other nominations for research? If there are no other nominations, join me to congratulate Dr. Francis Sally, who is the representative for research at HOSU. Dr. Francis Sally was here in the morning. He's a hematologist and deputy director at JCRC. Second, lastly, would like to get nominations for civil society organizations.
I nominate Moses Echodu.
Secondments for Moses Echodu. Noted. Any other nominations?
I nominate Miss Irumba Lisa.
Secondments for Miss Lisa Irumba. This is now very competitive. Would like to ask the two candidates to step out. Miss Lisa Irumba
Moses
and
Echodu
Mr.
is
Moses
already out.
Echodu.
Yeah, he's already out.
I think Lisa is also.
I'll be voting for Moses Echodu, and I request to stand down. Yeah, I would like to consider someone will nominate me for palliative care. Thank you.
Mr. Moses Echodu, please keep out. You have been nominated for civil society. You have been nominated for civil society. Please stay out.
Any other nominations for civil society? Thank you. Nominations closed. Ladies and gentlemen, join me to congratulate Mr. Moses Echodu, who is emerged victorious. He's the Executive Secretary of the Uganda Child Cancer Foundation.
Executive Director.
Executive Director of the Uganda Child Cancer Foundation. Nominations are now open for the representative of palliative care at HOSU. We have Lisa Irumba. Secondments for Lisa. Any other nominees for representative of palliative care?
I nominate Dr. Nabukenya Jennifer.
Jennifer Nabukenya. Secondments for Dr. Jennifer Nabukenya. Noted.
I second Dr. Jennifer Sengoba Nabukenya.
Noted. Thank you. Any other nominations for palliative care? Yes, Mr. Henry Waname, you can go ahead. Secondments for Ms. Harriet Kebirungi. Noted. Any other nominations for palliative care? Without further delay, we kindly ask Ms. Lisa Irumba, Dr. Jennifer Nabukenya Sengova to step out, and Ms. Sister Harriet Kebirungi to step out.
This is tight. Members, we vote. All of us, participation is required.
Okay. Ladies and gentlemen, you're encouraged to vote. It's very important to vote. As you know, palliative care is extremely important, and Uganda is known all over the world for palliative care. By show of hands, who of you vote for Lisa Irumba as the representative of palliative care. Okay. By show of hands, who of you vote for Dr. Jennifer Nabukenya Sengova? By show of hands, who of you vote for Harriet Kevironji, a palliative care specialist at UCI? Okay. Thank you very much. This has been the most interested or attractive voting exercise. We had over close to 60 people participating. Join me to congratulate Lisa Irumba, who has emerged the winner. And Lisa Irumba is the representative of palliative care with a total of 41 votes against 10 for Dr. Jennifer Nabukenya and 4 for Sister Harriet Kebironji. Congratulations, Lisa Irumba. Lastly, would like to nominate the very final representatives for trainees at HOSU. As you know, there's a lot of interest in training, and there are many trainees at the moment at Uganda Cancer Institute. There are now over 5 well-established fellowships for specialist training. We've been advised that there's a need for a representative of trainees at HOSU. Nominations are open for the representative of trainees at HOSU.
Natkunda Barbara.
Secondments for Dr. Barbara Natkunda. Noted.
As her mentor, I second her.
Other nominations for trainee representative at HOSU?
Dr. Namaganda Priscilla.
Dr. Namaganda Priscilla has already completed her specialist training.
She's a PhD trainee.
There is conflict of interest there. Any other nominations for trainee? PhD timeline is
Chair,
not
I
clear.
suggest we close the
She may
nomination.
stay there forever.
Chair, I suggest we close the nomination.
Nominations closed. Ladies and gentlemen, join me to congratulate Dr. Barbara Natkunda. Ladies and gentlemen, thank you so much for the participation in this voting exercise. Would like to ask the DJ to give us a brief music interlude as we prepare for the next phase of this exercise. We anticipate the president to give a speech, and we anticipate the executive director who will formally announce the nominees or the successful candidates of this exercise. Any other comments? Yes, Dr. Kakungulu.
Thank you so much, Dr. Solomon. I would like to request if we could have a few advisors or patrons for this executive committee nominated as well, so that they can guide the committee in coming up with a good leadership.
Thank you very much for your advice. Any objection? Yes, Executive Director.
So, thank you. My advice would be that maybe this could be one of the first order of business that the new executive can do, so that, you know, they can get appropriate and also do consultation to get the appropriate people to kind of advise the organization. Yeah, thank you.
Thank you very much, Executive Director, Dr. Jackson Orem. So, Dr. Kakungulu, your submission is acknowledged, but it has been forwarded to the Executive Committee. Yes, please.
Interdisciplinarity and collaborative initiatives under HOSU, I would advocate that, again, on top of that, we could add an ICT or digital technology expert on top of that team, because we work collaboratively. Thank you.
Thank you. Any objections to this suggestion? Communications and ICT personnel, would that be publicity?
Actually, I wanted to say that publicity would do that, but as we've been guided, again, there are provisions for co-opting people on particular committees, because as you realize, it might end up being a huge thing, but they can co-opt based on need.
Thank you very much for the guidance. Any other comments before we close this exercise? Thank you. If there's none, the DJ can give us a brief music interlude as we compile the outcome before we invite the Executive Director to read out this committee, who will be asked to come at the front here. And before them, we anticipate that the President will give a speech. DJ.
Thank you, Dr. Chivude. I must correct. I'm no longer at Mulago National Referral Hospital. I am a freelance senior consultant surgeon on the streets, but I look still strong. Before I congratulate this team that is going to work together this time, I must say this is a job that you must do and do it very well. Many a times in the medical board, we've struggled with decision making. So I expect that this team will work as a strong, formidable team to make decisions for patients' goodness, for patients' good in the treatment and as a multidisciplinary team. Because many times decision making for the good of the patient is a big problem. So I'm happy that this is a vast group and a number of you are concentrated in the Uganda Cancer Institute and in Zambia Hospital. So work as a team for the good of our patients. And you realize that Uganda Cancer Institute was selected as a center of excellence in the East African region. Make it a center of excellence. So without much ado, I'm talking as the chair of the Uganda Medical Board. So that's why I'm saying this strongly, because as chair of the board, I need a lot of your input. Many a times, we as specialists in Uganda don't put ourselves at that level of specialists. I want you to be confident in decision making and stand on your feet because you are specialized enough. But I don't like sometimes the shakiness of the confidence that you have. So this is the time you should practice that confidence and be strong in your decision making. Let no political office push you. You read your science and stand firm on your science. Give the board your opinion. Let the board make the decision, but be truthful in your decision. You may not face the other side, leave the board to face it for you, but give us the truth. So with this, may I announce the successful team that we have selected today. Can I begin from down coming up or up going down? Down coming up, okay. So I will start, not that the lowest one is the lowest cadre in the group. No, you are all good enough. And you will all work as a team. May I start with the representative of the trainees? That is Dr. Barbara Natukonda. Congratulations. Where is Barbara? Has she gone away? Representative for the palliative care, Miss Lisa Irumba. The chairs are not enough for them. I thought they're supposed to be in front so that we see them. Dr. Barbara, where is Barbara Natukonda? Civil Society Organization, Mr. Moses Echodu. Research, Dr. Francis Sally. He was seated there. I think he has gone away. Dr. Francis Sally. Radiation therapy, Mr. Karim Mawerere. Mr. Karim Mawerere. Medical physicist, Ms. Dr. Ausi Kavuma. I've not seen him since morning. I don't think he has come. Okay. Laboratory, Mr. Sylvester Kadumura. Peds Oncology, Dr. Anne Akulo. Gyn Oncology, Dr. Martin Origa. Pharmacy, Dr. Deo Chambade. Radiology, Dr. Agnes Chomubanji. Dr. Agnes. Pathology, Dr. Robert Lukande. Oncology Nursing, Sister Rita Bafumba. Radiation Oncology, Dr. Solomon Chibude. Hematology, Dr. Ruth Namazi. Surgical Oncology, Dr. Louis Asimwe. Medical Oncology, Dr. Bogere Najib. Publicity, Dr. Edward Kakungulu. Treasurer, Dr. Nixon Niyonzima. General Secretary, Dr. Clara Odiambo. Is it Odiambo or Adiambo? Oh, okay. Vice President, Dr. Valeria Nabosa. And finally, the President, none other than Dr. Henry Dungu. So I wish to congratulate you all. My part was to make the final announcement of the team, and I hand over, is it to the returning officer? Or the President to give us his talk. Thank you. You may use the mic next to you. Over to you, Mr. President.
Good afternoon, ladies and gentlemen. You can all hear me? Yeah. Wow. Thank you so much for braving all this to stay up to this time. You know, it gives us the courage that we have a team that is fully supportive. I am not going to make a speech, but accept the responsibility given to me and then the entire team, because we are going to be working together to ensure that we achieve what the promoters have started. I want to say something really quick, that for a long time we were talking about coming together as professionals in the area of hematology and oncology at all levels. And I'm glad that we have picked representatives from almost all areas. And as I said earlier, if your area is not represented, just know it is very, very important, okay? I want to thank you all for the faith and trust in us. We didn't campaign. I think none of us campaigned. but you have given the trust into us, and we have to appreciate you for all this. But without the promoters of the society, I don't think we'd be having the society. We had a small meeting as a small group, and then we went for advice to Dr. Jackson Orem in his capacity as Dr. Orem, not as Executive Director of Uganda Cancer Institute, but as, a senior medical oncologist. He said, "What do you think about this?" And he said, "Oh my God, I support this." And we felt that people will support it. So the promoters, you know yourselves, Dr. Kuku, I don't know if he's still here, Dr. Kakunguru, Dr. Niyonzima, has he left? No, he's around. Dr. Rita Bafumba, Dr. Solomon Chibude, and all those who subscribed for the first time to join the society when Dr. Kakunguru sent out a link. We saw so many people saying, yes, we are joining, and people started paying. We started without any coin. So we kept on going to friends and say, give us this, give us this. And here we are. Now we have a society that has an executive leadership, and on behalf of all members of the committee, I don't know what name we are giving it, I want to assure you that we are going to work hard to make sure that we achieve the proposed objectives. We may modify them as we move on. As we get more ideas, we modify, and then we come up with strategic ways of implementing the society. So with those few words, I want to once again thank you so much for being here since morning. I want to thank you for the trust in us, and I pray that you continue supporting the growth of the society so that it gets to the level of, societies like ASCO, ASH, and many others, okay? I want to encourage you to all be part of this, because we've agreed that much as we have the other societies within here, but we should have this huge umbrella society that is going to bring us together. Yesterday I was talking to some person and said we could have, for example, a society of transfusion medicine people, but how many are we in the country? We are not many. But we can have a huge HOSU that will bring together all of us, and we make sure that we go through HOSU to discover, prevent, and cure diseases related to blood and cancer. Once again, thank you very much. I'll stop here. Thank you. Back to the MC. Dr. Chibude.
Thank you very much, President. This is the end of this particular session 6, the annual general meeting. I would like to invite Dr. Nixon Niyonzima, the MC, so that we can proceed to the final session, which is networking session, actually chaired by Dr. Benjamin Mwesige. Dr. Mwesige, Benjamin. Okay, thank you.
I thank you so much for keeping with us till this late. The camera crew is requesting for a picture of the executive. You are so dispersed. There is no camera with that wide angle. So I think you might have to stand up, and then they take a picture. And then after the picture, we are going to get closing remarks from the executive director. You can imagine he's still with us since morning. And it will be our honor if he's to give us the closing remarks, and then we'll declare this event closed. So let's have the picture, and then the executive director will close the event. Our executive director, I've been waiting for this for a very long time to invite him to, to come and give us a closing remark.
Thank you very much, Edward. I also want to join my voice to the remarks that were made by our senior colleague, Dr. Jane Foalal, in congratulating this new team. I want to state that even though the society is a professional one and we are in it in our respective capacity, from my capacity as the executive director of the Uganda Cancer Institute, I see this as a very big endorsement of the role of the Uganda Cancer Institute in the development of cancer care, and by extension, also hematology. In most countries where you go, including where I trained, you can never divorce hematology and oncology. They go together. So I would want to really congratulate you and urge that let us make sure that these two areas continue to work together because in most cases actually it is very similar. Their challenges are similar, the population affected are also similar, so that means the solution should also be very similar, and including also the people who address the challenges. And that is the whole essence of the society. So on behalf of the Uganda Cancer Institute, we are going to provide all the support you need in whatever form. And I always say, the Uganda Cancer Institute is your platform. It's going to be there for you. Whatever you need, come to the Uganda Cancer Institute. But also in the converse, that means that anything which touches the Uganda Cancer Institute should also touch the society. And that means you need also to support with ideas, with insights, as well as guidance, so that the Uganda Cancer Institute can also accomplish its mandate. As Dr. Fualala stated very clearly, this mandate has now expanded to include the East African region. And by the way, I'll not be very surprised if it will also expand to be an example for the rest of Africa. So you can see for yourself. The challenge is huge, but in you, I really have the team that can drive us to the next level. So I want to thank you, and for that matter, I declare the formal moments of this symposium closed. Thank you.